college, Mysore, in the year 2014. Madam has presented many papers in national and international conferences, and she has guided undergraduate students for SGS project granted by ICMR New Delhi, and Madam has successfully completed it. She is a life member of many professional bodies. Her areas of interest are cytopathology and oncopathology. Now, I request Dr. S.K. Hiramat sir, Professor and HOD Department of Draveguna, to present vocative ma'am. Thank you, sir. Now we are going to start with the first scientific session, and I would like to hand over the session to Dr. Shakuntala ma'am. Ma'am, please.
Very good morning to one and all. At outset, I would like to thank the organizing team over here for inviting me to be part of the state level CME on integrated approach to cancer, that is Onco Veda 2022. I thank Dr. UB Kurat sir and Dr. S.N. Dalwani, who is Professor and HOD PG Department of Higher Chikitsa, and PG Coordinator Dr. Y.A. Paniban, who was in contact, who was in constant touch with me and was updating about the CME. So I thank once again the organizing team and organizing secretary. Now coming to the topic. We'll start the topic. It is diagnostic approach to cancer. So I'll be dealing the topic under these headings. First, we'll know about the definition of cancer, the burden of cancer carcinoma, the global burden as well as in the India. What is the burden of cancer at present? And what are the differences between benign and malignant neoplasms? What is the molecular basis of cancer and the laboratory diagnosis of cancer? So cancer, it is the second leading cause of death, next only to the cardiovascular diseases. The number of cases of cancer are on a very increasing mode these years. So what's even more agonizing than the mortality rate, it is the emotional and the physical suffering which is inflicted by the diagnosis of cancer to the patient as well as the relatives, the family members of the patients. So patients and public often ask, when will there be a cure for this disease, for cancer? So though the question seems to be simple, the answer is very difficult, because cancer, it is not just one disease. It is a group of disorders wherein it shapes profound growth dysregulation. So what is the only hope of controlling cancer? We should start learning more about its causation. Okay, we should start learning more about its causation, the pathogenesis, to understand what is the molecular basis for cancer. So what does the term neoplasia mean? Neo, it is new. So neoplasia, it means new growth. So there are various definitions which are put forward for neoplasia, but the one which is properly accepted is Willis definition of neoplasia. Each word in the definition is very important. So, a neoplasm, it is an abnormal mass of tissue. So, there is abnormal proliferation, irregulated proliferation of cells will be there. So, it is a neoplasm is an abnormal mass of tissue, the growth of which exceeds and it is uncoordinated with that of normal verge. It exceeds and it is uncoordinated with that of normal tissues, and it even persists even after cessation of the stimuli which evoke the change. Even after taking out the inciting stimulus, there is persistence of the growth of carcinoma. It is because of the genetic alterations that are passed down to the progeny of the tumor cells. So, if you take out the inciting stimulus, there is excessive proliferation and uncoordinated growth of tumor cells. So, the reason for that is the genetic alterations. Within the tumor cells, which are passed down to the progeny of the tumor cells. So these genetic changes, what they will do, they will cause excessive, unregulated proliferation. Okay, that becomes autonomous. What do we mean by autonomous? Every proliferation of cell or cell division, it requires the stimulus from growth factors. Okay, but what happens in carcinoma is these cells start multiplying independently without the physiologic growth stimuli. So it becomes unregulated proliferation and excessive proliferation. The growth of tumor cells will be autonomous, though they depend on host for their nutrition and blood supply. Cancer, it is regarded as a group of diseases wherein there is abnormal growth of cells and the ability of those cells to invade into adjacent tissues and adjacent organs, that we call it as metastasis. And eventually there is death of an affected patient if the tumor has progressed beyond that stage when it is inoperable. Okay, so cancer, it can occur any site, it can involve any tissue of the body, it can involve any type of the cells. So what are the major categories of cancer? The major categories are carcinomas, sarcomas and lymphomas. Carcinomas means they involve the epithelial lining, that is stratified squamous epithelium, the lining epithelium of internal surfaces of various organs, that is the cancers in the mouth, esophagus, upper aerodigestive tract, what we call it. So intestines, uterus, all the lining here is stratified squamous epithelium, and the skin epithelium. Skin is the largest organ in our body. So the carcinomas which are arising from all these, the epithelium, stratified squamous epithelium, the lining organs of various organs I just enlisted, here the tumor what we get is carcinomas. So it is from the lining, arise from the epithelial cells. Next, coming to sarcomas, they originate from mesodermal cells, that is the components of various connective tissues like fibrous tissue, fat, bone, blood vessels. Okay, so carcinomas mainly it is epithelial cells originating, sarcomas from the mesodermal cells. Lymphomas and leukemias, they arise from the cells of bone marrow and immune system. So these are the major categories of cancers: carcinomas, sarcomas and lymphomas. What do we mean by primary tumor and secondary tumor? The term primary tumor, it is used to denote cancer in the organ of origin. For example, in the lung, if there is occurrence of squamous cell carcinoma, it is a primary tumor. If it has metastasized to the lymph node in the neck, if a patient comes to you, elderly, like 74-year-old man, presents to you with lateral neck swelling, that is, lateral neck swelling is cervical group of lymph node is involved. There, if we do final aspiration, come little later, and when we do SLAC and when we study that under right microscopy, there will be metastatic squamous cell carcinoma in the lymph node. So here the primary tumor is lung and the secondary tumor is in lymph node. Got it? The primary tumor is in lung, the secondary tumor which has from the primary tumor it has metastasized to the lateral neck node, that is cervical lymph node, that is secondary tumor. So the term primary tumor, it is used to denote cancer in the organ of origin, while whereas it denotes the cancer that has spread to regional lymph nodes and distant organs. One more example is breast carcinoma. Breast carcinoma, it is the primary tumor, and metastasis of breast carcinoma to the axillary lymph nodes. So axillary lymph nodes will form the secondary tumor. When the cancer cells multiply and reach, when the cancer cells multiply and reach, when the cancer cells multiply and reach a critical size, the cancer becomes clinically evident as a lump or as an ulcer which is localized to an organ of origin in earlier stages. So as the disease advances, what are the symptoms and signs of invasion and distant metastasis becomes clinically evident. Now we got to know about the definition of carcinomas. Next, coming to burden of cancer. In 2012, the worldwide burden of cancer, it was 14 million new cases. It is annually 14 million new cases annually, and the death of cancer patients was 8 million. And the most common cancers in 2012 was lung, breast, and colorectal. Now, in comparison with 2020, see there is a rise in the number of cases as well as the number of deaths of cancer patients. So, in 2020, it is 19 million new cases and 10 million deaths. And the global burden, it is expected to be 28 million cases in 2040. That means there is a enormous rise in the number of cases. It is around 47% rise from 2020, and even there is 16 million. So the number of cases of cancers as well as the deaths related to cancers are increasing, and we should be aware of the warning signs. We should not be ignorant. We should not neglect. We should present early to the clinician and get examined. And female breast cancer, it has earlier the most common cancer in 2012 was lung cancer, but nowadays breast cancer has surpassed the lung cancer, and it is followed by lung, colorectal, prostate, and stomach. So breast cancer, it is on rise. Why? Some of the reasons which are put forward is it is because of late marriage, birth of the first child at late age, fewer children, and short periods of breastfeeding, which is the common practice in educated urban women. And even the family history of breast cancer also plays a role. So in women, it is cancer breast, followed by uterine cancer, that is cervical carcinoma, followed by that is colorectum, ovary, lip, and oral cavity. In women, cervical cancer is closely associated with poor genital hygiene, early consummation of marriage, multiple pregnancies, and contact with multiple sex partners. So this is about the global burden of cancer in present status, and how the number of cases are eventually increasing by the year of 2040. So next, coming to comparison between benign and malignant neoplasms. So benign neoplasms, they are very innocent. They are well defined. You can make out all the borders. They are very well differentiated, and they are very slow growing. Usually cohesive, expansile, well demarcated masses, and they will not invade or infiltrate the adjacent tissues. Benign neoplasms, they don't infiltrate, they don't invade the adjacent tissues, and metastasis absolutely is absent. So these are innocent tumors, benign tumors. So just excision of the tumor will cure the disease, and they will have a very normal life like a normal individuals. Whereas when compared to benign tumors, malignant, they are not well differentiated. There is lack of differentiation, that we call it as anaplasia. Okay, and they are the growth of the tumors will be rapid. They are locally invasive and they spread to distant organs. Metastasis is frequently seen. So when this picture, they will very well tell what is the difference between benign and malignant tumor. So leiomyoma, it is a smooth muscle tumor of uterine. Here we can make out all the borders, isn't it? So it's a round, regular, okay, and all borders are located. It is slow growing. Benign tumor is slow growing. It is non-invasive. It has not metastasized to organs and we study under light microscopy, it will be well differentiated. Whereas in comparison with leiomyoma, the malignant counterpart is leiomyosarcoma. It is the tumor arising cells of the myometrium of uterus. So here you can see in comparison with benign tumor, leiomyosarcoma in comparison with this, it is a very large tumor. You can make out the borders, very irregular borders. Okay, it is poorly demarcated and this is slow growing. Whereas malignant tumor, it is rapidly growing. There will be areas of hemorrhage, necrosis with the tumor, within the tumor, and it is locally invasive. It will infiltrate locally also and it will spread to the distant organs. It will metastasize to different organs as well. And when you take the differentiation, it is poorly differentiated. So these are the main differentiating features between benign and malignant tumors. Benign tumors, just enucleation or excision of the tumor will solve the problem and they will have a very good prognosis like a normal individuals. Whereas the malignant tumors, it depends upon various categories like staging and grading of the tumor. Whether what is the tumor size, how many lymph nodes have metastasized, and what is the spread to the distant organs. All these things depends and it will predict the prognosis in cases of malignancy. So this is how benign and malignant tumors are differentiated. Benign tumors have got a very well demarcated borders. You can make out all the borders. They will be very mobile. Very mobile. You can pinch the skin. The surface of the skin can be pinched. They will be very mobile. They are not adhering to the underlying structures and they are slow growing. Whereas malignant tumors, if you just examine, they will be irregular, larger in size when compared to the benign tumors, and they are firm or stony hard in consistency. They are fixed to the underlying adherent or fixed to the underlying structures. The mobility will be compromised in malignant tumors. So this is about benign and malignant tumors. Coming to molecular basis of cancer, the causation of cancer is multifactorial. You have multi-factors in the causation of cancer. That is, environmental factors plays a role, genetic composition plays a role. So in brief, I'll just tell you what is the molecular basis. So these environmental factors are acquired, DNA damaging agents. It can be chemically injured, radiation injury can be there, or viruses. There are oncogenic viruses like human papilloma virus, which causes cervical carcinoma, Epstein-Barr virus, which causes Burkitt lymphoma in young age. So there are so many oncogenic viruses which will result in causation of tumor. So these are the environmental factors. When they cause injury to the normal cell, the body rises. So that's why they tell we have to maintain the immunity. So we have to do our lifestyle modifications and we have to try to maintain our body's immunity. If our immunity is good, what happens? The damage which is caused by these factors, the body tries to regain that, revert back to the normal. Okay. But if that is not possible by the body's genetic composition or body's immunity, what happens? There is failure of the DNA repair. The DNA which is mutated, which is damaged, is not getting repaired here. Okay. So what happens if it is not repaired? Mutations in the somatic cells will occur and there will be activation of growth promoting oncogenes. Tumor suppressor genes are the genes like retinoblastoma, p53. These are the genes which suppress the tumor. Here what happens? Because of the body's mechanism, there is inactivation of tumor suppressor genes, activation of oncogenes, and aggression in genes that will regulate apoptosis. Okay, apoptosis is programmed cell death. Okay, when a cell acquires its senescence, it has to die. But here the cancer cell, it will not die, it will evade apoptosis. So all these factors, they contribute to the irreversible, unregulated proliferation of cells. Okay, so unregulated cell proliferation and this decreased apoptosis will also result in proliferation of cells. Clonal expansion will occur and there is angiogenesis, escape from immunity, and the tumor progresses, forming a malignant neoplasm which later invades and metastasizes to distant organs. So what is the molecular basis of carcinoma is? You have multifactorial origin, that is environmental factors, genetic of an individual, all these together they contribute to the causation of carcinoma. So we have to maintain a healthy lifestyle and build our immunity. So So next coming to diagnosis of tumor. In the diagnosis of tumor, what is very vital and pivotal is the role of clinical examination. Whenever patient visits to you, we have to spend the patient ask in detail when was the lump occurred, since how many months the patient is staying with the lump, how was it initially, is it small, it is rapidly increased to the present size, okay. Then what are the other symptoms? Any alteration of bowel habits is there, hoarseness of voice is there, whether there is difficulty in swallowing, all the symptoms we have. So clinical history, physical examination. Physical examination, when a patient presents lump, we have to examine. That's what I was emphasizing, the difference between benign and malignant tumors. So on examination only we will come to know whether the tumor is benign or we are dealing with a malignant tumor. So this clinical examination, history, physical examination plays a very, very vital role. Next we have pathology, hematological parameters for screening leukemias. Okay, we have bone marrow aspiration and biopsy study there, immunohistochemistry, tumor markers, cytogenetics, molecular diagnostics. All these are recently developed entities in the diagnosis of cancer. So clinical, just I was emphasizing, and we have to spend time acquiring clinical data and history of the patient. And moreover, the laboratory evaluation of lesion can be good if the specimen available to you is of target lesion. Okay, so your diagnosis depends upon the specimen what you have received. So the specimen what we have received should be adequate, should be representative, and should be properly preserved. So your diagnostic depends upon the sample what you have received or sample what you have collected doing fine classification cytology. So what are the sampling methods? There is excision biopsy, needle aspiration, and cytologic smear. That is fine needle aspiration cytology. Selection of an appropriate site for biopsy is also very important. When you come across a very large lesion, like a lesion which is 10 centimeter in size, we should be aware that the periphery may not be representative of the sample, and central can be. So whenever we have malignant tumors, there are areas of necrosis, areas of hemorrhage, areas of cystic change. So when we have sampled those areas, only the cyst material or the hemorrhagic material which you have sampled. So the malignant thing which is there on the periphery is not sampled. So whenever we are dealing with large specimens, we have to be careful. We have to collect multiple samples from the different areas. Now next coming to fine aspiration cytology. This FNAC plays a very important role in triaging patients. Whenever we receive patients with neck nodes, that is cervical lymph nodes or breast lumps or thyroid swelling, this fine aspiration cytology plays a very important role. So we can do FNAC from all palpable lesions, superficial palpable lesions like breast lumps, thyroid gland swelling, lymph nodes. We can as well do from the deeper structures like pancreatic tumors and mediastinal tumors, but it should be under image guidance, that is ultrasound guided or CT guided FNACs we can do in deep seated lesions. Whereas in superficial palpable lesions, we can just do that in our cytology section. So exfoliative cytology is the cells which are shed down from our body, like pap smear, which is the screening method for cervical carcinoma. Vaginal smears, that is for cervical carcinoma, and whenever there is oral cavity leukoplakia, when we are dealing with carcinoma tongue and all, we can take smears from the tongue, and we can take smears from the vaginal smears, okay, and we will stain with pap stain and we will study under light microscope. Even body fluids such as pleural fluid, ascitic fluid, sputum, aspirate from the stomach, CSF, all these will be submitted at cytology section to study the cellular morphology and tell whether it is infective or it is inflammatory or it is neoplastic. So in cytology section, we will be triaging the swellings and we will be telling whether it is infective, inflammatory or neoplastic. If neoplastic, whether it is malignant. So what is the fixative we use in cytology? It is 95% ethanol, wet fixed slides we stain with hematoxylin and eosin, dried smears we stain with Jimca, MG reliability is 97% by FNAC, but there are few false negative cases because of necrosis, hemorrhage or cystic change in a lesion. So what are the advantages of FNAC? It is an outpatient procedure and they give quick diagnosis. If a patient presents to you with a thyroid swelling this morning, within 2 hours they will be getting a report. But the is very quick in fine needle aspiration cytology, and the technique is also very economical to the patients, and we can do follow-up of those patients. If there is recurrence, again we can do FNAC, and this technique doesn't require anesthesia. This technique doesn't require anesthesia, and we can collect sample for microbiological cultures, and this reduces laparotomy and minor surgeries in the case. If it has the swelling is inflammatory or infective, the patient will be treated with antibiotics, drugs alone. The patient need not go for surgery. So we can avoid many surgeries by doing fine needle aspiration cytology. This procedure, we need not give antibiotics to the patient. This procedure is safe. We do FNAC on 5 months baby. 5 months baby also, if they present with lymph nodes in axillary lesion, cervical lesion, we do FNAC for even 5 months baby. This is a very safe technique and it doesn't have complications. What are the disadvantages is, we can't study the architectural pattern. What we study in histopathological sections, those architectural patterns cannot be studied here in FNAC, and if the swelling is too small, if we can't fix with our left hand, then FNAC is not amenable in those cases. And if the scanty cellularity is got in cases of cystic change in a tumor or hemorrhage, that time the gets compromised. So in those cases, then we can go for guided FNAC, ultrasound guided or CT guided FNAC. So detailed study and margins cannot be evaluated in FNAC. So this is, we are doing the thyroid FNAC. Once patient comes to us, we will explain the procedure to the patient, take them under our confidence, we explain them, okay. Then they are made properly treated with neck extended. We use this syringe, which is the syringe holder or FNAC we call. 5 ml syringe is used, which is fitted with 22 gauge needle for lymph nodes, 24 gauge needle for thyroid lesions, because thyroid has got a dual supply and it is very, very vascular. That's why we use 24 gauge needle. And this technique I told you, it is very, very safe for the patients. So here syringe, which is fitted with 24 gauge needle, is introduced into the lump. Okay, introduced into the lump. Then we give negative pressure. Negative pressure, so that it dislodges the cells within the lump, and repeated to and fro motions will be given within the lump. To and fro motions will be given, so that the cells get dislodged and they get collected in the hub of the needle. Okay, then later on negative pressure is withdrawn and the needle is taken out. Again, the syringe is filled with air, so that the in the needle will be blown onto the slide, and the smears will be prepared, and it is put in 95% ethanol. Wet fix we do HND and PAP stains, and dry smears we do MGG. Okay. Here we study the nuclear morphology, mainly the cells, the nuclear cytoplasmic morphology is studied, and we grade them whether it is benign or malignant. So I'll be dealing with cases which have come across last cytophysical section at gyms. A patient, 30-year-old lady, presented to us with lump in the breast. Left breast lump was there. When we examined, it was 3 to 2 centimeter lump, and it was very mobile. All borders we could make out, and it was just soft to foaming consistency. So all these examination findings will point out that it is a benign case. Okay. So then we did FNAC procedure as I've explained. Now FNAC procedure was done, and when the stain smears were received, these were the smears. So benign in the benign breast disease, the ductal epithelial cells are very cohesive. Okay, they will be seen in monolayered sheets, tag-on patterns. These are very cohesive cluster of cells, and in the background we are seeing bare benign naked nuclei. Okay, so here we can make out all the cells are round, regular. This dark staining cells, epithelial cells, and this is fibromyxoid stroma. In the breast we have ducts and the stroma. Stroma forms the supporting network for the ducts. This is The cells you can make out, they are round, regular, fine nuclear chromatin is there, we have myoepithelial cells. In the background, there are bare benign nuclei, naked nuclei, fibrous stroma is there. So based on these features, we signed it out as benign breast disease, fibroadenoma, suggested excision biopsy. So this is the anywhere lumps in the body, it has to be, isn't it? So benign breast disease, fibroadenoma was the standout thing for this lump. 30-year-old female, reproductive age female. So the lump was excised, and this we received in our histopathology section. In histopathology section, what we do, once we receive the specimen, whether it is benign or malignant, we do grossing of the specimen, we take all the size, we mention all the borders, what is the surface, whether it is soft or smooth, or it is bossulated, nodular, cut section. Cut section of this case, you can make out the surface is smooth. On cut section, it is grey-white, and there are slit-like spaces. So all these point out towards the benign nature of a breast lump. So when the slide is prepared and we studied under microscope, what we saw, it was the breast ducts. So the ductal elements have become slit-like. They have been compressed with the stroma. The stroma here have compressed the ducts. Or else normally when you see the breast slides, the ducts will be the lumen we can make out. They are called as tubules. Whereas here in fibroadenoma, the stroma has compressed the ducts and they have become slit-like. It is called intracanalicular pattern and this is pericanalicular pattern. Both the patterns are characteristic of fibroadenoma. So this is again will be signed out as fibroadenoma. So excision of lump, it has solved the problem of a 30-year-old lady who had come with a breast lump. So it is a benign and they will have a very good prognosis like a normal individual. So coming to the case number 2, here we received, now age is no bar for carcinomas. Even a 25-year-old lady presented with breast carcinomas. So this was 32-year-old lady who came with a right breast lump and the lump was 8 into 7 centimeters in size. The lump was very stony hard, it was adherent to the underlying structure. The mobility of the lump was compromised. Okay, so here we are dealing with the malignant nature of the lesion. All this, so that's what I was telling you. The clinical examination forms a very important role. Half of the diagnosis, almost 70% of the diagnosis we can make on a proper examination. Then by doing the procedure, we are confirming the diagnosis. So here in the breast lump, I told it was irregular. It can't take out all the borders. It was encroaching into the adjacent tissues. It was adherent. So when the final classification pathology of that lump was done, we received these smears. In comparison to the previous case, the cells, the ductal cells were very cohesive there. Here you can make out the malignant cells. The tumor cells are discohesive. The cells are discohesive. There is varying sizes. Anisonucleases is there. Here you can make out, see the morphology of nucleus. It is aggressive looking. It's not innocent. So there is high nuclear cytoplasmic ratio. Entire cell is occupied by the nucleus, and chromasia is hypochromatic. Some of the cells can show prominent nucleoli. So see the discohesive nature, that is very important. And the bare benign nuclei, what we saw in the benign case, is missing here. There are no bare benign nuclei in the background. So discohesiveness is a feature of malignant neoplasms. So the cells are discohesive and they are pleomorphic, having INC ratio, hypochromatic nucleus, prominent nucleoli. So here we have signed it out as cytological features are positive for malignancy and it is positive for ductal carcinoma breast. So later on what the do, he will plan for radical surgeries in cases of malignancies. Modified radical mastectomy was done in this case. So this is the gross specimen. Again we study the size and where is the presence of tumor. On cut section, we cut this tissue like a bread loaves. Okay. And this is the, on cut section, this is the tumor. Here we can make out the invading borders here. So here you can make out, the tumor is very irregular. It is invading into the adjacent tissues. Okay. So this is about the ductal carcinoma. This is the gross specimen and this is the cut section. Grey-white, solid tumor which is irregular in size. We are seeing here on the gross specimen. Coming to the microscopy, see this is the tumor. This is moderately differentiated and this is poorly differentiated. Differentiation depends upon the tumor tubules. See here, normally I told in the breast, the ducts, they will have tubules. So in well differentiated, they will try to maintain the preserve, they get preserved like a original breast ducts. So more than 75% here there will be tubules. So this is well differentiated breast carcinoma, but then there is invasion and there are all features of malignancy. As I was just enlisting, all features of malignancy like high NC ratio, irregular nuclear membrane, pleomorphic hypochromatic nucleus, all these features can be seen. Here if you see in the moderately differentiated, the tubular pattern is not much. So it will be between 10 to 75%, and there is a stromal desmoplasia, and there will be mitosis. Atypical mitosis will be seen here. In the insert you can make out the nuclear feature. See here it is poorly differentiated carcinoma. Here there are no tubules. The tumor is thrown into sheets. We call it as solid sheets. Sheets and trabecular pattern will be there, and we can make out the cellular morphology. They are very aggressive looking cells with high NC ratio, hypochromatic nucleus. So again, in breast carcinoma, it depends upon the staging. At what stage the patient presented to you? What is the tumor size? What are the lymph node metastases? So here we received modified radical mastectomy, means whole breast along with the axillary clearance will be received here. So axillary clearance, there you have to study about number of lymph nodes, and you have to tell what how many number of lymph nodes are involved. That again will predict your stage. Okay, and even metastasis. So tumor, node and metastasis decides the patient's prognosis in the future. Apart from this benign and malignant lesions, we can directly diagnose them. There are some gray zone areas in between, like hyperplasia, hyperplastic lesions. When we are in a doubt, that time we advise for core needle biopsy. Core needle biopsy means it is core needle gun will be there, that will be introduced into the lung. Linear tissue fragments of about 2 centimeters will be taken out. Multiple sections from the different areas of the tumor will be taken out, and it will be sent in 10% formalin for histopathological examination. Because we can't just sign it out when there are, because surgery depends upon your report. Okay, so we have to doubly confirm before signing out it as malignancy. But when you have come across gray zone areas, then we can go for core needle biopsies before confirming whether it is malignant lesion. Because the surgery, the malignant lesions will undergo radical surgeries, whereas benign, there will be just lumpectomy to solve the problem. So next, those were the cases. Now we come. Now we will deal with lymph node cases. Here, this was a male patient, 10-year-old. He presented with a lateral neck swelling, that is cervical lymph node swelling was there. He gave history of fever, repeated episodes of sore throat, and when we did FNAC, this was the picture we received. So here we can see, this is HID section, this is the PAP section. Lymphoid cells are seen in varying stages of maturation. We see immunoblast, centroblast are seen, and this is tingible body macrophage. That is macrophage which has engulfed the nuclear debris. This is again a feature of reactive lymphadenitis or a non-specific lymphadenitis. So, lymphoid cells in varying stages of maturation along with tingible body macrophage, we find out it as reactive lymphadenitis. That means it is a non-specific lymphadenitis, and the patient may require only antibiotic therapy or the drug therapy. Next, this is the male person who was 30-year-old. He presented with multiple neck nodes. Here we can see there are multiple neck nodes, and when we did pilot aspiration cytology, what was the thing what we saw? There was central area of necrosis which was surrounded by epithelioid cells and Langerhans type of giant cells. It may or may not be present in the. So when we received a specimen, see these are lymph nodes. They are not discrete. Okay, they are not. These multiple lymph nodes are fused, and we call it as matting of lymph nodes. Okay, so when we examine this patient, we could make that matting. The lymph nodes were not discrete. The surface is fused. So these are fused lymph nodes. It is called as matting of lymph nodes. It is a characteristic feature of tuberculosis or granulomatous lymphadenitis. So we find it out as granulomatous lymphadenitis. Here in this case, we can send a syringe to CBNAT analysis. That is computer-based nucleic acid amplification test to detect Mycobacterium tuberculosis. And we can send the material even for microbial culture as well. So this is matching the diffusion of lymph node, and the lymph nodes are not discrete. So this is the case of granulomatous lymphadenitis. Case number 5. This was a patient, 20-year-old. He also presented with the lateral neck swelling. Cervical group was involved. In this patient, there are multiple group of lymph nodes involved. Cervical group, axillary group, inguinal group, mediastinal group of lymph nodes were involved. So this shows that multiple group of lymph nodes are involved and they are in continuity. Cervical, axillary, mediastinal, inguinal groups are involved. So this is a feature of lymphoma, Hodgkin's lymphoma. So when we study the microscopic slides, here we can make out there is polymorphous population, mainly it is lymphocytes, and the characteristic cell what we see in lymphoma is RS cell, that is Reed-Sternberg cell. We call this as owl-eye appearance of the nucleus. And there is 2 nucleus with the prominent eosinophilic nucleoli. Owl-eye appearance of the nucleus. This is called as Reed-Sternberg cell, which is a characteristic feature of lymphoma, Hodgkin's lymphoma. Hodgkin's lymphoma, it has got bimodal population of presentation. We see this lymphoma in 2nd decade as well as in the 6th decade, and they have got a very good prognosis. The prognosis in this lymphoma. So this is about lymph node cases. Now coming to thyroid. The thyroid cases, most commonly we see females. So if some 10 to 11 females are affected, 1 male will be affected. That is the ratio. Most commonly seen in females. Here we see a teenage girl who has presented with a diffuse thyroid swelling. So this is a diffuse thyroid swelling. We did SNAC, colloid was aspirated. Okay, brownish fluid was aspirated. Some 10 ml fluid was aspirated. Brownish colored fluid, that is. And then when we received specimen, this was a specimen total thyroidectomy. On cut section, it was filled with colloid. So this was the case of nodular colloid goiter with a cystic change. So this is again a benign case. So here we can see this is the lady who presented with thyroid swelling. We can make out here it is swelling. You can make out the nodularity. On the surface there is a nodularity, isn't it? So it is a huge swelling. Surface there is a nodularity. When we did final aspiration cytology, again here we aspirated colloid, and on the colloid, thick and thin colloid with thyroid follicular cells. So what the specimen what we received here on a cut section, it is showing multiple cystic areas. Tan brown is the normal color of thyroid. This is the normal color of thyroid. So there are numerous cysts which is filled with hemorrhagic material. And on histopathological examination, here we can make out there are multiple nodules here. They are separated by fibrous septa, and these nodules are composed of varying size thyroid follicles filled with colloid. So this is the case of multinodular goiter. Again, this is a benign. So here, 30-year-old lady presented with a solitary neck swelling. In comparison with the previous thing, you can make out there was a diffuse neck swelling. Thyroid was diffusely enlarged, whereas here it is a solitary neck swelling. On final aspiration cytology, the cellular material what we received here, it shows the cells which are having INC ratio. The nuclear chromatin is marginally pushed towards the periphery. Here we can make out growing. See, these are intranuclear cytoplasmic inclusions. These are very characteristic features of papillary carcinoma thyroid. So these are intranuclear inclusions. This is about growing, nuclear growing. So the specimen in this case was, this is a normal thyroid. Here we can make out a solid grey white tumor on cut section. So this shows that there is a solid grey white tumor from this area. When we have sampled, we saw on histopathological section, the tumor we saw was in a papillary pattern. Okay, see here we can make out. See, these are true papillae. Papillae means they will have a fibrovascular core and nuclear features are very, very important in papillary carcinoma. So these are, they are called as optically clear nucleus because the chromatin is pushed or it is marginated to the periphery. Often an or optically clear nuclei we call them because the chromatin is pushed to the margin, and this is the true papillae having a fibrovascular core. Make out the nuclear grooves here. We can make out the intranuclear inclusions. So these are all the nuclear features in a papillary carcinoma. So in histopathology section, we see the papillary pattern and the lined cells. The nuclear features are very important. Optically clear nucleus with grooving and inclusions. So this is one more gross case of papillary carcinoma. Here we can see the papillary excrescences. See, this is the thyroid I told you. It is a tan brown in color normally. Here we can make out it is a solid grey white tumor with this friable grey white friable matter, that is the papillary excrescences. And on histopathological examination, it is the tumor is thrown into papillary pattern and it is lined by cells having all the features which I just enlisted. So this is a papillary carcinoma thyroid. Among thyroid malignancies, papillary carcinoma thyroid has got best prognosis. That means 10-year survival is about 80 to 90%. Papillary carcinoma has got the best prognosis. And we come across many soft tissue swellings in the lipoma. It can present at any, the site can be anywhere in the body. Groin, inguinal region, head and neck, shoulder, abdomen. These are soft swellings. Soft swellings, we can make out all the borders here. It is soft in consistency, and when we do final aspiration, we will get greasy material or oily material. Okay. So, and in FNAC, you will see benign adipocytes, loosely cohesive benign adipocytes against the background of lipoidal material. So anywhere in the body there is appearance of lumps, it has to be excised. This lipoma was excised, it was sent for histopathological section. Here we can see on cut section, what is the color of the fat? It is yellowish. So this is the lipoma. We can make up all the borders. See, this again tells it is a benign tumor. The malignant counterpart of lipoma is liposarcoma. Okay, so this is lipoma. You can make out all the borders. On cut section it is yellowish. So on histopathological examination you can see these are adipocytes. Adipocytes are large and the nucleus is pushed to the periphery because of the presence of ample amount of fat. So which has dissolved on histopathological processing. That's why we see clear cells. Okay, so fat dissolved on histopathological processing on formalin. When the tissue is sent in formalin and when histopathological processing is done, fat dissolves. Okay, to demonstrate fat, again we have special stains like Sudan black, frozen section, we get fat. So this is a benign tumor of adipocytes, that is soft tissue swelling. We signed it as lipoma. Excision of that will cure the disease and they don't require further treatment and the prognosis is excellent. They will live like a normal individuals. Next, coming to exfoliative cytology, this is very important in a reproductive age group females. All will be advised to undergo PAP screening. It is to screen cervical carcinoma. Here in cytology, we grade the dysplasias, whether it is high grade intraepithelial lesion or low grade intraepithelial lesion. We grade them, and if the dysplasia is crossed and if there is malignancy, we sign out it out as squamous cell carcinoma. For dysplasias, only cervical biopsy will be the treatment. But if it is squamous cell carcinoma of the cervix, then the patient has to undergo radical surgery, vaginal hysterectomy has to be done. So, proper screening, proper screening is essential in all reproductive age group females. So here, exfoliative cytology, PAP smear. Here we can see these orangeophilic cells are squamous cells. These bluish cells are intermediate cells. Okay, and if it is menopausal age group smear, then we will see predominantly parabasal cells. And background we are seeing here neutrophils. So this is the inflammatory smear because there are no signs of dysplasia in the cells. So this was inflammatory smear and it was negative for intraepithelial lesion by malignancy. That means we are telling it is negative for malignancy and it is an inflammatory smear and it just requires antibiotic therapy. Next is smear. Here it was a 57-year-old lady who came with abnormal vaginal bleeding. And when pap smear was done, here we saw the cells. See, make out here how the cells are angry looking or aggressive looking. High MC ratio, here irregular nuclear membrane, hypochromatic nucleus. These are all features of malignancy here. So aggressive the cells are, having high MC ratio and irregular nuclear membrane. So this is one more cell showing the features of malignancy. So this was a 57-year-old lady who presented with abnormal vaginal bleeding on pap smear study. It was reported as high-grade squamous intraepithelial lesion, and then cervical biopsy was done to that patient. So pap screening is essential in order to screen the squamous cell carcinoma of cervix. So next, coming to hematological investigations, here we have a hematology section which deals with all a study of anemias and leukemias here. So what is the main test we do here is CBC, that is complete blood count or cell counts. Here we study the RBCs for the normal count, morphology, and then WBCs, that is leukocytes, neutrophil, lymphocyte, eosinophil, basophil. All these differential counts will be studied whether the count is normal. The normal WBC count is 4,000 to 11,000 per cubic mm. If the count is more than 11,000, then it falls under leukocytosis. Less than 4,000, it will go for leukopenia. We have various causes for leukocytosis and leukopenia. And we have to study about platelets. Mainly in CBC, we will come to know about RBCs, WBCs, platelets. Platelets, whether the count is normal or decreased or increased. That we will be assessing complete blood count. Next is peripheral smear study. Here, one drop of blood is put on a slide, smear is prepared, and it is stained with Leishman. In peripheral smear study, we study for the presence of anemias or leukemias, and bone marrow aspiration and biopsy. If we are dealing with malignancies or cases of pancytopenia, where there is decrease in all the three cell lines, like if RBCs is decreased, WBCs is decreased, platelets are decreased below the normal range, then we call it as pancytopenia. To evaluate those cases, then we will go for bone marrow aspiration and biopsy. So this is about cell count and peripheral smear study, bone marrow aspiration and biopsy. This is the routine thing what we do in our hematological sections. So this is a peripheral smear of a person who had low hemoglobin. Okay, some 20-year-old lady who presented with hemoglobin 8 grams. MCV is 60 femtoliters. So when peripheral smear, we saw these cells. So this is a normal lymphocyte, and the RBC size will be of that of lymphocyte. When you compare with this lymphocyte, we can make out RBCs are reduced in size. Okay, and the central pallor, what we are seeing, it is more than 1/3. That means it is microcytic hypochromic. Normally RBCs, they are filled with hemoglobin here, you can see, but here central pallor is more. That tells that hemoglobin, which is at the margin of the RBCs, is decreased here. So the cells are microcytic hypochromic. You can see elliptocytes, you can see target cells. Okay, this is the peripheral smear study of a microcytic hypochromic blood picture. There are various causes for microcytic hypochromic blood picture. Most common cause in our setting will be iron deficiency anemia, then thalassemia. Okay, the thalassemia patients will also have microcytic hypochromic blood picture. Sideroblastic anemias, they will have microcytic hypochromic blood picture. Next, coming to macrocytic normochromic blood picture. Here this patient will have dual folic acid and vitamin B12 deficiency. You can make out RBCs, they are in varying shapes and sizes. We call them as anisocytosis, that is variation in size. Poikilocytosis, variation in shape. So anisopyclocytosis is there, and in macrocytic anemia, we will see hypersegmented neutrophils, teardrop cells, and varying size shapes of RBCs. So macrocytic anemia patients, they commonly present with pancytopenia. Pancytopenia is decrease in all the three cell lines, RBC, WBC, platelets, all the three lines are decreased. In order to evaluate that, then we will go for bone marrow study for these patients. So in brief, I'll be telling the bone marrow aspiration, how it is done. So this is the needle we use, gem-shady needle for bone marrow aspiration and biopsy. So this is the procedure. The patient is on the left lateral or right lateral position, and the patient has to be explained about the procedure. And the site of aspiration will be posterior superior iliac spine. PSIS is the site of aspiration. Local anesthesia, what we use here is 2 to 5 ml of 2% lignocaine. As the periosteum of the bone is very, very pain sensitive, we have to nicely infiltrate the periosteum with 2% lignocaine so that the patient can tolerate the pain. So this is the PSIS, and the patient has to lie down in a fetal position. That means the knee joints have to be taken to the chest level in the fetal position so that your PSIS becomes obvious for doing the procedure. Here local anesthesia is used, and gem-shady needle will be introduced, and aspiration material will be taken out. And we can do biopsies also to study myelodysplastic syndromes, myelofibrosis. If we are suspecting those dyscaryopoiesis or ineffective erythropoiesis, we will go for bone marrow biopsies as well. Procedure of bone marrow aspiration and biopsy is done. So megaloblastic anemia, just now I showed you the peripheral blood picture. These patients present with pancytopenia. After doing bone marrow aspiration, these are the smears we receive. Here, these are the large cells having INC ratio, 5 nuclear chromatin. We call it as C-like chromatin. This is the feature of megaloblast. So here we are seeing erythroid hyperplasia of megaloblastic maturation. So it shows there is folic acid and vitamin B12 deficiency in this patient. Next, coming to leukemia. What are leukemias? So when the patient comes to the hematology section, when we do CBC, his total count will be more than 1 lakh. It is usually 4,000 to 11,000 the total count. Here in leukemia it goes to more than 1 lakh per cubic mm. That time we will suspect leukemia. So it is stem cell disorder which is characterized by malignant neoplastic proliferation as well as accumulation of immature cells in the bone marrow. So when you take acute myeloid leukemia, here the stages of hematopoiesis in myeloid series is initially we have myeloblast, promyelocyte, metamyelocyte, then band form and the formation of neutrophil. But here what happens in leukemia, there is arresting differentiation of cells at blast stage. That's why there is increased number of blasts. When we do peripheral smear, we see the slide which is studded with the blast. What are these blasts? They are myeloblasts having INC ratio, and there are 2 to 5 nucleoli. These pale areas are nucleoli with 5 nuclear chromatin. This eye dots, what we are seeing in cytoplasm, it is characteristic of myeloid neoplasms, that is acute myeloid leukemia. When comparison to that ALL, here we can see predominantly mature lymphocytes and the lymphoblast. There we have 5 nuclear chromatin in myeloid series. Here you can see chromatin, it is clumped, and there are 1 to 2 nucleoli. ALL, it is usually seen in children and it has got a very good prognosis. Immunohistochemistry, here in the diagnosis of cancer, it is finding the aspiration cytology and histopathology which plays a vital role in diagnosing whether it is benign and malignant. And these immunohistochemistry, they form supplementary things. So the availability of specific antibodies, it has facilitated the identification of cell products or surface markers. So it is used in the diagnosis and management of malignant neoplasms. So if the tumors are undifferentiated, sometimes the tumors are so much undifferentiated, on histopathological examination, we will be unable to tell whether it is of epithelial origin or it is of smooth muscle origin. When the tumor is very, very poorly differentiated, what we do is we go for cytokeratin or Desmin stain. Cytokeratin means it tells that the tumor is from, see, this is the section where we have done cytokeratin staining. Here it is a membranous staining. Tumor cells, the membrane is stained and it is telling it is positive for cytokeratin. From this we will come to know that this malignancy is epithelial malignancy, not a smooth muscle or skeletal muscle malignancy. So in poorly differentiated tumors, when we are in a dilemma, we go for immunohistochemistry to diagnose the undifferentiated tumors and to categorize leukemia, whether it is B-ALL or T-ALL leukemias, lymphomas, and to detect the site of origin. Sometimes what you have received is metastatic deposit, and we don't know where is the primary tumor coming from. That time, if we are suspecting prostate carcinoma, we will do PSA staining, prostate specific antigen staining in a metastatic deposit. If it turns to be positive, then we can make out the primary is from prostate. So, detection of site of origin in metastatic tumors. Suppose if we have received a metastatic deposit and we are thinking it is of thyroid, then we can go for thyroglobulin staining. Then that will solve the problem, telling that the primary tumor could be thyroid in those cases. So, for diagnosing undifferentiated tumors, for categorization of leukemias, to know the site of primary tumor in cases of metastatic tumors, and to detection of molecules like estrogen receptor, progesterone receptor in breast malignancies, to tell the prognosis in those patients. So this is the cytokeratin positivity, telling that this tumor is of epithelial origin. Next, coming to molecular diagnosis. Molecular diagnosis for diagnosis of malignant tumors, for diagnosis, prognosis, and for detection of minimal residual disease, and to know the hereditary predisposition. So molecular diagnosis, for example, when a brain tumor, that is oligodendroglioma, is taken, presence of 1p19q, it means that there is good treatment response. And suppose in colon cancer, the patient has been treated, radical surgery has been done, he has received chemoradiation. Later on, after 4 years, he will present with recurrence, or the residual tumor is there. That time, if we do KRAS staining, we will come to know the presence of minimal residual disease in those patients. And to detect hereditary predisposition in cases of breast carcinomas. That is, if there is a family history of breast carcinoma and individual from that family comes and asks whether I will also be getting breast carcinoma, that time we can go for these stainings, BRCA1, BRCA2, that will tell the predisposition to breast carcinomas. So what is flow cytometry? Here DNA content and surface antigens are quantitatively measured and individual cell characteristics are found out. So this is the case of leukemia. Here CD, that is cluster of differentiation 22, 19, 10 positivity, it tells that it is a B lineage leukemia. So from the flow cytometry, by studying antigens and DNA content, we can make out whether it is B or T leukemia, because the treatment protocol varies in both of them. Last, coming to tumor markers. What are the tumor markers? So they are biochemical indicators. They tell the presence of tumor. So they can be cell surface antigens, they can be proteins, they can be enzymes and hormones. Okay, they have to be detected in plasma and body fluids. So these tumor markers are not primary modality of diagnosing tumor, but supportive rather than primary modalities for the diagnosis of cancer. What is the main utility of this? It will be helpful in laboratory tests to support the diagnosis, response of therapy, and if there is relapse on when the patient is on follow-up with you, if you want to know the relapse of those cases, then these tumor markers can be used. So they are antigens, or they can be proteins, or enzymes and hormones. So what are the hormones? It is HCG, human chorionic gonadotropin, which is used for trophoblastic tumors. Calcitonin, medullary carcinoma of the thyroid. So they can be hormones, oncofetal antigens, isoenzymes in prostatic cancer, prostatic acid phosphatase, and non-specific enolase in small cell carcinoma of lung, and immunoglobulins, we use them in multiple myeloma diagnosis, and CA125, it is characteristic of ovarian tumor, CA199 in colon cancers. So these are all tumor markers. They help when the is suspected, they support in the diagnosis to know the prognosis mainly. Enzymes, proteins, glycoproteins, okay, then oncofetal antigens, these are all tumor markers. Carcinoembryonic antigen, it is a glycoprotein, it is elevated in colorectal, pancreatic and gastric carcinoma. It is also seen in benign conditions like cirrhosis, hepatitis. So it lacks the sensitivity and specificity. But what does CA help us is to know the tumor burden and if there is a residual tumor in the patient. Alpha fetoprotein, it is widely used for the diagnosis of hepatocellular carcinoma, germ cell tumor of testes, but it is also elevated in cirrhosis and hepatitis. So, but the marked elevation, it is seen in hepatocellular carcinoma and germ cell tumor of testes. So, post-therapy alpha fetoprotein levels are used to know the response to the therapy in those cases of HCC and germ cell tumor of testes. So, prostatic acid phosphatase, it is specific for prostatic carcinoma. False negative rates are also seen, but it is not used for diagnosis, but it is used for monitoring the therapy and to detect the prognosis. So all these tumor markers, they are used for monitoring the disease, to know the relapse, to know the prognosis. So coming to the summary, neoplasia, it is a new growth. Benign neoplasms, they stay localized to the site of origin. They do not invade. Just lumpectomy or lobectomy will cure the disease. Whereas malignant tumors, they metastasize to the distant organs. Cancer is multifactorial in origin. It has both genetic and environmental causation for the cancer. So diagnosis, when it comes to diagnosis of carcinoma, I will just emphasize that clinical examination, it is very, very important, very, very vital. That will help you to diagnose and tell whether it is benign or malignant based on examination. So proper clinical examination of a patient has to be done, proper clinical history has to be taken, and cytology and histopathology, they play a very, very vital role, and they are gold standard in diagnosing the tumors. Whereas immunohistochemistry, molecular methods, flow cytometry, tumor markers, just now I read, all these are newer modalities and they are not primary modalities in diagnosing cancer. They act as supplementary and they contribute in the cancer diagnosis.
Thank you, ma'am. Now the session is open for discussion. If you have any queries, you can ask to ma'am. If you have any queries, please ask.
Good morning, ma'am. Natural killers as a metformin destroy the tumors, ma'am. And how they play a role in what? Up to what extent we can control cancers by increasing natural killers? Natural killers as a metformin destruction of tumors in body, ma'am. By increasing the natural killer cells, ma'am, can we control cancer?
That is on research again. That is again on research. Natural killer cells are protective to our body, and they, whenever there is foreign body influence or any viral organism influence, they play a role and they come to that site in order to protect our body. So it is again on research, but nothing has been developed till now.
And there is another concept known as autophagy. Can we adapt in our day-to-day life to cure cancer?
Autophagy is not adaptive. You are not adapted in the cancer treatment.
Anybody is having any queries? Next we have inauguration session followed by one more scientific session.
ಮೂರು ಜನ ಎಂಟು ಇಲ್ಲಿ ಅಲ್ಲಿ ಜಾಗ ಇದ್ದಲ್ಲ ಅಲ್ಲಿ ಅವ್ರು ಇದು ಐತಿ ಅಲ್ಲಿ ಹೆಂಗೆ ಬರ್ತಾರೆ ಅವ್ರು ಕೊಂಡ್ರಕ್ಕೆ ಇಲ್ಲೇ ಸ್ವಲ್ಪ ಇಲ್ಲ ಇಂದ ಫ್ರಂಟ್ ಲೈನ್ ಮತ್ತೆ ಎಷ್ಟೈತಿ ನೋಡಿ.
Now we have inauguration ceremony of Onco Veda. Now I would like to hand over the session to Dr. Ashwini Munaganagar, Assistant Professor, Department of Shareerik Kriya.
गुरुवे सर्वलोकानां विषजे रोगिणां हृदये सर्वविद्यानां श्री दक्षिणामूर्तये नमः. With the blessings of Sri Jagadguru Sri Abhinava Shivananda Mahaswami Ji, Sri Jagadguru Sri Sadashivananda Mahaswami Ji, Sri Shivananda Brahmata Gadaj. Namaste, distinguished chief guest, president, academic dean, resource person, PG, PhD, delegates from different college, faculty and students of TGM Ayurvedic Medical College and Hospital, postgraduate PhD studies and research center GADAG. In our institute, each department organizes CME. In this year, from the Department of Biology itself, they organizing CME on Onco Veda 2022. Myself, Dr. Ashwini Munaganagar, Assistant Department of REASERCH.
Myself, Dr. Rajni, Assistant Professor in the Department of Ayush. On behalf of Management and Department of PG and PG Studies in Ayush, I welcoming you all for the state level CME and Onco Veda 2022, an integrated approach to cancer.
Now, I request Dr. Paravi to escort our Vice President Dr. E.B. Pura sir on dais. Now, I request Dr. Sobgit sir to escort today's chief guest, Sri Manjunath Abhigiri, Chief Editor, Hindu Karnataka Daily Newspaper, GADAG, on dais. Thank you. Thank you, sir. Now, I request Dr. Rohini to escort Sri B.S. Patil sir, Secretary, JSPD Samsthe, GADAG. Thank you, ma'am. Now, I request Dr. Rudresh sir to escort Dr. G.B. Patil sir, Executive Member, JSPD Samsthe, GADAG. Now, I request Dr. S.T. Gremar sir to escort Dr. Satyanarayan Bhatt sir, Principal, Director, Research and Development, Munia, Institute of Ayurveda Medical Science, Manipal. Thank you, sir. Now, I request Dr. Veena Kori ma'am to escort Dr. Shakuntala Armani ma'am, Associate Professor, GADAG, Institute of Medical Science, GADAG. Thank you, ma'am. Now, I request Dr. Nadab sir to escort Dr. S.N. Balwadi sir, Academic Dean, Professor and HOD, Department of Chiropractic. Thank you, sir. Now I request Dr. Suvarna Nidgundi ma'am to escort Dr. Yasmin Paniban ma'am, PG Coordinator and Professor, Department of Chikitsa.
Cancer is one of the most deadly challenges, spreading drastically in the 21st century. According to WHO reports, cancer caused 9.6 million deaths in 2021. A correct diagnosis of cancer leads to the choice of treatment modalities such as surgery, radiotherapy, and chemotherapy. The primary goal is generally to cure cancer, considerably prolong, improve the quality of life through curative, supportive, or palliative, and also by psychological support. At present scenario, the Ayurvedic system of medicine seems supportive in better treatment in conjunction with the modern medical system. The Ayurvedic principles are based on equilibrium of the dosha and restoring to natural. Thus, there is need for our to find out effective therapeutic and non-therapeutic measures to treat cancer. Looking into all these facts, an effort is made to prepare a platform where different Ayurvedic and from this specialty deliberates their clinical experiences and critical knowledge to young Ayurvedic researchers.
Every positive thought is a silent prayer which will change our life. Prayer purifies our mind and takes away negativity. Now, I would like to call Dr. Suvarnalata ma'am for prayer song to invoke the Almighty and make this event a blessed one.
Música
Thank you, Dr. Swarnalata ma'am, for invoking Lord Ganesha. Sunshine is a well thing. It brings a lot of brightness. A smile is the universal welcome. Now I request Dr. Asmin Paniban ma'am, PG Coordinator, Professor, Department of Ayurvedic, for welcome speech and introducing guests to the gathering.
A very warm and pleasant morning and welcome to one all gathered here for today's CME and integrated approach to cancer Onco Veda 2022. So President of today's event, Dr. U.V. Purat sir, Principal and CMO. Today's resource person, Dr. Satyanarayan Bhatt sir, Principal and Director, Research and Development, Munia Institute of Ayurveda Medical Sciences, Manipal. Dr. Shakuntala Armani, Associate Professor, GADAG Institute of Medical Science, James GADAG. Today's chief guest and inaugurator, Shri Manjunath Basappa Abhigeri, Chief Editor, Kittur Karnataka Daily Newspaper, GADAG. Dr. G.B. Patil sir, Executive Committee Member, JSVB Samsthe, GADAG. Shri B.S. Patil sir, Secretary, JSVB, Dr. S.N. Parvati sir, Professor, HOD, and PHX chairpersons, co-chairpersons across the state, UG, entire organizing team of Onco Veda 2022. It's an immense pleasure to welcome you all to this one-day state level CME, an integrated approach to cancer Ayurveda, Onco Veda 2022, organized by PhD and PG Studies, Department of Dietetics, DGM AMC, GADAG. On this beautiful occasion, I take this privilege to welcome the dignitaries on the dais. First, President of today's CME, Dr. U.B. Purat sir, Principal and CMO, DGM AMC, GADAG, who always encourage and guide us to conduct such academic and student-centric activities. I welcome Dr. U.B. Purat sir on behalf of our department. I call Dr. Sabgi sir to welcome sir by offering a bouquet. Thank you, sir. Now I welcome Dr. Satyanarayan Bhatt, the resource person of today's CME Onco Veda 2022. I take this moment to introduce Dr. Satyanarayan Bhatt, sir. Sir is presently rendering his valuable services as Principal and Director, Research and Development, Munia Institute of Ayurveda Medical Science, Manipal. Completed BMS graduation at STM College of Ayurveda, Udupi. Post-graduation in Vaishali Kalpana from IPGT and RA Gujarat Ayurveda University, Jamnagar. Work experience, lecturer in the subject Rasashastra and Vaishali Kalpana for both UG and PG students since last 18 years. Working as an R&D executive and MR for ISO in an Ayurvedic pharmacy and actively involved in design and development of Ayurvedic formulations, quality control of Ayurvedic medicines, research on single herbs and herbomineral preparations, clinical research in Munia Ayurveda hospitals and TOTs and various seminars, CMEs, etc. Sir has presented papers like Ayurvedic manuals on wellness and purification and management, reference to epigenetics in international webinar on Global Cancer Summit 2020 and conferred with Edward Kennedy Memorial Award the best presenter from the senior research category. With this brief introduction, I call Dr. Jairaj Basri sir to welcome Dr. Satyanarayan Bhatt sir by offering a bouquet. Thank you, sir. Our today's another eminent resource person, Dr. Shakuntala Armani madam, who I have already introduced, and madam has already given a talk on diagnostic approach to cancer. I also welcome Dr. Shakuntala madam on this dais. I call Dr. Suvarna madam to welcome Dr. Shakuntala Armani madam by offering a bouquet. Thank you, madam. Now it's my pleasure to introduce and welcome Shri Manjunath Basappa Abhigeri, Chief Editor, Kittur Karnataka Daily Newspaper, GADAG, who is the chief guest and inaugurator of today's CME. Shri Manjunath Basava Abhigiri is a well-known personality in the field of media, agriculture and corporate sectors. At present, sir is providing valuable services to many organizations and he has dedicated himself to political, educational and business matters. Kittur Karnataka, a daily newspaper which comes in 4 colors, is the main and primary contribution of Shri Manjunath Abhigiri sir. Sir is a great believer in Ayurveda. With this brief introduction, I call Dr. Kasim to welcome Dr. Basava sir to this desk. Thank you. Now I would like to welcome Shri B.S. Patil sir, Secretary JSVV Samsthe GADAG. I call Dr. Jairaj sir to welcome sir by offering a flower. Thank you, sir. It's my great pleasure to welcome Dr. G.B. Patil, sir, Executive Committee Member, JSVV Samsthe GADAG. I call Dr. Kumar Chodoplav, sir, to welcome by offering a bouquet. Thank you. Now I welcome Dr. S.M. Bedwani, sir, Professor HOD, PG and PhD Studies in Kayachikitsa and Academic to this event. I call Dr. Ashwini Madam to welcome sir by offering a bouquet. I take this privilege to welcome another eminent resource person of the CME, Dr. Prashant A. Sir, Principal Professor and HOD Ayurveda Mahavidyalaya Hubli, Dean ISM RGHS Bengaluru, who will be joining us in the afternoon. I take this time to welcome all the delegates across the state of Karnataka, UG students, PG and PhD scholars, chair and co-chairpersons of the scientific session and the organizing team of Onco Veda 2022. With this welcome note, I conclude. Thank you.
Thank you, ma'am. Now I request Dr. Ashwini Beni ma'am to welcome Dr. Yasmin Paniban ma'am. Thank you, ma'am. Now I request Dr. S.N. Belvedi, sir, Academic Dean, Professor and HOD, Department of Practical, sir, for keynote address.
I request Dr. M.E. Sugin sir to honor the bouquet with our respected Dr. G.S. Irmat sir, former principals of DGM Medical College, GADAG. Please sir, I request Dr. G.S. Irmat sir, please come on the dais. Thank you sir. I request Sri Chennai Agreement sir to come on the dais, and I request Dr. Jairaj Basarigada sir to honor with the bouquet and welcome respected Chennai Agreements. वागर्त इव संप्रोक्तो वागर्त प्रतिपत्ति जगतः पितरो वंदे पार्वती परमेश्वरो. वार्म गुड मॉर्निंग टू ऑल. ನಮ್ಮ ಜಗದ್ಗುರು ಶ್ರೀ ಶಿವಾನಂದ ಮಠದ ಜಗದತ್ರಯ ಪೂಜ್ಯರನ್ನ ಮನದಲ್ಲಿ ನೆನೆದು ಭಕ್ತಿಪೂರ್ವಕವಾಗಿ ನಮಸ್ಕರಿಸಿ, ಜಗದ್ಗುರು ಶ್ರೀ ಅಭಿನವ ಶಿವಾನಂದ ಮಹಾಸ್ವಾಮಿಗಳವರ ಪಾದ ಪದ್ಮಗಳಿಗೆ ಭಕ್ತಿಪೂರ್ವಕವಾಗಿ, ಜಗದ್ಗುರು ಶ್ರೀ ಸದಾಶಿವಾನಂದ ಮಹಾಸ್ವಾಮಿಗಳವರ ಚರಣಕಮಲಗಳಿಗೆ ಭಕ್ತಿಪೂರ್ವಕವಾಗಿ ನಮಸ್ಕರಿಸಿ ಆಶೀರ್ವಾದವನ್ನು ಪಡೆಯುತ್ತಾ, ಈ ಸಂದರ್ಭದಲ್ಲಿ ನಮ್ಮ ಸಂಸ್ಥೆಯ ಸಂಸ್ಥಾಪಕರಾದ ದಾನಪ್ಪ ಗುರುಸಿದ್ದಪ್ಪ ಮೇಲ್ಮಾಣಿಗೆ, ತಾಯಿ ಗಿರ್ಜಮ್ಮ ದಾನಪ್ಪ ಮೇಲ್ಮಾಣಿಗೆ ಅವರನ್ನ ಮನದಲ್ಲಿ ಸ್ಮರಿಸಿ ನಮಸ್ಕರಿಸಿ, Onco Veda 2022 State Level CV, the President of today's function, Dr. U. Purasar, Principal and CMO DGM Medical College, Chief Guest of this program, respected Sri Manjunath Abhigiri sir, Chief Editor, Kittur Karnataka Daily Newspaper GADAG, respected Sri V.S. Patil sir, Jagadguru Shivananda Vidyavardhaka Samsthe. One more guest, respected Patil sir, former principal of DJM Medical College and also executive member of Jagadguru Shivananda Vidyavardhaka Samsthe Veda. Dr. Yasmin Madam, PG Coordinator, respected all the dignitaries and resource person of Onco Veda 22, Dr. Shakuntala Ramani Madam, Associate Professor Jims, Dr. Satyanarayana Bhatt sir, Principal and Director, Union Institute of Ayurveda Science, Manipal, Dr. Prashant yes sir, Principal, Ayurveda Mahavidyalaya Hubballi, as well as Dean, Indian System of Medicine, Rajiv Gandhi University of Health Sciences, Bangalore. So all teaching faculties, other guests who come over here, PG scholars and dear students delegates, dear PhD scholars of different colleges who came for the paper presentations in this great event CME. I wholeheartedly welcome you all for the CME and integrated approach to cancer Onco Veda 2022. The Department of PG and PhD, the staff member organizing this state level CME and decided to select an area that is cancer, one of the burning issues in the present era. So under the guidance of our respected principal, Dr. U. sir, the department has taken lead and made the list of resource person who worked in this area and invited to share their practical experience to our young budding doctor. So our today's resource person, Dr. Shakuntala Ramani Madam, has already deliberated her topic, and Dr. Satyanarayana Bhatt sir in the next session is going to initiate. This CME is divided into two sessions. The first scientific session, Dr. Shakuntala Ramani Madam will deliberate the topic on diagnostic approach to cancer. And soon after the completion of this madam, now we are at the stage of inaugural function. Sri Manjunath Abhigiri sir, Chief Editor, will going to inaugurate the function with the other dignitaries of the dais. So after the inauguration function, one more eminent personality, Dr. Satyanarayana Bhatt sir, will going to deliver on the topic applications of multidimensional Ayurvedic treatment in the management of cancer, with special reference to Rasaushadis clinical. And later, totally we received 20 papers on different subjects of cancer, and we divided into two sessions. So after Satyanarayana Bhatt's presentation, there will be one paper presentations in which the PG and PhD scholars will presenting paper presentation. So later there will be a lunch break, and in the afternoon session, a second session will be initiating by the presentations of Dr. S. Prashant sir. The topic is on principles and management of cancer in Ayurveda. So once again, after this presentation, the second oral paper presentations will be initiated, and for this different parts of Karnataka, PG and PhD scholars, they will deliver their papers. So later there will be a panel discussion followed by valedictory, and in the valedictory function there will be announcement of the best paper by the PhD and PG scholars. The CME will be ending with the national anthem. So at this moment, I convey my gratitude to all my departmental staff, all HODs and different committee heads of DJM Medical College, and also the principals of different colleges of Karnataka who sent their PG scholars, PhD scholars, as well as escorting teachers to involve in this great event CME. And so with this, I end up my words. Thank you very much.
Thank you, sir, for throwing the light on Onco Veda 2022. Shubham karoti kalyanam arogyam dana sampadam shatru buddhi vinashaya deepam jyotir namostute. Light is a symbol of brightness and prosperity. Sunlight expels the darkness and brings happiness in our life. Now I request all the dignitaries on the dais to inaugurate this event by lighting the lamp.
सुराचितलिङ्गं निर्मलभासितशोभितलिङ्गं सहस्रलिङ्गं तत्प्रणमामि सदा शिवलिङ्गम्
Thank you all. Thank you all. Now I request today's chief guest, Sri Manjunath Abhigiri sir, Chief Editor, Kittur Karnataka Daily Newspaper GADAG, for the inaugural speech.
ಜಗದ್ಗುರು ಶಿವಾನಂದ ಆಯುರ್ವೇದಿಕ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನ ಈ ಕಾರ್ಯಕ್ರಮದ ಅಧ್ಯಕ್ಷ ವಹಿಸಿದಂಥ ಈ ಕಾರ್ಯಕ್ರಮದ ಕ್ಯಾನ್ಸರು ಮತ್ತು ಈ ಆಯುರ್ವೇದಿಕ ಮತ್ತು ಅಲೋಪತಿ ಕ್ಯಾನ್ಸರ್ ಬಗ್ಗೆ ಒಂದು ವಿಚಾರಗೋಷ್ಠಿಯನ್ನು ಈ ಕಾರ್ಯಕ್ರಮದ ಅಧ್ಯಕ್ಷ ವಹಿಸಿದಂಥ ಡಾಕ್ಟರ್ ಪುರಸ್ಸರೇ ಪುರವರೇ ಹಾಗೂ ಜಿ ಬಿ ಪಾಟೀಲ್ರೇ ಹಾಗೂ ಬೆಳವಡಿ ಸರ್ರೇ, ಡಾಕ್ಟರ್ ಪರಿಬಂದ್ ಅವರೇ ಹಾಗೂ ಮಣಪಾಲ ಬಂದಂಥ ಡಾಕ್ಟರ್ ಮಣಪಾಲ ಆಯುರ್ವೇದ ಹಾಸ್ಪಿಟಲ್ನ ಡಾಕ್ಟರು ಹಾಗೂ ಜೇಮ್ಸ್ನ ಮೇಡಮ್ ಅವರು ಹಾಗೂ ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಆಗಮಿಸಿದಂಥ ಎಲ್ಲ ಸ್ಟೂಡೆಂಟ್ ಮೆಡಿಕಲ್ ಆಯುರ್ವೇದ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನ ಎಲ್ಲ ವಿದ್ಯಾರ್ಥಿಗಳು, ಪ್ರೊಫೆಸರು ಎಲ್ಲರಿಗೂ ನಾವು ವಂದಿಸಿ ಇವತ್ತಿನ ಈ ಕಾರ್ಯಕ್ರಮ ಒಂದು ಒಳ್ಳೆಯ ಕಾರ್ಯಕ್ರಮ. ಈ ಕ್ಯಾನ್ಸರ್ ನೋಡಿ ಏನಪ್ಪ ಅಂದ್ರೆ ಇದು ಎಲ್ಲಿಂದ ಹುಟ್ಟುತ್ತಾ ಅನ್ನುವಂಥ ಒಂದು ಸಸ್ಯ ಮತ್ತು ಕ್ಯಾನ್ಸರ್ ಹೆಂಗೆ ಬರುತ್ತೆ. ನಾನು ಒಂದು ಟೈಮ್ನಾಗ ಈ ಕ್ಯಾನ್ಸರ್ ಹಾಸ್ಪಿಟಲ್ ಡಾಕ್ಟರ್ ಆರ್ವಿ ಪಾಟೀಲ್ ನಾನು ಸಣ್ಣ ವಯಸ್ಸು ಒಂದು ನಮ್ಮ ಬ್ರದರ್ ಕ್ಯಾನ್ಸರ್ ಆಗಿದೆ. 1970 ನಮ್ಮ ನೋಟನ ಕ್ಯಾನ್ಸರ್ ಆಗಿದೆ. ಕ್ಯಾನ್ಸರ್ ಆದಾಗ ಪಾಟೀಲ್ ಕಡೆ ನಾವು ಹೋದಾಗ ಕ್ಯಾನ್ಸರ್ ಹೆಂಗೆ ಬಂತು ಅದ್ರ ಬಗ್ಗೆ ಅವರು ಒಂದು 70 ಇಸ್ವಿ ಅಂದ್ರೆ ಇವತ್ತು 52 ವರ್ಷದಿಂದ ಅವ್ರು ಕ್ಯಾನ್ಸರ್ ಅನ್ನೋದು ಗೊತ್ತಿರುವಾಗ ಅವ್ರು ಮಾಡೋಲ್ಲ. ಇವತ್ತು ಸಾಕಷ್ಟು ಮೆಡಿಸಿನ್ ಅಲೋಪತಿ ರೋಗ ಬಂದಿದೆ. ಈ ಫಂಗಸ್ನಿಂದ ಕ್ಯಾನ್ಸರ್ ಬರ್ತದೆ ಆಲ್ರೆಡಿ ಹೇಳಿದ ನನಗೆ ಇವತ್ತು ಡಾಕ್ಟರ್ ಏನು ಕ್ಯಾನ್ಸರ್ ಹಾಸ್ಪಿಟಲ್ ಹೆಡ್ ಇದ್ರು ಏನು ಹಾಸ್ಪಿಟಲ್ ಅವರು ಈ ಫಂಗಸ್ ಈ ರೊಟ್ಟಿ ಜೋಳ ರೊಟ್ಟಿ ನಾವು ಇರ್ತೀವಿ ತಿಂಗಳಲ್ಲಿ ಇರ್ತೀವಿ ಅದು ತಿನ್ನಬಾರ್ದು ಅಂತ, ಅಥವಾ ಲಿಂಬೆಹಣ್ಣು ಊಟದವ ಲಿಂಬೆಹಣ್ಣು ಉಪಯೋಗ ಮಾಡಿ ಫಂಗಸ್ ಫಂಗಸ್ ಬರೀ ರೊಟ್ಟಿಯಿಂದ ಬರೋಲ್ಲ. ಈ 6 ಗಂಟೆಗಳ ಮನೆಯಾಗಿ ಇಟ್ಕೊಳ್ತೀವಿ, ಡಬ್ಬೆ ಒಳಗೆ ಇಟ್ಟಿರ್ತೀವಿ, ಹಸಿ ಡಬ್ಬೆ ಒಳಗೆ ಇಡ್ತೀವಿ, ಫಂಗಸ್ ಆಗುತ್ತೆ ಅಂತ. ಫಂಗಸ್ ಆಗದಂಗೆ ನೋಡ್ಕೊಳೋದು ಫಸ್ಟ್ ನಾವು ಹುಟ್ಲಿಂದ ಬರೋದಿಲ್ಲ. ಕ್ಯಾನ್ಸರ್ ರೋಗ ಇರಲಿ ಯಾವುದೋ ರೋಗ ಬರಲಿ ಈ 6ರಿಂದ ಈ ರೋಗಗಳು ಬರ್ತಾವೆ. ಇದನ್ನು ಆದಷ್ಟು ನಾವೆಲ್ಲ ಇದರ ಬಗ್ಗೆ ಸ್ವಲ್ಪ ಜಾಗ್ರತೆ ಮೂಡಿಸ್ಬೇಕು. ಕ್ಯಾನ್ಸರ್ ಬಂದಿಂದ ತೋರಿಸ್ಬೇಕಂದ್ರೆ ಕ್ಯಾನ್ಸರ್ ಬರೋಕ್ಕಿಂತ ಮೊದಲ ಏನು ಫುಡ್ ಹೆಂಗೆ ಯೂಸ್ ಮಾಡಬೇಕು, ನಾವು ಏನು ಮಾಡಬೇಕು ಅನ್ನೋದು. ನಿಂಬೆಹಣ್ಣು ಕಂಪಲ್ಸರಿ ಇರ್ತಾರೆ. ಯಾರು ಆರ್ಮಿ ಪಡೆದು ಹೇಳಿದ್ದು ಸಣ್ಣ ಪೀಸ್ ಭಾಳಲ್ಲ, ಸಣ್ಣ ಪೀಸ್ ಊಟದಾಗ ಲಾಸ್ಟಿಗೆ ನಿಂಬೆಹಣ್ಣು ತಿಂದ್ರಿ ಫಂಗಸ್ ಹೋಗುತ್ತಾ ಕ್ಯಾನ್ಸರ್ ಬರೋಲ್ಲ ಅಂತ ನನಗೆ ಹೇಳಿದ್ದು. ಮತ್ತು ಇವತ್ತು ಅಲೋಪತಿ ಮತ್ತು ಏನು ಆಯುರ್ವೇದಿಕ್ ನಮ್ಮ ದೇಶದ ಒಂದು ಪುರಾಣಿ ಮೆಡಿಸಿನ್ ಆಯುರ್ವೇದಿಕ್. ಇವತ್ತು ಹಳ್ಳಿಗಳು ನಾವು ನೋಡ್ತೀವಿ, ಸಾಕಷ್ಟು ಆಯುರ್ವೇದಿಕ್ ಪಂಡಿತರು ನಾವು ನೋಡ್ತೀವಿ. ಈ ಸಾಮಾನ್ಯವಾಗಿ ಈಗ ನಾವೆಲ್ಲ ಈಗ ಒಂದು 50 ವರ್ಷ ಅಲೋಪತಿ ಆಯಿತು, ಇವೆಲ್ಲ ಈಗ ಜೋರೈತಿ. ಮೊದಲು ಹಳ್ಳಿಗಳು ಡಾಕ್ಟರ್ ಇಲ್ಲೇ ಭದ್ರಾಪುರದಾಗ ಕಾಲು ಕೈ ಮುರಿದು ನಾವು ಕಣ್ಣಿ ನೋಡಿ ಒಂದು ಆಕ್ಸಿಡೆಂಟ್ ಕೇಸು ಪೂರ್ತಿ ಪುಡಿ ಆಗಿತ್ತು. ಅಂಥ ಕೇಸ್ ತೊಗೊಂಡು ಹೋದ್ರು ಭದ್ರಾಪುರ ಉದಾರ ಅದನ್ನು ಗಾಯ ಮಾಡಿಸಿ ಅದನ್ನೇನು ಎಲಬು ಪೌಡ್ರ್ ಆಗಿ ತೆಗೆದು ಎಲ್ಲ ಅದನ್ನು ಕೂಡಿಸಿ ಇವತ್ತಿಗೂ ಅವ್ರು ಅಡ್ಡಾಡ್ತಾರೆ. ಆಮೇಲೆ ಎಷ್ಟೋ ಜನ ಇವತ್ತಿಗೆ ಕೊಡ್ಬಾರ ಇರ್ತಾರೆ. ಈಗ ಡಾಕ್ಟರ್ ಏನು ನಮ್ಮ ಈಗ ಭದ್ರಾಪುರ ಹಾಕ್ತಿದ್ರು ಹಂಗೆ ಈ ಜಾಂಡೀಸ್ಗೆ ಇಂಗಳು ಮೇಣ ಕೊಡ್ಬೋದು. ನಮ್ಮ ಹಿರಿಯರು ನಮ್ಮ ಮನೆ ಒಳಗೆ ಇಂಗಳು ಮೇಣ ಕೊಡೋದು ಅದು ಜಾಂಡೀಸ್ ಹೋಗ್ಬೋದು. ಆಮೇಲೆ ಬಿಳೆ ಕಾಮರಿಗೆ ಒಂದು ಇನ್ನೊಂದು ಇದು ಕೊಡ್ತೀವಿ, ಯಾವುದು ಅದಕ್ಕೆ ನೆಲ್ಲಲ್ಲಿ ಅಂತ ಅರ್ಧ ಕೊಡ್ತೀವಿ. ದನಕರುಗಳು ಈಗ ಉಚ್ಚ ಕಟ್ಟಾದ ದನಕ್ಕೆ ನಮ್ಮಲ್ಲೇ ನೆಗಡಿ ಮುಳ್ಳು ತೊಳೆದು ಗುಡ್ಡಿ ಗುಂಡಿ ದನಕ್ಕೆ ಡಬ್ಬನ ಹೇಗೆ ಬಿಡಿಸ್ತದೆ ಅವು ಅದು ಕ್ಲಿಯರ್ ಆಗಿ ಉಚ್ಚ ಕ್ಲಿಯರ್ ಆಗ್ತಿರ್ತವೆ. ಹಿಂಗೆ ಅನೇಕ ಆಯುರ್ವೇದಿಕದೊಳಗೆ ಸಾಕಷ್ಟು ಮೆಡಿಸಿನ್ ನಮ್ಮಲ್ಲೇ ನಾವು ನೋಡ್ತೀವಿ ಹಳ್ಳಿ ಒಳಗೆ. ಯಾಕಂದ್ರೆ ನಮ್ಮ ಹೊಲ ಇತ್ತು, ಮೆಣಸು ಪೌಡ್ರ್ ಮಾಡಿ ಪಟ್ಟಿ ಹಿಡಿದಾಗ ದನಕ್ಕೆ ಆಕಳಕ್ಕೆ ಆ ಮೆಣಸಿಂದ ನೀರು ಹಾಕಿದಾಗ ಪಟ್ಟಿ ಅದು ಕ್ಲೀನ್ ಆಗೋದು. ಹಿಂಗೆ ಅನೇಕ ಆಯುರ್ವೇದಿಕ್ ಔಷಧಿಗಳು ನಮ್ಮಲ್ಲೇ. ಈಗ ನನಗೆ ನಾಯಿ ಕಳೆದಿತ್ತು ನನಗೆ 13ನೇ ವಯಸ್ಸಿನಾಗ, ನನಗೆ 55 ವರ್ಷದ ನಾಯಿ ಕಳೆದಾಗ ಹೊಂಬಳದಾಗ ನಮ್ಮ ಹಿರೇಮಠದ ನಮ್ಮ ಆಯುರ್ವೇದ ಡಾಕ್ಟರ್ ಅವ್ರು ಊರಾಗ ಹೋಗಿ ಉಸಿರಾಗಿ ಅಂತ ದಾರ ಕಡಿಸ್ಕೊಂಡು ಆರಾಮಾಗ. ಈ ಉಸಿರಾಗ ಒಂದು 30 ಇಂಜೆಕ್ಷನ್ ಹಾಕವಿ. ಅವಾಗ ನಾವೆಲ್ಲ ಹಿಂಗೆ ಮಾಡ್ಕೊಂಡಿದ್ವಿ. ಈಗ ಆಯುರ್ವೇದಿಕ್ ಏನಿದಪ್ಪ ನಮ್ಮ ಹಳ್ಳಿ ಒಳಗೆ ಸಾಮಾನ್ಯವಾಗಿ ಚೆನ್ನೈ ಹಿರೇಮಠ ಕುಂತಾರ, ಅವ್ರ ತಂದೆಯವರು ಡಾಕ್ಟರ್ ಹಳ್ಳ್ಯಾಗ. ಆವಾಗಿನ ಕಾಲ ಏನು ಹಳ್ಳಿ ಒಳಗೆ ಏನು ಡಾಕ್ಟರ್ ಇರ್ತಿದ್ರು, ಅವಾಗ ಆ ಡಾಕ್ಟ್ರ ಎಲ್ಲ ಔಷಧ ಕೊಡ್ತಿದ್ರು, ಅದರ ಗಿಡಮೂಲಿಕೆನ ಅವ್ರು ಕೊಡ್ತಿದ್ರು. ಈ ಚೆನ್ನೈಯವರಿಗೆ ಸಾಕಷ್ಟು ಅದ್ರ ಬಗ್ಗೆ ಮಾಹಿತಿ. ಹಂಗೆ ನಮ್ಮ ಆಯುರ್ವೇದಿಕ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನವರು ಅನೇಕ ಹಳ್ಳಿ ಒಳಗೆ ಪಂಡಿತರು ಅದಾರ, ಆಯುರ್ವೇದಿಕ್ ಪಂಡಿತರು. ಅವ್ರು ಏನು ಆಯುರ್ವೇದ ಕಾಲೇಜಿನಾಗ ಕಲ್ತಿಲ್ಲ, ಅವರು ಪುನಾದಿಂದ ಬಂದಾರ. ಅವ್ರ ಕಡೆ ಕೆಲವು ವಿದ್ಯಾರ್ಥಿಗಳು ಅದನ್ನು ನಮ್ಮ ಆಯುರ್ವೇದಿಕ ಪ್ರೊಫೆಸರ್ಸು ಎಲ್ಲ ನಿಮ್ಮ ಸಿಬ್ಬಂದಿಯವರು ಕರೆಸಿ ಅವ್ರ ಕಡೆ ಏನು ವಿದ್ಯೆ ತೊಗೊಂಡು ಟೆಸ್ಟ್ ಮಾಡಿ ಅದು ಯೋಗ್ಯ ಇತ್ತಪ್ಪ ಅಂದ್ರೆ ನಾನು ಕಾರು ತೊಗೊಂಬನ್ನಿ. ಈ ಮಕ್ಕಳಾಗಿಲ್ಲ ಅವ್ರು ಔಷಧ ಹೇಳ್ತಾರೆ, ಮಕ್ಕಳಾಗಿಲ್ಲ ಅಂದ್ರೆ ಔಷಧ ಹೇಳ್ತಾರೆ, ಮಕ್ಕಳಾಗಬೇಕು. ಆಮೇಲೆ ಈಗ ಒಂದು ಹಳ್ಳಿ ಒಳಗೆ ಹೊಟ್ಟೆ ಜಾಡ್ಸಿರ್ತಾರೆ, ಹಾಸ್ಪಿಟ್ಲ್ ಎಷ್ಟು ಇರ್ತಾರೆ, ಕೆಲವು ಹಳ್ಳಿಗೆ ಲಾಸ್ಟ್ ಹೇಳಿರ್ತಾವೆ, ಅದಕ್ಕೆ ಅದು ಬಂದ್ ಮಾಡುವಂಥದ್ದು ಐತಿ, ಚಾಲು ಮಾಡುವಂಥದ್ದು ಅವ್ರು ಕಲಿಸೋದು. ಹಂಗೆ ಅನೇಕ ಪಂಡಿತರು ನಾವು ನೋಡೀನಿ ಸಾಕಷ್ಟು. ಇಲ್ಲೇ ಈಗ ಹಡಗಲಿ ಮತ್ತು ಹರಪಳ್ಳಿ ಗಿಡಕ್ಕೆ ಬಾಗಿಲು ದೂರ ಐತಿ. ಆ ಬಾಗಿಲೊಳಗೆ ಇವತ್ತಿಗೂ ಕಾಳು ಲೆಕ್ಕದಾಗಿರಲಿ, ದನಕರ ಇರಲಿ, ಆಕಳು ಇರಲಿ, ಅವು ಏನೋ ಕಾಲ ಇದಾಗಿದ್ರೆ ಮುರಿದಿದ್ರೆ ಅದನ್ನ ಇವತ್ತಿಗೂ ಕಟ್ಟಿ ಆರಾಮ ಮಾಡಿ ಕಳಿಸ್ತಾರೆ. ಇವು ಅನೇಕ ಇವನ್ನ ನಾವು ನೋಡಿದ್ದೀವಿ. ಮತ್ತು ಇಂಥ ಒಂದು ಆಯುರ್ವೇದಿಕ ನಮ್ಮ ದೇಶದ ಇದು ಮೆಡಿಸಿನ್ ಇತ್ತು. ಮತ್ತು ಮೋದಿಯವರ ಆಯ್ತು, ಕರ್ನಾಟಕ ಸರ್ಕಾರ ಆಯ್ತು, ಕೆಲವೊಂದು ಸರ್ಕಾರ ಇವತ್ತು ಆಯುರ್ವೇದಿಕ್ ಬಗ್ಗೆ ಸಾಕಷ್ಟು ಒತ್ತು ಕೊಟ್ಟಾರ. ಮತ್ತು ಅಲೋಪತಿ ಈಗ ಎಕ್ಸ್ಟೆಂಡ್ ಆಯ್ತು, ಸೀರಿಯಸ್ ಕೇಸಸ್ ಅಲೋಪತಿನೇ ಬೇಕು ನಮ್ಗೆ. ಯಾಕೆ ಆಯುರ್ವೇದಕ್ಕೆ ಇನ್ನೂ ನಮ್ಗೆ ಸಿಕ್ಕಿಲ್ಲ. ಯಾವುದು ಎಕ್ಸ್ಟೆಂಡ್ ಕೇಸು ಇಮಿಡಿಯೇಟ್ ಬಂಧಿಸ್ಬೇಕಂದ್ರೆ ಹಿಂದಕ್ಕೆ ಆಯುರ್ವೇದೊಳಗೆ ಇತ್ತು, ಆದ್ರೆ ಅದು ನಮ್ಮಲ್ಲೇ ಇನ್ನೊಂದು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಅದು ಉಳಿತಿತ್ತು. ಅದು ಅಲ್ಲೆಲ್ಲ ಹಳ್ಳಿಯಾಗಿ ಇಟ್ಕೊಂಡು ಎಷ್ಟೋ ಮಂದಿ ತಮ್ಮ ವಿದ್ಯೆ ಇಟ್ಕೊಂಡು ಸತ್ತು ಹೋಗ್ಬಿಟ್ರು. ಆ ವಿದ್ಯೆ ಈಗ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಇತ್ತಂದ್ರೆ ಈಗ ಅನೇಕ ಕ್ಯಾನ್ಸರ್ ಈಗ ನಮ್ಮಲ್ಲೇ ನಮ್ಮ ಹಳೆಯಾಗ ಕ್ಯಾನ್ಸರ್ ಆಗೈತಿ. ಸಿದ್ಧಿಹಳ್ಳಿ ಅಂತ ತೋರ್ಸ್ಯಾನ, ನಾವು ಸಿದ್ಧಿಹಳ್ಳಿ ಸಾಗರದ ಸಿದ್ಧಿಹಳ್ಳಿ ತೋರ್ಸ್ಯಾನ. ಅವ್ನು ಕ್ಯಾನ್ಸರಿಗೆ ಆರಾಮಾಗಿ 4 ತಿಂಗಳಾಯ್ತು. ಅವನು ಅಲೋಪತಿ ತೊಗೊತಾ ಇದ್ದಾನೆ ಎಲ್ಲೇ ಮಣಿಪಾಲ್ದಾಗ. ನಿನ್ನೆ ಈಗ ಜಸ್ಟ್ ಕುಂತಾಗ ಅವ್ರು ಡಾಕ್ಟರ್ ಅಂತ ಫೋನ್ ಮಾಡುವ, ನಾನು ಹೋಗಿ ಬಂದೆ, ಆರಾಮಾಯ್ತು, ನನ್ನ ಡಾಕ್ಟರ್ ಇದರಿಂದ 2 ತಿಂಗಳು ತೊಗೊಂತಾರೆ. ಹೋದವಾದಾಗ ಅಲ್ಲೇ ಸಿದ್ಧಿಹಳ್ಳಿ ಅಂತ ಕಡೆ ಹೋದಾಗ ಅವರು ಔಷಧ ಕೊಡ್ತಾರೆ. ಸಿದ್ಧಿಹಳ್ಳಿ ನೀವು ಹೋಗಿ ನೋಡ್ಕೋಬೋದು. ಅವರು ಗುರುವಾರ ಮತ್ತು ಸಂಡೇ 2 ದಿವಸ ಔಷಧ ಕೊಡ್ತಾರೆ. ಒಂದು 1000 ಜನ ಬರ್ತಾರೆ, ಎಲ್ಲರಿಗೂ ಕೊಡ್ತಾರೆ. ಎಷ್ಟೋ ಮಂದಿ ಗುಣ ಆಗ್ಯಾರ. ಅಂಥದ್ದೇ ಹೋಗಿ ನೀವು ಆಯುರ್ವೇದಿಕ್ ಡಾಕ್ಟರ್ಸ್ ನೀವೆಲ್ಲ ಹೋಗಿ ಪ್ರೊಫೆಸರ್ಸ್ ಹೋಗಿ ಅದು ಏನಂತು ಎಲ್ಲ ತಿಳ್ಕೊಂಡು ನೀವು ಸುಮ್ಮನೆ ಟೆಸ್ಟ್ ಮಾಡಿ ಅದನ್ನು ಕಾರ್ಯಕ್ರಮ ತರಬೇಕು ಅಂತ ನನ್ನೊಂದು ಅಪೇಕ್ಷೆ. ಅಂತ ಡಾಕ್ಟರ್ ಸಾಕಷ್ಟು ಅದಾರ. ಈಗ ನಮ್ಮ ಮಳೆ ಅಲ್ಲಿ ವರ್ಷನ್ ಅದೇನಿಲ್ಲ, ಅವರು ಬಟ್ಟಿಗೆ ಕೆಲಸವಾಗಿತ್ತು, ಅದೊಂದು ಕಪ್ಪಳ ತೆಗೆದು ಹಚ್ತಾರೆ, ಬಟ್ಟಿಗೆ ಹಚ್ಚಿ ಒಂದು 2 ತಾಸು ಮಲಗಿಸ್ತಾರೆ, ಸ್ನಾನ ಮಾಡಿಸಿದಾಗ ಅದು ಹೋಗುತ್ತೆ. ಈಗ ಗಂಟ್ಲಕ್ಕಾದ್ರೆ ಗಂಟ್ಲಕ್ಕೆ ಹಚ್ತಾರೆ. ಹಿಂಗೆ ಅನೇಕ ಇವು ಸಿಸ್ಟಮ್ ಅದಾವು. ಇವನ್ನೆಲ್ಲ ಆಯುರ್ವೇದ ನಮ್ಮ ಕಾಲೇಜಿನವರು ಇವು ಹೋಗ್ಬಿಟ್ಟು, ಯಾಕಂದ್ರೆ ಆ ರಿಸರ್ಚ್ ಅವರು ಎಷ್ಟೋ ವರ್ಷದಿಂದ ಆ ವಿದ್ಯೆ ಕಲ್ತು ಉಳಿಸ್ಕೊಂಡು ಬಂದಾಗ ಅದು ಉಳಿಸೋದು ನಿಮ್ಮ ಕೆಲಸ. ಸರ್ಕಾರ ಸ್ಕೋಪ್ ಕೊಟ್ಟೈತಿ, ಸಾಕಷ್ಟು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಆಯುರ್ವೇದಿಕ್ ಆಗೈತಿ, ಉಳಿಸ್ರಿ. ಮತ್ತು ಅಲೋಪತಿಯೋ ಹೋಗ್ಬೇಕು, ಹೋಗಿ ಏನಾಯ್ತು ಆಯುರ್ವೇದದಾಗ ತಿಳ್ಕೋಬೇಕು. ಈಗ ನಾವು ಮಲೇರಿಯಾ ಅಂತ ಕೇಳ್ತೀವಿ, ಮಲೇರಿಯಾ ಇದಕ್ಕೆ ಭಾಳ ಮಲೇರಿಯಾ ಆದಾಗ ಒಂದು ಜಂಗಲ್ನಾಗ ಕೆಲವು ಆದಿವಾಸಿಗಳು ಹೋಗಿ ಅದು ಇದ್ರ ನೀರು ಹೊಂದಾಗ ಇದರ ನಿಂತಿರ್ತಾರೆ ಕಿರಿ ಒಳಗೆ ಅಂತ ನೀರು ಮಲೇರಿಯಾ ಆರಾಮ ಆಗ್ತದೆ. ಒಬ್ಬ ಸೈಂಟಿಸ್ಟ್ ಕೂತ್ ನೋಡಿದಂತೆ ಇದು ನೀರು ಅಗ್ರಿ ಹೊಲಸು ನೀರು, ಈ ಬಿಸಿಕೆರೆ ಹಸಿರು ನೀರು ಇರುತ್ತಲ್ಲ ಆ ಟೈಪು ಹೊಲಸು ನೀರು ಕುಡಿತಾರೆ, ನೀವು ಹೆಂಗೆ ಆರಾಮ ಆಗ್ತದೆ ಅಂತೇಳಿ ಅವ ಟೆಸ್ಟ್ ಮಾಡಕ್ಕೆ ಕುಂತಾವ. ಅಲೋಪತಿ ಒಬ್ಬ ಸೈಂಟಿಸ್ಟ್ ಕುಂತು ಅದು ಎಷ್ಟೋ ವರ್ಷಕ್ಕೆ ಅದು ಖಾಲಿ ಆಗ್ತದೆ. ಅಲ್ಲಿ ಒಂದು ಗಿಡದ ಬಡ್ಡಿ ಬೆಳೀತದೆ, ಆ ಬಡ್ಡಿ ಕರಿಗೆ ಮೆಡಿಸಿನ್ ಆಗಿರ್ತದೆ. ಅದು ಮನೆ ಸರ್ ಇದು ನಾವು ಓದಿದ್ವಿ. ಹಂಗೆ ಆಯುರ್ವೇದಿಕ್ ಇರಲಿ ಅಲೋಪತಿ ಇರಲಿ ಎಲ್ಲ ಗಿಡಮೂಲಿಕೆಯಿಂದ ಬರುವಂಥ ಒಂದು ಇದು ಮೆಡಿಸಿನ್. ಅದಕ್ಕೆ ಆದಷ್ಟು ನಮ್ಮ ಆಯುರ್ವೇದ ಕಾಲೇಜು, ಗದಗ ಮೆಡಿಕಲ್ ಆಯುರ್ವೇದ ಕಾಲೇಜು ಎಲ್ಲ ಡಾಕ್ಟರ್ಸ್ ಪ್ರೊಫೆಸರ್ಸು ಈಗ ಅನೇಕ ಮಂದಿ ಏನು ಹಳ್ಳಿ ಒಳಗೆ ಕೊಡ್ತಾರೆ, ಅವ್ರು ಕನ್ಸಲ್ಟ್ ಮಾಡಿ ಆ ವಿದ್ಯೆ ಏನೈತಿ ತಂದು ಸಂಶೋಧನೆ ಮಾಡಿ ಅವ್ರು ಯೋಗ್ಯ ಇದ್ದರೆ ಅದನ್ನು ತರಲಿ ಅಂತ ನಾನು ಈ ಮಿತಿ ಮುಖಾಂತರ ಹೇಳ್ತೀನಿ. ನನಗೆ ಮನೆ ಮೊನ್ನೆ ಒಂದು ಎಜೋಗ್ರಾಫಿ ಮಾಡಿದ್ರು. ಸ್ವಲ್ಪ ಇಷ್ಟ ನಡೆದ್ರೆ ನಾನು ಸುಸ್ತಾಕೈತೆ ಹತ್ತು ಹೋದ್ರೆ ನನಗೆ ಸುಸ್ತಾಕೈತೆ. ನಾನು ಡಾಕ್ಟ್ರ್ ಕಡೆ ಹೋದೆ, ಇಲ್ಲ ಎಜೋಪತಿ ಮಾಡೋಣ ಎಜೋಪ್ ಮಾಡಿ ಬ್ಲಾಕ್ ಏನಿದೆ ಅದು, ಯಾಕಂದ್ರೆ ನಂಗೆ ಬ್ಲಾಕ್ ಇಲ್ಲ ಅಂತ ಗ್ಯಾರಂಟಿ ಇತ್ತು. ಗೋಡ್ಕಿನ ಡಾಕ್ಟ್ರು ಒಂದು 30 ವರ್ಷದಿಂದ ಅಟೋರ 10 mg ಕೊಲೆಸ್ಟ್ರಾಲ್ ಗುಳಿಗೆ ಕೊಟ್ಟು ಆ ಗುಳಿಗೆ ಅಂತ ಬಂದಾಗ ನನಗಲ್ಲಿ ಬ್ಲಾಕ್ ಇಲ್ಲ ಅಂತ ಗ್ಯಾರಂಟಿ ಇತ್ತು. ಮಾಡ್ರಿ ಡಾಕ್ಟ್ರ್ ಅಂತ, ಇಲ್ಲ ಬ್ಲಾಕ್ ಅಂತ. ಮತ್ತು ಏನಾಗೈತೆ ಅದು ಏನು ಗೊತ್ತಾಗೋದು, ಬ್ಲಾಕ್ ಅಂತ ಇಲ್ಲ. ಈಗ ನೀವು ಎಕ್ಸ್ಟ್ರಾ ಗುಳಿಗೆ ಕೊಡ್ತೀವಿ, ರಕ್ತ ತಳಗೆ ಮಾಡೋದು ಮತ್ತು ಅಟೋರ 10 2 3 ಕೊಡ್ತೀವಿ, ಆಯ್ತು ಕೊಳ್ಳಪ್ಪ ತೊಗೊಂಡು ಮುಂದೆ ಒಳ್ಳೆ ಇದು 10 ಫುಟ್ ಹೋದ್ರು ಮೊದಲು ಮಾತಾಡ್ಕತ್ತ. ಅವಾಗ ಏನು ಮಾಡಬೇಕು ಅನ್ನೋ ನಾನು ಸೆಂಟ್ರಲ್ ಡಾಕ್ಟರ್ ಹೇಳಿದ್ರು, ಈಗ 40 ಅವರು ಸ್ಕ್ಯಾನಿಂಗ್ ಬರೋದು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್, ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಸ್ಕ್ಯಾನಿಂಗ್ ಅದರ ಪೂರ್ತಿ MT ಆ ಸ್ಕ್ಯಾನಿಂಗ್ ಮಾಡೋದು. ಹೋಗಿ 7 ಸಾವಿರ ಅವರು ನಮ್ಮ ಡಾಕ್ಟ್ರು ತಿಳಿಸ್ಕೊಂಡು ಸ್ಕ್ಯಾನ್ ಆಯಿತು. ಅದು ಕೊಟ್ಟು ಕುಳಿಯಿಂದ ಹಿಂದೂ ಬ್ಯಾಲೆನ್ಸ್ ಮಾಡೋದು ದೋಷ. ಅವಾಗ ನಾನು ಇದು ಆಯುರ್ವೇದಕ್ಕೆ ಆರಾಮಾಗಿ ಬಂದಿದ್ದು. ನಮ್ಮ ಮಗಳು ಏನಾದ್ರು ಡಾಕ್ಟ್ರಿಗೆ ಹೋಗ್ಬೋದು, ಪುರೋಸ್ ಸರ್ಗೆ ರಿಂಗ್ ಮಾಡಿದ್ವಿ. ಪುರೋಸ್ ಸರ್ ಔಟ್ ಆಫ್ ಕಾಲೇಜ್ ಬಂತು, 4-5 ಬಾರಿ ಮಾಡಿದಾಗ ಅವ್ರು ಹಿರೇಮಠ ಸರ್ಗೆ ನಾವು ಪ್ರೊಫೆಸರ್ ಹಿರೇಮಠದ್ರು ನಾವು ಫೋನ್ ಮಾಡಿದ್ವಿ. ಯಾಕಂದ್ರೆ ನಾವು ಹಿಂದಕ್ಕೆ ಸ್ವಲ್ಪ ಇದ್ರ ಕಡೆ ಬರ್ತಿದ್ವಿ, ಕೆಲವು ಔಷಧ ಮಾಹಿತಿ ಕೇಳಕ್ಕೆ 30 ವರ್ಷದಿಂದ ಬರ್ತಿದ್ವಿ ನಾವು. ಅವರು ಬರೀ ನೀವು ಪುರದ ಇವರು ನಮ್ಮ ಮಾರಮೇಶ್ವರ ಸರ್ ಮಾರಮೇಶ್ವರ ಸರ್ ಕಡೆ ಕರ್ಕೊಂಬಂದು ಬಸರಿಗಿಡ ಸರ್ ಕಡೆ ಕರ್ಕೊಂಬಂದು ಬಂದು ಕೂಡ ಎಲ್ಲ ಒಂದು 10 ದಿವಸದ್ದು ಮೆಡಿಸಿನ್ ಕೊಟ್ಟರು. ಮತ್ತು ಇದನ್ನು ಪಂಚಕರ್ಮ ಮತ್ತು ಎಲ್ಲ ಆಯಿತು. ಈಗ 30 ದಿವಸ ಅವ್ರ ಕಡೆ ತೊಗೊಂಡೆ. ನನಗೆ ಯಾವುದೇ ಇಲ್ಲ, ಬರೋಬ್ಬರಿ 40 ನಿಮಿಷ ವಾಕಿಂಗ್ ಮಾಡ್ತೀನಿ ನಾನು ಬೆಳಿಗ್ಗೆ. ಮೊದಲು ಇಷ್ಟ ಉಳಿದಿದ್ದೆ ಅಂತಂದ್ರೆ ಇವತ್ತು ಬೆಳಿಗ್ಗೆ ನಾನು 40 ನಿಮಿಷ ನಮಗೆ ಚೆನ್ನೈ ಹಿರೇಮಠರು ಅವರು ಆಯುರ್ವೇದ ಡಾಕ್ಟ್ರು ಚೆನ್ನೈ ಹಿರೇಮಠರು ಹಳ್ಳ್ಯಾಗ ನೀವು ವಾಕಿಂಗ್ ಚಾಲು ಮಾಡಿದ್ರು. ಇಲ್ಲ ನಂಗೆ 10 ಫುಟ್ ನೋಡೋದು ಈಗ ನಡೆಯಕತ್ತಿರ ನಡ್ರಿ ನೀವು ಒಂದು ವಾಕಿಂಗ್ ಹೋದರೆ ಆ ಸರ್ ಔಷಧ ಕೂತು ವಾಕಿಂಗ್ ಹೋದ್ರೆ 40 ನಿಮಿಷ ಕಾನ್ಸೆಪ್ಟ್ ನಾನು ಹೋಗ್ತೀನಿ. ಅಲ್ಲಿ ಕೂತು ಒಂದು 5 ನಿಮಿಷ ಅಷ್ಟು ತೊಗೊಂಡು ಮತ್ತೆ ಎಕ್ಸರ್ಸೈಸ್ ಮಾಡಿ ನಾನು ಮನೆಗೆ ಬರ್ತೀನಿ. ಆಯುರ್ವೇದಕ್ಕೆ ಏನೈತಿ ಭಾಳ ಒಳ್ಳೇದೈತಿ. ಸಾಕಷ್ಟು ವಿದ್ಯಾರ್ಥಿಗಳು ಇಂಟ್ರೆಸ್ಟ್ ತೊಗೊಂಡು ನಿಮ್ಮ ಹಳ್ಳಿ ಒಳಗೆ ಏನು ಡಾಕ್ಟರ್ ಸಾರ ಅವ್ರನ್ನ ಸ್ವಲ್ಪ ತಿಳ್ಕೊಬೇಡ್ರಿ. ಅವ್ರ ಕಡೆಯಿಂದ ಕೆಲವು ಹೋಗಿ ನಮ್ಮ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ನವ್ರಿಗೆ ನಾವು ರಿಕ್ವೆಸ್ಟ್ ಮಾಡ್ತೇನೆ ಅಂದರೆ ನೀವು ಅವ್ರ ಕಡೆ ಹೋಗಿ ಅದು ಏನೇನ ಇದು ಔಷಧ ತೊಗೊಂಡು ತಂದು ರಿಸರ್ಚ್ ಮಾಡಿ ಹೋಗ್ಬಿಟ್ರೆ ಡಾಕ್ಟರ್ ಅಂತ ಈ ರೀತಿ ಮುಖಾಂತರ ಹೇಳಿ. ಮತ್ತು ಹಿಂದೆ ಗುಮ್ಮರೋಡ್ ಡಾಕ್ಟರ್ ಅಂತಿದ್ರು, ನಮ್ಗೆ ಗೊತ್ತೈತಿ ಡಾಕ್ಟರ್ ಗುಮ್ಮರೋಡಿ MBBS MD MS ಅವರು. ನನಗೊಮ್ಮೆ 35 ವರ್ಷದಿಂದ ಇಲ್ಲಿ ಚುಚ್ಚಾಕತ್ತಾನೆ ಅಂತ ಚುಚ್ಚಿದ್ರೆ ಡಬಳ ಚುಚ್ಚಿದಾಗ ಇದೇನೋ ಹಾರ್ಟ್ ಆಗ್ತದೆ ಅಂತ ನೀವು ಹಿಡ್ಕೊಂಡು ಕಾರ್ನಾಗ ಕರ್ಕೊಂಡು ಡಾಕ್ಟರ್ ಹೋದೆ ಅವ್ರ ಹಾಸ್ಪಿಟ್ಲಿಗೆಲ್ಲ. ಸರ್ ನನಗೆ ಹಾರ್ಟ್ ಭಾಳ ಇದಾಗುತ್ತೆ, ಹಾರ್ಟ್ ಆಗಿದೆ. ಹಾರ್ಟ್ ಆಗಿದೆ ನನಗೆ ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ, ನಿಮ್ಗೆ ಹಾರ್ಟ್ ಆಗಿಲ್ಲ, ಗ್ಯಾಸ್ ಆಗಿದೆ, ಕುಂದಿರ್ಬೇಕು ಡಾಕ್ಟರ್. ಕುಂದಿರಿಸಿ ಮಧ್ಯಾಹ್ನ ಏನಾಗಿಲ್ಲ ಕುಂದಿರ್ಬೇಕು. ಕುಂದಿರಿಸಿದ್ರು ಒಂದು ಗುಳಿಗೆ ಕೊಡು, ಗ್ಲಾಸ್ಗೆ ಗುಳಿಗೆ ತಿಂದಿದ್ರು ನಾವು ತಿಂದೆ. ಇನ್ನೊಂದು ಕೊಡೋರಿಗೆ ತಿಂದೆ, ನೀರು ಕೊಡೋದು ಹೋಗ್ತಿದ್ರು, ಗ್ಯಾಸ್ ಎಲ್ಲ ಹೋಗಿ ಅದು ಹೋಗೋದು. ಅವ್ರು ಹೇಳಿದ್ರು, ಇದು ಆಯುರ್ವೇದಿಕ್ ಹೇಳಿದ್ರು ಅವ್ರು MS MD ಅವರು ಅಲೋಪತಿ ಡಾಕ್ಟ್ರು, ನೀನು ಇನ್ನು ಮೇಲಿಂದ ತೋಟದಲ್ಲಿ ಮಾಡೋದು ಮೆಣಸಿನ್ಕಾಯಿ ತಿನ್ಬೇಡ, ಮೆಣಸಿನ್ಕಾಯಿ ಹಸಿಕಾಯಿ ಆಗುತ್ತಾ, ಆಮೇಲೆ ಕಡ್ಲಿ ಚಟ್ನಿ ತಿನ್ಬೇಡ, ಇಂಥವೆಲ್ಲ ಕರ್ಕಲ ಬಿಡು ಮತ್ತೆ ಹೇಳಿದ್ರು. ನಿಮ್ಗೆ ಕಾಲ ಆರಾಮಾಗುತ್ತಾ, ಗುಳಿಗೆ ಕೊಡೋದು ಇದು ಬಿಟ್ಟು ಬಿಡೋ ಆರಾಮಾಗ, ಇವತ್ತಿಗೂ ಆರಾಮಾಗ. ಅಂದ್ರೆ ಒಳ್ಳೆ ಡಾಕ್ಟರ್ ಅಂತಿದ್ರು ನಮ್ಮ ಡಾಕ್ಟರ್ ಬೆಳವಣಿಗೆ ಅವ್ರ ಕಡೆ ನಾವು ತೋರಿಸ್ತಿದ್ವಿ. ಅವರು ಏನಪ್ಪ ಅಂದ್ರೆ ಟೋಟಲ್ ಆಯುರ್ವೇದಿಕ್ ಹಿಡ್ಕೊಂಡ ಅಲೋಪತಿ ಅವರು ಆಯುರ್ವೇದಿಕ್ ಹಿಡ್ಕೊಂಡ ಮೆಡಿಸಿನ್ ಕೊಡ್ತಿದ್ರು. ಪತ್ತೆ ಮಾಡಿರಿ ಮೊದಲು ನೀವು ಈ ಚಪಾತಿ ಮಾಡಿರಿ ಇಂಥದ್ದು ಮಾಡಿರಿ ಅಂತ ಹೇಳಿ ಔಷಧ ಕೊಡ್ತಿದ್ದೆ. ಅದು ಅಲೋಪತಿ ಕೊಡ್ಬೇಕಾದ್ರೆ ಅದು ಅಲೋಪತಿ ಏನಪ್ಪ ಅಂದ್ರೆ ಅದು ಇಂಗ್ಲೀಷ್ ಔಷಧ. ನಮ್ಮ ದೇಶನ ಬ್ರಿಟಿಷರು ಎಷ್ಟೋ ವರ್ಷ ಆಳಿಲ್ಲ, ಆ ಮೆಡಿಸಿನ್ ಇದು ಬಂತು. ಆಯುರ್ವೇದಿಕನೂ ಇರಲಿ ಅದು ಇರಲಿ, ಎರಡು ಶ್ರೇಷ್ಠ ಎರಡು ಬೆಳೀಲಿ. ಜನರಿಗೆ ಸ್ಪರ್ಧೆ ಹೆಂಗೆ ಆಗ್ಬೇಕಂದ್ರೆ ನಂದು ಶ್ರೇಷ್ಠ ನಿಂದ ಶ್ರೇಷ್ಠ ಅನ್ನೋದು ಎರಡೂ ಶ್ರೇಷ್ಠ ಕೂಡಿ ಜನರಿಗೆ ಒಳ್ಳೇದು ಮಾಡಲಿ ಅಂತ
Thank you, sir, for your inaugural words and sharing your experience. Now, I request all the dignitaries on dance to felicitate today's chief guest, Sri Manjunath Abhigiri, sir. take today's resource person, Dr. Satyanarayan Bhatt sir and Dr. Shakuntala Armani ma'am. Thank you all dignitaries. Now I request Shri V.S. Patil sir, Secretary JSPP Samsthe Gadag, to speak few words about this event.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರಗಳು. ಅಂಕೋ ವೇದ 2022 ಈ ಒಂದು ಸಮಾರಂಭದಲ್ಲಿ ಉಪಸ್ಥಿತರಿರ್ತಕ್ಕಂಥ ವೇದಿಕೆ ಮೇಲೆ ಇರ್ತಕ್ಕಂಥ ಎಲ್ಲರಿಗೂ ಗಣ್ಯರಿಗೆ ನಮಸ್ಕರಿಸುತ್ತಾ ಹಾಗೂ ಇಂದಿನ ಸಮಾರಂಭದಲ್ಲಿ ಭಾಗಿಯಾಗಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ಸಿಬ್ಬಂದಿಯವರಿಗೂ ಹಾಗೂ ನಮ್ಮ ಮಾಜಿ ಪ್ರಿನ್ಸಿಪಾಲ್ಗಳು ಮತ್ತು ಇತರೆ ಗೆಸ್ಟ್ಗಳೆಲ್ಲ ಬಂದಿದ್ದಾರೆ, ಅವರು ಎಲ್ಲರಿಗೂ ನಮಸ್ಕರಿಸುತ್ತಾ ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರಗಳು. ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮ ಏರ್ಪಡಿಸಿರೋದು ನಮಗೆ ಭಾಳ ಸಂತೋಷ ಅನಿಸುತ್ತೆ. ಯಾಕೆಂದರೆ ಇವತ್ತಿನ ಕಾಲದಾಗ ಈಗ ಕ್ಯಾನ್ಸರ್ ಬಗ್ಗೆ ಈಗ ಎಷ್ಟೋ ಸಾಕಷ್ಟು ರಿಸರ್ಚ್ಗಳು ನಡೆದವು. ಸುಮಾರು ಈಗ ಒಂದು 40 ವರ್ಷ 50 ವರ್ಷದಿಂದ ಕ್ಯಾನ್ಸರ್ ಬಂದತಿ ಅಂದ್ರೆ ಜನ ಸತ್ತೋಗ್ಬಿಡ್ತಾರೆ. ಆ ಒಂದು ಫೀಲಿಂಗ್ ಇತ್ತು. ಅಂಥದನ್ನು ಹಂತ ಹಂತವಾಗಿ ಸಾಕಷ್ಟು ಡೆವಲಪ್ಮೆಂಟ್ಸ್ ಆಗಿದ್ದವು. ಮತ್ತು ಇದರಲ್ಲಿ ಎಷ್ಟು ರಿಸರ್ಚ್ ಮಾಡಿದರೂ ಕಡಿಮೆ. ಆಯುರ್ವೇದಿಕ್ ಇರಲಿ, ಅಲೋಪತಿ ಇರಲಿ, ಯಾವುದೇ ಇರಲಿ, ಎಷ್ಟು ರಿಸರ್ಚ್ ಮಾಡಿದರೂ ಕಡಿಮೆ. ಓವರಾಲ್ ವ್ಯಕ್ತಿಗೆ ಏನಿದೆ ಆಗಬೇಕು, ಆರಾಮಾಗಬೇಕು, ಅದು ಮುಖ್ಯ ಇರೋದು. ನಾನು ಒಂದು 2 ಘಟನೆಗಳನ್ನು ಹೇಳ್ತೇನೆ. ಅದನ್ನ ಹೇಳಿ ನಾನು ಒಂದು ಇದನ್ನು ಮಾಡ್ತೀನಿ. ಮೊದಲನೇದು, ಸುಮಾರು ಒಂದು 1974-75ರಲ್ಲಿ ನಮ್ಮ ತಾಯಿ ತಂಗಿ, ಅದು ನಮ್ಮ ಚಿಕ್ಕಮ್ಮರಿಗೆ ಒಂದು ಈ ಥರ ಕೈಯಲ್ಲಿ ಒಂದು ಗಂಟಾಗಿತ್ತು. ಗಂಟಾದಾಗ ಅದನ್ನೇನು ಮಾಡಿದ್ರು, ಡಾಕ್ಟರ್ ಅವ್ರನ್ನ ಬಯಾಪ್ಸಿಗೆ ಅವಾಗ ಇಲ್ಲಿ ಎಲ್ಲಿ ಇದ್ದಲ್ಲೋ ಬಾಂಬೆ ಕಳಿಸ್ಬೇಕಾಗಿತ್ತು. ಬಯಾಪ್ಸಿ ಕಳಿಸಿದಾಗ ಅದ್ರಲ್ಲಿ ಏನಂತ ಬಂತು, ಇಲ್ಲ ಅದು ಕ್ಯಾನ್ಸರ್ ಆಗಿದೆ, ಅದು ಕ್ಯಾನ್ಸರ್ ಟ್ಯೂಮರ್ ಅದಕ್ಕೆ ಅದನ್ನು ಅಷ್ಟೇ ಆಪ್ರೇಷನ್ ಮಾಡೋಕ್ಕಾಗಲ್ಲ, ಮತ್ತು ಬೇರೆ ಕಡೆ ಎಲ್ಲ ಸ್ಪ್ರೆಡ್ ಆಗುತ್ತೆ. ಇಮಿಡಿಯೇಟಾಗಿ ಕೈ ಕಟ್ ಮಾಡಿಬಿಡ್ರಿ, ಮಾಡಿಸ್ಬಿಡ್ರಿ, ಆಪ್ರೇಷನ್ ಮಾಡಿ ಅಂತ ಹೇಳಿದರು. ಯಾವುದೋ ಎಡಗೈ. ಅವಾಗ ನಮ್ಮ ಚಿಕ್ಕಮ್ಮರು ಸ್ವಲ್ಪ ಬಾಡಿಲಿ ವೀಕ್ ಆಯಿದ್ರು ಅವರು. ಮತ್ತು ಅವರಿಗೆಲ್ಲ ಇಂಥವೆಲ್ಲ ಹೇಳ್ಬಿಟ್ರೆ ಮತ್ತಷ್ಟು ಇದಾಗ್ಬಿಡ್ತಾರೆ, ಕುಂದು ಹೋಗಾರ ಹೇಗೆ ಮಾಡೋದು ಏನು ಅಂತಂದು ಭಾಳಷ್ಟು ವಿಚಾರಗಳು ನಡೆದವು. ಭಾಳಷ್ಟು ಕಡೆ ಬೆಂಗಳೂರಿಗೆ ಹೋಗಿ ಬಂದರು, ಮತ್ತು ಡೆಲ್ಲಿ ಹೋಗಿ ತೋರಿಸಿದ್ರು. ಇಲ್ಲಿ ಬೇರೆ ಏನು ಇಲ್ಲ, ಏನು ಮಾಡೋದು ಅಂತ ಅಂದರು. ಅದಕ್ಕೆ ನಮ್ಮ ಮಗಳಿಗೆ ಏನಂದ್ರೆ, ಇಲ್ಲ ಆಕೆ ಕೈಗೆ ಕಟ್ ಮಾಡಿದ್ರೆ ಭಾಳ ದಿವಸ ಉಳಿಯೋದೇ ಅಲ್ಲ, ಮತ್ತಷ್ಟು ಅದೇ ಒಂದು ಕೊರಗಿನಾಗ ಇದಾಗ್ಬಿಡ್ತಾರ, ಏನಾರ ಬೇರೆ ಏನಾದರೂ ನೋಡೋಣ, ವಿಚಾರ ಮಾಡೋಣ ಅಂತಂತ ಸ್ವಲ್ಪ ಒಂದು 15 ದಿವಸ 20 ದಿವಸ ಕಳೆದ್ರು. ಆ ಟೈಮಲ್ಲಿ ಏನಾಯ್ತು, ಒಬ್ಬ ಪಾರಂಪರಿಕ ವೈದ್ಯರು ನಮ್ಮ ಅಲ್ಲೇ ರಾಣಿಬೆನ್ನೂರು ಸರೌಂಡಿಂಗ್ ಯಾವುದೋ ಒಂದು ಹಳ್ಳಿಯಲ್ಲಿದ್ದರು ಅವರು. ಅವ್ರನ್ನ ಏನೋ ಒಂದು ವಿಷಯದಾಗ ಬಂದಾಗ ನಾನು ನೋಡ್ತೇನೆ, ಇದನ್ನು ಏನು ವಿಚಾರ ಮಾಡ್ತೀನಿ ಅಂತ. ನಮ್ಗೆ ಇಲ್ಲ ಪೂರ್ಣ ಧೈರ್ಯನೂ ಅಲ್ಲ. ಆಯಿತು, ಏನೋ ಮಾಡಿ, ಮತ್ತು ನಾವು ಅದನ್ನು ಕೈ ಕಟ್ ಮಾಡೋಕ್ಕಿಂತ ಬೇರೆ ಏನಿದೆಯಲ್ಲ ಆಲ್ಟರ್ನೇಟಿವ್ನ ಮಾಡಿ ವಿಚಾರ ಮಾಡಿ ನೋಡೋಣ ಅಂತ ಅಂದರು. ಅವರು ಬಂದು ನೋಡಿ ಒಂದು ದಿವಸ 2 ದಿವಸದಲ್ಲಿ ನೋಡಿದರು, ಇವ್ರ ಬಗ್ಗೆ ಡೀಟೇಲ್ ಸ್ಟಡಿ ಮಾಡಿದರು. ಮಾಡಿ ನಾನು ಆಪ್ರೇಷನ್ ಮಾಡಿ ತೆಗಿತೀನಿ ಅಂದರು ಅವರು. ಅವ್ರಿಗೆ ನೀವು ಏನು ಮಾಡ್ತೀವಿ ಆಪ್ರೇಷನ್ನ, ಇಲ್ಲ ಇಲ್ಲೇ ಮಾಡ್ತೇನೆ ನೀವೇನು ಅದ್ರ ಬಗ್ಗೆ ವಿಚಾರ ಮಾಡಬೇಡ್ರಿ ಅಂತ ಅಂದರು. ನಮ್ಗೆ ಅದು ಒಂದು ಸ್ವಲ್ಪ ಮನಸ್ಸಿಗೆ ಅಳಕ್ಕೆ ಬಂತು. ಅಳಕ್ಕಿತ್ತು ನೋಡ ನಮ್ಮ ಮಗ ಅಂದ್ರೆ ಆಯ್ತು ಬಿಡಪ್ಪ ಏನೈತಿ ಮತ್ತು ಆಕೆ ಅಲ್ಲಿ ಹೋದ್ರು ಕಟ್ಗಿಟ್ಟು ಮಾಡಿದ್ರೆ ಒಳ್ಳೇದಲ್ಲ, ನೋಡೋಣ ಹೇಗೈತೆ ಮಾಡಿ ಹೋಗ್ಬೋದು ಅಂತಂದ್ರು. ಅವ್ರು ಏನು ಮಾಡಿದ್ರು ಅಂದ್ರೆ ಇದು ಮತ್ತೆ ತಪ್ಪು ತಿಳ್ಕೊಬೇಡ್ರಿ, ನಾ ಇದು ಹೇಳೋದೆಲ್ಲ ಔಟ್ ಆಫ್ ವೇದಾಗೆ ಇದೆ ಮತ್ತೆ ಇರೋದು. ಅವ್ರು ಏನು ಮಾಡಿದ್ರು, ಅವು ಹೊಸವೆಲ್ಲ ಬೇಡಿಗೆಲ್ಲ ತರಿಸಿ ಮನೆಯಲ್ಲೇನ ಇದನ್ನು ಕಟ್ ಮಾಡಿದ್ರು. ಕಟ್ ಮಾಡಿ ಅವು ಏನೋ ಒಂದು ಕೊಳೆ ಗಿಬ್ಬಿ ಇಟ್ಕೊಂಡು ಅವೆಲ್ಲ ಬ್ಲಡ್ ಗಿಡ್ಡೆಲ್ಲ ತೆಗೆದು ಸಕ್ ಮಾಡಿ ಅದು ಒಂದು ಇಟ್ಟು ಗಡ್ಡಿ ಅಂತಂದು ಬಂತು. ಅದೆಲ್ಲ ಬಂತು, ಅದನ್ನು ತೆಗೆದ್ರು. ಆಮೇಲೆ ಅವ್ರು ಡ್ರೆಸ್ಸಿಂಗ್ ಮಾಡಿದ್ರು. ಮಾಡಿ ಸುಮಾರು ಒಂದು 10-15 ದಿವಸ ಅದು ಏನೇನೋ ಸ್ವಲ್ಪ ಆಯುರ್ವೇದಿಕ್ ಅದು ಕೊಡ್ತಾ ಇದ್ರು ಅವರು. ಅದು ಕೊಟ್ಟ ಮೇಲೆಲ್ಲ ಆರಾಮಾತು ಅವ್ರಿಗೆ ಸ್ವಲ್ಪ ಅದೇನು ರಿಲೀಫ್ ಆಯ್ತು. ರಿಲೀಫ್ ಆದಮೇಲೆ ಒಟ್ಟ ಹೇಳಿದ್ದಲ್ಲ ಇದು ಹಿಂಗೆ ಕ್ಯಾನ್ಸರ್ ಐತಿ ಇದು ಐತಿ ಅಂತಂದು ಅವ್ರಿಗೆ ಆರಾಮಾಗ್ತದೆ. ಡಾಕ್ಟ್ರೆ ಅವರು ಪಾರಂಪರಿಕ ವೈದ್ಯರು ಏನಂದ್ರೆ ನೋಡಿ ನೀವೇನು ಆರಾಮೈತಿ ಇದ್ರ ಬಗ್ಗೆ ಬಿಡ್ರಿ, ಸುಮ್ಮನೆ ಬಿಡ್ರಿ ಅಂತ ಅಂದರು. ಆಯಿತು ಅಂತ ಸುಮಾರು ನಾವು ಸುಮಾರು ಒಂದು 2 ತಿಂಗಳು 2.5 ತಿಂಗಳು ಅನ್ನೋದ್ರೆ ಅದೇನು ಕಟ್ ಮಾಡಿದ್ರಲ್ಲ ಅದೆಲ್ಲ ಹೆಲಪ್ ಆಯಿತು. ಹೆಲಪ್ ಆಯಿತು, ಎಲ್ಲ ಆಯಿತು. ಆಮೇಲೆ ಅವ್ರಿಗೆ ಒಂದು 1 ಮಂತ್ ಒಂದಿಷ್ಟು ಅವರು ಆಯುರ್ವೇದಿಕ್ ಔಷಧ ಕೊಟ್ಟರು. ಆಯುರ್ವೇದಿಕ್ ಔಷಧ ಕೊಟ್ಟಮೇಲೆ ಆರಾಮಾಯಿತು. ಅವ್ರಿಗೆ ಆ ಥರ ಆರಾಮಾಗಿದ್ದು ಸುಮಾರು ಒಂದು 20 ವರ್ಷ ಆದಮೇಲೆ ಅವರು ತೀರ್ಕೊಂಡ್ರು. ಆ 20 ವರ್ಷದವರೆಗೂ ಈ ಕ್ಯಾನ್ಸರ್ ಬಗ್ಗೆ ಆಗಲಿ ಮತ್ತೊಂದ್ರ ಬಗ್ಗೆ ಆಗಲಿ ಅದು ಆಗಿತ್ತು ಅನ್ನೋದು ಯಾರಿಗೆ ಅವ್ರಿಗೂ ತಲೆಯಾಗಿ ಬರಲಿಲ್ಲ, ಉಳಿದವ್ರಿಗೂ ತಲೆಯಾಗಿ ಬರಲಿಲ್ಲ. ಇದೆಲ್ಲ ಏನು ಅನಿಸುತ್ತೆ ಅಂದ್ರೆ ಅದು ಏನು ದೇವರ ಇಚ್ಛೆ ಅದು, ಯಾರ ಕೈಯಿಂದಲ್ಲ, ಅದು ಹೇಗೆ ಆರಾಮಾಯ್ತೋ ಏನಾಯ್ತೋ ಗೊತ್ತಿಲ್ಲ. ಇದು ಒಂದು ಘಟನೆ. ಆಮೇಲೆ ಇನ್ನೊಂದು ಘಟನೆ ಏನಂದ್ರೆ ನಮ್ಮಲ್ಲಿ ಒಬ್ಬರು ಫೇಮಸ್ ಡಾಕ್ಟರ್ ರಾಣೆಮಂಡ್ರಲ್ಲಿ ಫಿಸಿಷಿಯನ್, ಒಳ್ಳೆ ಫೇಮಸ್ ಡಾಕ್ಟರ್. ಅವರು ಮಗ ಸುಮಾರು ಒಂದು 12-13 ವರ್ಷ ಇದ್ದಾಗ ಅವನಿಗೆ ಬ್ಲಡ್ ಕ್ಯಾನ್ಸರ್ ಅಂತಂದು ಇದು ಮಾಡಿದ್ರು. ಬ್ಲಡ್ ಕ್ಯಾನ್ಸರ್ ಅಂತ ನನಗೆ ನಾವು ಭಾಳ ನರ್ವಸ್ ಆಗಿಬಿಟ್ರು, ಹೇಗೆ ಮಾಡೋದು ಏನು. ಅವ್ರು ಕಂಟಿನ್ಯೂಸ್ ಆಗಿ ಮುಂಬೈದಲ್ಲೇ ಕರ್ಕೊಂಡೋಗಿ ಟಾಟಾ ಇನ್ಸ್ಟಿಟ್ಯೂಟ್ನಾಗ ಅವನಿಗೆಲ್ಲ ಇದು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಿಸಿ ಭಾಳ ಸುಮಾರು 1 ವರ್ಷದ ದಿವಸ ಅವರು ಪೇಚಾಡಿದ್ರು. 1 ವರ್ಷದ ದಿವಸ ಪೇಚಾಡಿ ಅವನ್ನ ತಿರುಗಿ ಆರಾಮಾಗಿ ಬಂದ ಹುಡುಗ ಆರಾಮಾಗಿ ಬಂದು ಈಗ ಅವ ಏನಿದಾನ ಅಂದ್ರೆ ಪೂರ್ಣ ಪ್ರಮಾಣದಾಗ ಆರಾಮಾಗಿ ಅವ ತಿರುಗಿ ಕಂಪ್ಯೂಟರ್ ಸೈನ್ಸ್ ಮುಗಿಸಿದ. ಕಂಪ್ಯೂಟರ್ ಸೈನ್ಸ್ ಮುಗಿಸಿ ಈಗ ಇಂಡಿಯಾಕ್ಕೆ 2 ಪರ್ಸನ್ಸ್ ಅದು ಸೆಲೆಕ್ಟ್ ಆಗ್ಯಾರ ಅಮೇರಿಕದಲ್ಲಿ, ಅಮೆಜಾನ್ ಒಳಗೆ, ಆ ಸ್ಪೆಷಲ್ ಇದ್ರೊಳಗೆ ಅವ ಅದು ಸಾರಿ ಅಮೆಜಾನ್ ಅಲ್ಲ, ಇದು ಆ್ಯಪಲ್ ಇದ್ರೊಳಗೆ, ಆ್ಯಪಲ್ ಕಂಪ್ಯೂಟರ್ಸ್ ಐತಲ್ಲ ಅದರೊಳಗೆ ಇಡೀ ಇಂಡಿಯಾಕ್ಕೆ ಇಬ್ಬರು ಅಂತ ಅದ್ರಾಗ ಅವನು ಒಬ್ಬನು ಫಸ್ಟ್ ಪರ್ಸನ್. ಅವನು ಈಗ ಹೆಚ್ಚು ಕಮ್ಮಿ ಒಂದು ಹೋಮ್ ಟೇಕ್ ಸ್ಯಾಲ್ರಿ ಏನಿದೆ ಅಲ್ಲ ಪರ್ ಇಯರ್ 5 crores ಇದೆ. ಅವ ಈಗ ಏನೂ ಆಗಿಲ್ಲ ಅನ್ನೋ ವ್ಯಕ್ತಿ ಅದಾನ. ಅಂದ್ರೆ ಏನಿದ್ರೆ ತಾತ್ಪರ್ಯ ಒಂದು ಆಗಲಿ ಅಲೋಪತಿ ಆಗಲಿ ಇವೆಲ್ಲ ಸರಿಯಾದ ಟ್ರೀಟ್ಮೆಂಟ್ ತೊಗೊಂಡಾಗ ಆರಾಮಾಗುತ್ತೆ. ಮತ್ತು ಅವನಿಗೆ ಎಷ್ಟು ನಗನಾಗುತ್ತೆ ಅದಾನ ಅಂದ್ರೆ ಅವ್ನಿಗೆ ಈಗ ನೆಕ್ಸ್ಟ್ ಮೋಸ್ಟ್ಲಿ ಇನ್ನೊಂದು 4-5 ಮಂತ್ಸಲ್ಲೇ ಮ್ಯಾರೇಜ್ ಮಾಡ್ತಾರೆ ಅವನು ಅಂತ ಆರಾಮಾಗಿದೆ. ಅದಕ್ಕೆ ಯಾವುದಕ್ಕಾದ್ರೂ ಮನೋಧೈರ್ಯ ಮನಸ್ಥೈರ್ಯ ಆಮೇಲೆ ಅವ್ರು ತೊಗೊಳ್ತಕ್ಕಂಥ ಟ್ರೀಟ್ಮೆಂಟು ಇವೆಲ್ಲ ಅವ್ರ ಮೇಲೆ ಪರಿಣಾಮ ಬೀರುತ್ತೆ. ಒಂದು ದೆಸೆಯಲ್ಲಿ ತಾವೆಲ್ಲ ಈ ಒಂದು ಆಯುರ್ವೇದಿಕ್ ಆಗಲಿ ಅಲೋಪತಿ ಆಗಲಿ ಎಷ್ಟು ಮಾಡಿದ್ರೆ ಕಡಿಮೆ ಅದನ್ನು ಮಾಡ್ಕೊಂಡು ಹೋಗಿ ಈ ಒಂದು ಪೇಷಂಟ್ಗಳಿಗೆ ಕ್ಯಾನ್ಸರ್ ಪೇಷಂಟ್ಗಳಿಗೆ ಒಂದು ಅನುಕೂಲ ಆಗುತ್ತದೆ ಅಂತಂದು ನಾನು ಒಂದು ವ್ಯಕ್ತಪಡಿಸುತ್ತಾ ನನಗೆ ಅವಕಾಶ ಮಾಡಿಕೊಟ್ಟು ಎಲ್ಲರಿಗೂ ವಂದನೆ ತಿಳಿಸುತ್ತಾ ನಾನು
So, now I request Dr. G.B. Patil sir, Executive. Now I request Dr. E.B. Pura sir for presidential speech.
ಪ್ರಕಸ್ಮರಣೀಯ ಜಗದ್ಗುರು ಶಿವಾನಂದ ಮಹಾಸ್ವಾಮಿ ಅವರನ್ನ ಪರಂಪರೆಯೆಲ್ಲ ಪೂಜ್ಯರನ್ನ ಭಕ್ತಿಪೂರ್ವಕವಾಗಿ ನಮಸ್ಕರಿಸಿ ಇಂದು ಕಾಯಚಿಕಿತ್ಸಾ ಸ್ನಾತಕೋತ್ತರ ವಿಭಾಗದಿಂದ ಜರುಗುತ್ತಿರುವ ಆಂಕೋವೇದ ಎನ್ನುವ ವಿಚಾರ ಸಂಕಿರಣದ ಮುಖ್ಯ ಅತಿಥಿಗಳು, ಈ ನಾಡಿನ ಬಹುದೊಡ್ಡ ಕಿತ್ತೂರು ಕರ್ನಾಟಕ ಪತ್ರಿಕೆಯ ಸಂಪಾದಕರಾಗಿರ್ತಕ್ಕಂಥ ಸನ್ಮಾನ ಶ್ರೀ ಮಂಜುನಾಥ್ ಸರ್ ಬಿಗೇರವರೇ, ಇವತ್ತಿನ ಮುಖ್ಯ ಅತಿಥಿಗಳಾದ ಶ್ರೀ ಬಿ ಎಸ್ ಪಾಟೀಲ್ ಸರ್ ಅವರೇ, ಜೊತೆಗೆ ಡಾಕ್ಟರ್ ಸತ್ಯನಾರಾಯಣ ಭಟ್ರು ಅವರೇ ಮತ್ತು ಡಾಕ್ಟರ್ ಅರ್ಮನಿ ಮೇಡಮ್ ಅವರೇ, ಸಂತೋಷ್ ಬೆಳವಡಿ ಅವರೇ ಮತ್ತು ಎಸ್ ಎನ್ ಪಡಿಮಂದ್ ಅವರೇ, ಡಾಕ್ಟರ್ ಜೆ ಎಸ್ ಸರ್ ಅವರೇ, ಅವರು
ಹಿರೇಮಠರವರೇ ಮತ್ತು ಎಲ್ಲ ಆಮಂತ್ರಿತರೆ, ಎಲ್ಲ ಮಹಾವಿದ್ಯಾಲಯದಿಂದ ಆಗಮಿಸಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ಯುವ ಸಂಶೋಧಕರೇ, ತಮ್ಮೆಲ್ಲರಿಗೂ ಶರಣೆ. ಇಲ್ಲಿವರೆಗೆ ಉದ್ಘಾಟನೆ ಮಾಡಿದ ಮಂಜಾತ ಬಿಗೆ ಸರ್ ಅವರು ನಮಗೆ ಬಹಳ ಮೌಲ್ಯಯುತವಾಗಿರ್ತಕ್ಕಂಥ ಸಂದೇಶವನ್ನು ಕೊಟ್ಟಿದ್ದಾರೆ. ಅದು ಭಾಷಣ ಅಲ್ಲ, ಅದು ಅನುಭವ. ಅದೊಂದು ಅಪಾರ ಕಾಳಜಿ. ಜೊತೆಗೆ ಆಯುರ್ವೇದ ಏನಾದರೂ ಎಲ್ಲಾದರೂ ಇದ್ದದ್ದ ಆದ್ರೆ ಅದು ಪುಸ್ತಕದಲ್ಲಿಕ್ಕಿಂತ ಕೊನೆ ಕೊಂಡಿಯಾಗಿರುವಂತಹ ನಮ್ಮ ಹಳ್ಳಿಯೊಳಗಿರ್ತಕ್ಕಂಥ ವೈದ್ಯರಲ್ಲಿ ಆ ವಿದ್ಯೆ ಇದೆ. ಆ ಪಾರಂಪರಿಕ ವಿದ್ಯೆಯನ್ನ ತಾವು ಸಂಶೋಧಕರಾಗಿದ್ದುಕೊಂಡು ಆ ಹಳ್ಳಿಗೆ ಹೋಗಿ ಆ ವೈದ್ಯರ ಬಳಿಯಲ್ಲಿ ಚರ್ಚಿಸಿ ಆ ಏನು ಮಾಡ್ತಾರಂತಕ್ಕಂಥದ್ದನ್ನು ಕೇಳಿ ಅದನ್ನು ತಂದು ಮನುಕುಲಕ್ಕೆ ಒಳ್ಳೆಯ ಮಾಡುವಂಥ ಗುರುತರ ಜವಾಬ್ದಾರಿ ಮೇಲಿದೆ ಅಂತಕ್ಕಂಥ ಸಂದೇಶ ಬಹಳ ಬಹಳ ಅರ್ಥಪೂರ್ಣವಾದಂಥದ್ದು ಮತ್ತು ಸ್ಪರ್ಧಾತ್ಮಕವಾಗಿದ್ದು ಮತ್ತು ಬಹಳ ನಮಗೆ ಕೊಟ್ಟಿರ್ತಕ್ಕಂಥ ಒಳ್ಳೆಯ ಸಂದೇಶ. ಆದ್ದರಿಂದ ಎಲ್ಲ ಯುವ ವಿಜ್ಞಾನಿಗಳು ಬಂದಿದ್ದಾರೆ. ನೀವು ಸುಮಾರು ಒಂದು 60-70 ಎಲ್ಲ PG ಸ್ಕಾಲರ್ PhD ಬಂದಿದೆ. ನಾನು ಭಾಳ ಖುಷಿಯಾಗುತ್ತೆ. ಯಾಕಂದ್ರೆ ಇವತ್ತು ಕಾನ್ಫರೆನ್ಸ್ ಹೋದ ಕಡಿಮೆ ಆದ ಅಂಥ ಪರಿಸ್ಥಿತಿಯೊಳಗೆ ನೀವು ಬೇರೆ ಬೇರೆ ಕಾಲೇಜಿಂದ 60-70 ಜನ ಬಂದಿದ್ದಾರಲ್ಲ, ನೀವೆಲ್ಲ ಇದು ಚಾಲೆಂಜ್ ಆಗಿ ತಗೋಬೇಕು. ನಿಮ್ಮೂರ ಹಳ್ಳಿಯೊಳಗೆ ಯಾರಾದ್ರೂ ಆಯುರ್ವೇದ ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡ್ತಾರೋ ಹೆಂಗೋ, ಆ ಪಕ್ಕದಲ್ಲಿ ಯಾರಾದ್ರೂ ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡ್ತಾರೋ ಹೆಂಗೆ, ಏನು ಕೊಡ್ತಾರ, ಎಷ್ಟು ಕೊಡ್ತಾರ, ಎದಕ್ಕೆ ಕೊಡ್ತಾರ ಅನ್ನೋದ್ರ ಬಗ್ಗೆ ತಾವು ವಿಶೇಷ ಒಂದು ಕಾಳಜಿಯನ್ನು ವಹಿಸ್ಬೇಕು. ಇಲ್ಲಿ 2 ಸಂದರ್ಭಗಳು ಬರ್ತಾವೆ. ಯಾವ ಪಾರಂಪರ್ಯ ತನ್ನ ಜ್ಞಾನವನ್ನು ಬಿಟ್ಟುಕೊಳ್ಳಿಕ್ಕೆ ಇಚ್ಛೆಪಡಲ್ಲ. ಹಾಗಾಗಿ ನಮ್ಮ ಆಯುರ್ವೇದ ಇವತ್ತು ಹಿಂದೆ ಬಿದ್ದಿದೆ. ನನ್ನ ವಿದ್ಯೆಯನ್ನು ಕೊಟ್ಬಿಟ್ರೆ ಅವ ನನ್ನ ಮುಂದೆ ದವಾಖಾನೆ ಹಾಕಿದ್ರೆ ಹೆಂಗ, ನಾವು ಮಾಡ್ತಕ್ಕಂಥ ರೋಗಿಗಳನ್ನ ನಾವು ಔಷಧ ಕೊಟ್ಟು ಹೆಂಗ ಅಂತ ಐತಿ. ಅದರಿಂದ ನೀವು ನೇರವಾಗಿ ಅವನ ನೀವೇನು ಕೊಡ್ತೀರಿ ಅಂತ ಕೇಳೋದಕ್ಕಿಂತ ಅವನ ಸೇವಕನಾಗಿ, ಆಯುರ್ವೇದ ವಿದ್ಯೆ ಹಂಗೆ ಬರಲ್ಲದು, ಒಬ್ಬ ವೈದ್ಯನ ಸೇವಕನಾಗಿ ಕರಕಮಲ ಸಂಜಾತನಾಗಿ ಅವ ಹೇಳ್ತಕ್ಕಂಥ ಕೆಲಸಗಳನ್ನು ಒಬ್ಬ ಸಾಮಾನ್ಯ ಮನುಷ್ಯನಾಗಿ ಮಾಡ್ತಾ ಹೋದಂಗೆಲ್ಲ ಇವನಲ್ಲಿ ಬಹಳ ಆಸಕ್ತಿ ಇದೆ, ಈಗಿನಾದ್ರೂ ವಿದ್ಯೆ ಕೊಡಬೇಕು ಅನ್ನೋಂತಹ ಒಂದು ಮನೋಭಾವ ಬರ್ತದೆ. ಆ ಮೂಲಕವಾಗಿ ನಾವು ಪಡಿಬೇಕೆ ಹೊರತಾಗಿ ಹೋದ ತಕ್ಷಣ ಹೋಗಿ ರೊಕ್ಕ ಕೊಟ್ಟು ಅಂಗಡಿಯಾಗ ಮಾಲ್ ತಗೊಂಡಂಗೆ ಅಲ್ಲದು. ಆಯುರ್ವೇದ ವಿದ್ಯೆಯಲ್ಲಿ ಪಡಿಬೇಕಂದ್ರೆ 3-6 ತಿಂಗಳು 6 ತಿಂಗಳು ವರ್ಷ ಹೊತ್ತು ಆ ಸೇವೆ ಯಾವ ಪಂಡಿತರಿರ್ತಾರ, ಆ ಪಂಡಿತರಲ್ಲಿ ನೀವು ಸೇವೆ ಮಾಡಿದ್ರೆ ಮಾತ್ರ ಆ ವಿದ್ಯೆ ಬರೋಂಥ ಹೊರತಾಗಿ ಅದು ಸಾಧ್ಯ ಇಲ್ಲ. ಅದು ನಾನು ಕಂಡಂಥ ಅನುಭವ. ನಾನು ಕೂಡ ಸಾಕಷ್ಟು ವೈದ್ಯರು 1 ತಾಸಿಗೆ 2 ತಾಸಿಗೆ ಯಾವ ವೈದ್ಯರು ತಮ್ಮ ಅನುಭವಗಳನ್ನು ಹಂಚಿಕೊಳ್ಳಲ್ಲ. ಅವ್ರು ಹೇಳಿದಂಗೆ ನಾನು ಸಾಕಷ್ಟು ಹಳ್ಳಿಗಳಿಗೆ ಹೋಗಿದ್ದೇನೆ. ಆದ್ರೆ ಯಾರು ನಾವು ಅವರ ವಿಧೇಯರಾಗಿ ಅವ್ರಿಗೆ ವಿಶ್ವಾಸದವರು ನಾವು ಬೀರ್ತಪ್ಪ ಅಂದ್ರೆ ಇನ್ನೂ ಬೇಕಾಗಿಲ್ಲ, ಅವ್ರು ಹೇಳೋದು ಬೇಕಾಗಿಲ್ಲ, ಅವ್ರು ಏನು ಮಾಡ್ತಾರೆ ನೋಡಿದ್ರೆ ಅದು ನಮಗೆ ವೈದ್ಯ ಆಗ್ತದೆ. ಆ ಕಾರಣಕ್ಕಾಗಿ ಪಾರಂಪರಿಕ ವೈದ್ಯ ವಿದ್ಯೆಯನ್ನು ಅದು ಇವತ್ತು ಅಳಿವಿನ ಅಂಚಿನೊಳಗದ. ಇವತ್ತು ನಮ್ಮ ಚೆನ್ನೈನವ್ರ ವಯಸ್ಸವ್ರು 70 ವರ್ಷ 80 ವರ್ಷ 90 ವರ್ಷ ಇರ್ತಕ್ಕಂಥ ಮುದುಕರಲ್ಲಿ ಮಾತ್ರ ಆ ವಿದ್ಯೆ ಅದ. ಯುವಕರಲ್ಲಿ ಆ ವಿದ್ಯೆ ಇಲ್ಲ. ಆ ವಿದ್ಯೆಯನ್ನು ಉಳಿಸೋದು ಬೆಳೆಸೋದು ನಮ್ಮ ಗುರುತರವಾದ ಜವಾಬ್ದಾರಿ ಇದೆ ಅಂತಕ್ಕಂಥದ್ದು ಭಾಳ ಸತ್ಯ ಐತಿ. ಅದನ್ನು ನಾವೆಲ್ಲ ಸ್ಪರ್ಧಾತ್ಮಕತೆ ಇದ್ಕೊಂಡು ಅದನ್ನು ಪ್ರಯತ್ನ ಮಾಡಿ ಅದನ್ನು ಉಳಿಸೋ ಪ್ರಯತ್ನ ಮಾಡತಕ್ಕಂಥ ಮಾತನ್ನು ಈ ಸಂದರ್ಭದಲ್ಲಿ ಹೇಳ್ತೇನೆ. ಅವರಿಗೂ ಕೂಡ ಅಭಿನಂದನೆ ಸಲ್ಲಿಸ್ತೇನೆ. ಅವರು ಹೇಳಿದ್ರು ತಮ್ಮ ಅನುಭವವನ್ನು ಏನಂತ, ಅವರು ಕೇವಲ ಅವ್ರನ್ನ ಯಾಕೆ ಗೆಸ್ಟ್ ಮಾಡಿದ್ರು ಅಂದ್ರೆ ಪತ್ರಿಕೆ ಸಂಪಾದಕರಂತಲ್ಲ, ಅವ್ರು ಮಾಡ್ತಕ್ಕಂಥ ಕೆಲಸ ಮಾಡ್ತಕ್ಕಂಥ ರಂಗಗಳೇ ಅನೇಕ. ಕೈಗಾರಿಕೆ, ವಾಣಿಜ್ಯ, ರಾಜಕೀಯ, 1-2 ಎಲ್ಲ ವಿದ್ಯೆ, ಎಲ್ಲ ಅವರಿಗೆ ಅವ್ರ ಜ್ಞಾನ ಐತೆ, ಎಲ್ಲ ಈ ಪ್ರಪಂಚ ಜ್ಞಾನ ಐತೆ. ಅದಕ್ಕಿಂತ ಹೆಚ್ಚು ಜ್ಞಾನ ಅವ್ರಿಗಿರೋದು ಆಯುರ್ವೇದೀಯ ವನಸ್ಪತಿಗಳನ್ನು ಕಲ್ಟಿವೇಟ್ ಮಾಡ್ತಕ್ಕಂಥ ಮತ್ತು ಅವುಗಳನ್ನು ಕ್ರೋಢೀಕರಿಸಿ ಅವನ್ನ ಎಕ್ಸ್ಪೋರ್ಟ್ ಮಾಡ್ತಕ್ಕಂಥ ಬಹುದೊಡ್ಡ ಜ್ಞಾನ ನಮ್ಮ ಮಂಜುನಾಥ ಹಿರಿಯರಿಗೆ. ಅವರ ಮಗ ನಮ್ಮ ಆತ್ಮೀಯ ಸ್ನೇಹಿತರು ಅವರು ಅನೇಕ ವನಸ್ಪತಿಗಳನ್ನ ಬೆಳೆಸಿ ಅವುಗಳನ್ನು ಪ್ರಪಂಚಕ್ಕೆ ಪೂರೈಕೆ ಮಾಡ್ತಕ್ಕಂಥ ಪ್ರಮುಖರಲ್ಲಿ ಅವರೊಬ್ಬರು ಕೂಡ. ಅದ್ರ ಜೊತೆಗೆ ಅವ್ರು ಹೇಳಿದ್ರಲ್ಲ, ಅಭಿಮಾನದಿಂದ ಆಯುರ್ವೇದ ಚಿಕಿತ್ಸೆಗಾಗಿ ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯಕ್ಕೆ ಸಾಕಷ್ಟು ಸಾರಿ ಬರ್ತಾರೆ. ಗಂಡ, ಹೆಂಡತಿ, ಮಕ್ಕಳು, ಮೊಮ್ಮಕ್ಕಳೆಲ್ಲ ಕರ್ಕೊಂಡು. ಇಂಥವ್ರು ಇವತ್ತು ಸಿಗೋದು ಅಪರೂಪ ಇದೆ. ಆದ್ದರಿಂದ ಅಂತಹ ಒಂದು ವಿಶಿಷ್ಟವಾಗಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ರಂಗಗಳಲ್ಲಿ ಪ್ರಸಿದ್ಧಿ ಪಡ್ತಕ್ಕಂಥ ವ್ಯಕ್ತಿಗಳು ಇವತ್ತು ಆಯುರ್ವೇದ ಚಿಕಿತ್ಸೆಗೆ ಬರೋದ್ರಿಂದ ಆಯುರ್ವೇದಿಯರಾಗಿರ್ತಕ್ಕಂಥ ನಮಗೆ ಬಹುದೊಡ್ಡ ಜವಾಬ್ದಾರಿ ಇದೆ. ಬಂದಂಥ ವ್ಯಕ್ತಿಗೆ ನಾವು ಅವ್ರಿಗೆ ಹಿತವಾದ ಅವ್ರಿಗೆ ಸರಿಯಾಗುವಂತಹ ಟ್ರೀಟ್ಮೆಂಟನ್ನು ಕೊಡಬೇಕಾದದ್ದು. ಒಂದು ವೇಳೆ ಅದನ್ನು ಕೊಡೋಕ್ಕಾಗದೆ ಹೋದ್ರೆ ಮತ್ತೊಬ್ಬರ ಅನುಭವಿಕರನ್ನ ಕೇಳಿಕೊಡ್ತಕ್ಕಂಥದ್ದು. ಬಟ್ ಅವರು ಡಿಸಪಾಯಿಂಟ್ ಆಗಿ ಹೋಗಲಾರ್ದಂಗೆ ಆ ವ್ಯಕ್ತಿಯನ್ನ, ಆ ಒಂದು ರೋಗಿಯನ್ನು ನಾವು ಹಿಡಿದು ಅದ್ರ ಜೊತೆಗೆ ಚಿಕಿತ್ಸೆ ಮಾಡೋದ್ರ ಮೂಲಕವಾಗಿ ಯಶಸ್ಸನ್ನು ಪಡಿಬೇಕಾದದ್ದು ನಮ್ಮೆಲ್ಲರ ಜವಾಬ್ದಾರಿ ಇರ್ತಕ್ಕಂಥ ಮಾತನ್ನು ಈ ಸಂದರ್ಭದಲ್ಲಿ ಹೇಳಿ ಅವರು ತಮ್ಮ ಕಾರ್ಯಕ್ರಮ ಮಧ್ಯದಲ್ಲಿ ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯಕ್ಕೆ ಬಂದು ಒಪ್ಕೊಂಡು ಒಂದೇ ಒಪ್ಕೊಂಡು ಬಂದು ಕಾರ್ಯಕ್ರಮ ಉದ್ಘಾಟಿಸಿದ್ದಕ್ಕೆ ಬಹಳ ಸಂತೋಷ ಆಗಿದೆ. ತಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ, ಸಂಸ್ಥೆಯ ಪರವಾಗಿ ಅವರಿಗೆ ತುಂಬ ಹೃದಯದ ಕೃತಜ್ಞತೆ ಸಲ್ಲಿಸ್ತೇನೆ. ಆದ್ಮೇಲೆ ಇವತ್ತು ಮಾರ್ನಿಂಗ್ ಈಗಾಗಲೇ ಒಂದು ತಾಸು 15 ನಿಮಿಷವರೆಗೆ ರಮಣಿ ಮೇಡಮ್ ಅವರು ಬಹಳ ವಿಸ್ತೃತವಾಗಿರ್ತಕ್ಕಂಥ ವೆರೈಟಿ ಆಫ್ ಕ್ಯಾನ್ಸರ್ಸ್ಗಳ ಒಂದು ಅಧ್ಯಯನ ಡಯಾಗ್ನೋಸ್ ಹೇಗಾಗ್ತದೆ ಅನ್ನೋ ಬಗ್ಗೆ ಸ್ಲೈಡ್ ಶೋ ಮುಖಾಂತರ ಕೇಳಿದ್ದೀನಿ. ಆಮೇಲೆ ಅದರ ಸಂಪಾದ ಜ್ಞಾನ ಪಡೆದಿದ್ದೀನಿ. ಅವರು ಕೂಡ ಇವತ್ತು ತಮ್ಮ ಕಾರ್ಯಭಾಗದ ಮಧ್ಯದಲ್ಲಿ ಸಹಿತ ಬಂದು ತಮ್ಮ ಅನುಭವ ಹಂಚಿಕೊಂಡಿದ್ದಕ್ಕೆ ಅವರಿಗೂ ಕೂಡ ಸಂಸ್ಥೆ ಪರವಾಗಿ ಅಭಿನಂದನೆ ಸಲ್ಲಿಸ್ತೇನೆ. ಇನ್ನು ಬರುವ ಈಗ ನೆಕ್ಸ್ಟ್ ಈ ಸೆಷನ್ ಮುಗಿದ ತಕ್ಷಣ ಮುನಿಯಾರ್ ಆಯುರ್ವೇದಿಕ್ ಕಾಲೇಜಿನ ಪ್ರಾಂಶುಪಾಲರು ಸಂಶೋಧಕರು ಆಗಿರ್ತಕ್ಕಂಥ ಪ್ರೊಫೆಸರ್ ಸತ್ಯನಾರಾಯಣ್ ಭಟ್ ಅವರು ನಾವು ಹೆಂಗೆ ಇಲ್ಲಿ ನಮ್ಮ ಕಾಲೇಜ್ ಪ್ಯಾರಲೈಸಿಸ್ಗೆ ನರರೋಗಗಳಿಗೆ ಹೆಂಗೆ ಫೇಮಸ್ ಅದ, ಆ ಮುನಿಯಾರ್ ಆಯುರ್ವೇದಿಕ್ ಕಾಲೇಜ್ ಕ್ಯಾನ್ಸರ್ಗೆ ಫೇಮಸ್ ಅದ. ಕ್ಯಾನ್ಸರ್ ರೋಗಗಳು ಹುಡುಕೊಂಡು ಅವ್ರ ಕಡೆ ಹೋಗ್ತಾವ. ಸೊ ನೂರಾರು ಸಾವಿರಾರು ಕ್ಯಾನ್ಸರ್ ರೋಗಗಳಿಗೆ ಆಯುರ್ವೇದಿಕ್ ಚಿಕಿತ್ಸೆ ಕೊಡೋದ್ರ ಮೂಲಕವಾಗಿ ಅನೇಕ ರೋಗಗಳನ್ನ ನಾವು ಮಾಡ್ರ. ನಮ್ಮ ಕರ್ನಾಟಕದಲ್ಲಿ ಕೆಲವು ಬೆರಳೆಣಿಕೆಯೊಳಗೆ ಈ ಕ್ಯಾನ್ಸರ್ ಚಿಕಿತ್ಸೆ ಮಾಡುವಂತಹ ಪ್ರಮುಖರಲ್ಲಿ ಸತ್ಯನಾರಾಯಣ್ ಭಟ್ ಅವರು ಕೂಡ ತಮ್ಮ ಅನುಭವಗಳನ್ನ ಅದರ ಜೊತೆ ಹಂಚಿಕೊಂಡಿದ್ದಾರೆ. ತಾವು ಯಾರಾದ್ರು ಡೌಟ್ಸ್ ಇದ್ರೆ ಆಫ್ಟರ್ ಈಗ ಸೆಷನ್ ಅವರ್ಸ್ ನೀವು ಅವ್ರ ಜೊತೆ ಡಿಸ್ಕಸ್ ಮಾಡಿ ನಿಮ್ಮ ಅವರಿಂದ ನಿಮ್ಮ ಸಲಹೆ ಸೂಚನೆಗಳನ್ನು ಪಡೆದುಕೊಂಡು ತಾವು ಕೂಡ ಈ ಒಂದು ಟ್ರೀಟ್ಮೆಂಟ್ ಏರಿಯಾವನ್ನು ಆಯ್ಕೆ ಮಾಡ್ಕೋಬೇಕಂತಕ್ಕಂಥ ಮಾತನ್ನು ಹೇಳ್ತೀನಿ. ಅವರಿಗೂ ಕೂಡ ಸಂಸ್ಥೆಯ ಪರವಾಗಿ ನಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ತುಂಬ ಹೃದಯದ ಸಲ್ಲಿಸ್ತೇನೆ. ಆದ್ಮೇಲೆ ಇವತ್ತು ಮಧ್ಯಾಹ್ನದ ಡಾಕ್ಟರ್ ಪ್ರಶಾಂತ್ ಎಸ್ ಹುಬ್ಬಳ್ಳಿಯಿಂದ ಬರ್ತಾರ. ಅವರು ಕೂಡ ಸಾಕಷ್ಟು ಪ್ರಾತ್ಯಕ್ಷಿಕ ಅನುಭವ ಹೊಂದವರು. ಅವರ ಅನುಭವನ ಕೇಳ್ರಿ. ನಾನು ಒಂದು ಮಾತು ನಿಮ್ಮ ಯುವ ವಿಜ್ಞಾನಿಗಳು ಹೇಳಲಿಕ್ಕೆ ಇಚ್ಛೆಪಡ್ತೇನೆ. ಆಯುರ್ವೇದವನ್ನು ಯಾರು ಬೆಳೆಸಕ್ಕೆ ಯಾರು ಬರಲ್ಲ, ನಾವು ಬೆಳೆಸಬೇಕು. ಇಟ್ ಇಸ್ ಆಲ್ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟೀಸ್. It is a type of relay. 5,000 years ago, our ancestors, they brought it to new era or modern era. It is the responsibility of all the faculties and the students and PG scholars, researchers. We have to carry this stick of relay to the next generation by having the skilled modern knowledge along with appropriate applications. Then only the modern science excels. There are so many areas. ಒಂದು ಕಡೆ ಒಂದು ಮಾತನ್ನು ಹಗಲಲ್ಲಿ ನಾನು ಹೇಳಿರ್ತೇನೆ. ಪಂಡಿತ್ ತಾರಾನಾಥರವರ ಬಳಿಗೆ ನಮ್ಮ ಗದಗಿನ ನೀಗಲ ಯೋಗಿ ಪತ್ರಿಕೆಯ ಕೌತಾಳ ವಿರಕ್ನವರು ಹೋದಾಗ ಮಾತೇನೇ ಮಾತಾಡಿದ್ರು. ಆಯುರ್ವೇದ ಹೆಂಗೆ ಇದು ಪರಿಸ್ಥಿತಿ, ಮುಂದೆ ಹೆಂಗೆ ಬೆಳಿಲಿಕ್ಕೋ ಇಲ್ಲೋ ಎಲ್ಲ ಕುಂಠಿತ ಹಾಕೊಂಡು ಹೊಂಟು, ಯಾರು ಜನ ಆಯುರ್ವೇದ ಬರ್ತಿಲ್ಲ. ಅವಾಗ ಪಂಡಿತ್ ತಾರಾನಾಥವ್ರು ಭಾಷಣ ಏನಂತ, ಎಲ್ಲಿ ಅಲೋಪತಿ ನಿಲ್ಲುತ್ತದೆಯೋ ಅಲ್ಲಿಂದ ಆಯುರ್ವೇದ ಪ್ರಾರಂಭವಾಗುತ್ತದೆ ಅನ್ನುವಂಥ ಮಾತನ್ನು ಅವ್ರು ಹೇಳ್ತಾರೆ. ಅದು ಇವತ್ತು ಸತ್ಯದ. ಇವತ್ತು ಎಲ್ಲಿ ಅಲೋಪತಿ ನಿಂತದ ಅಲ್ಲಿಂದ ಆಯುರ್ವೇದವನ್ನು ಪ್ರಾರಂಭ ಮಾಡಬೇಕಾದದ್ದು ನಮ್ಮೆಲ್ಲ ಜವಾಬ್ದಾರಿ ಇದೆ. ಇವತ್ತು ಅನೇಕ ಕಡೆ ಕ್ಯಾನ್ಸರ್ಗಳಿಗಾಗಲಿ, ರಿನಲ್ ಫೇಲ್ಯೂರ್ಗಾಗಲಿ, ಅನೇಕ ಮೆಟಬಾಲಿಕ್ ಡಿಸಾರ್ಡರ್ದಲ್ಲಿ ದೇರ್ ಆರ್ ಸೋ ಮೆನಿ ಲ್ಯಾಕಿನೆಸ್ ಅಥವಾ ಅದರಲ್ಲಿ ಉತ್ತರಗಳಿಲ್ಲ. ಆ ಉತ್ತರಗಳನ್ನು ಕಂಡುಹಿಡಲಿಕ್ಕೆ ಅಂತ ಆ ಪ್ರದೇಶಗಳನ್ನು ಆಯ್ಕೆ ಮಾಡಿಕೊಂಡು ನಾವು ಅದನ್ನು ಚಾಲೆಂಜ್ ಆಗಿ ಸ್ವೀಕಾರ ಮಾಡ್ತಾ ಹೋದಂಗೆಲ್ಲ ಅದು ನಮಗೆ ಹೆಚ್ಚೆಚ್ಚು ನಾಲೆಜ್ ಬರ್ತಾ ಹೋಗ್ತದೆ. ಯುವ ವಿಜ್ಞಾನಿಗಳು ಇಂಥವುಗಳನ್ನು ನಾವು ಆಯ್ಕೆ ಮಾಡ್ಕೋಬೇಕು. ಯಾವುದೇ ಆಯುರ್ವೇದ ನಾವೊಂದು ಲಾಸ್ಟ್ ಕಿವಿ ಮಾತನ್ನು ಹೇಳಕ್ಕೆ ಇಚ್ಛೆಪಡ್ತೇನೆ. ಆಯುರ್ವೇದ ಔಷಧಿ ಅಥವಾ ಚಿಕಿತ್ಸಾ ಪದ್ಧತಿ ಅಥವಾ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಅಂತಂದ್ರೆ ಇದು 1-2 ದಿನದಲ್ಲಿ ತಿಳಿಯುವಂಥದ್ದಲ್ಲ, 2 ವರ್ಷದಲ್ಲಿ ತಿಳಿಯುವಂಥದ್ದಲ್ಲ. 6 ವರ್ಷಗಳವರೆಗೆ ನಾವು ಆ ಸಂಶೋಧನಾ ಮನೋಭಾವದಲ್ಲಿ ಕೆಲಸ ಮಾಡ್ತಾ ಹೋದಂಗೆಲ್ಲ ಅದರಲ್ಲಿ ಒಂದಿಷ್ಟು ಸಿಗ್ತದೆ. ಅದರಿಂದ ವೈದ್ಯಕೀಯ ಜ್ಞಾನ ಅಂತಕ್ಕಂಥದ್ದು ಇದು ಸಮುದ್ರದಲ್ಲಿ ಈಜಿದ ಹಾಗೆ. ನೀವು ದಂಡೆಯೊಳಗೆ ಈಜಿದ್ರೆ ನಿಮ್ಗೆ ಕಪ್ಪಿ ಚಿಪ್ ಸಿಗ್ತದೆ, ಸಮುದ್ರ ಮಧ್ಯದಲ್ಲಿ ಹೋಗಿ ಈಜಿದ್ರೆ ನಿಮ್ಗೆ ಮೂತ್ರತ್ವಗಳು ಸಿಗ್ತಾವ. ಹಂಗೆ ಆಯುರ್ವೇದದಲ್ಲಿ ಸಹಿತ ಬಹಳ ಕಷ್ಟಪಟ್ಟು ಈ ಸಂಶೋಧನೆ ಮಾಡುವ ಮೂಲಕವಾಗಿ ಈ ಮನುಕುಲಕ್ಕೆ, ಸೈನ್ಸಿಗೆ ತಮ್ಮೆಲ್ಲರ ಕೊಡುಗೆ ಅಪಾರವಾಗಿರ್ತಕ್ಕಂಥ ಮಾತನ್ನು ಈ ಸಂದರ್ಭದಲ್ಲಿ ಹೇಳಿ, ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯದ ಎಲ್ಲ ಕಾರ್ಯಕ್ರಮಗಳು ಸದಾ ನಮ್ಗೆ ಬೆನ್ನೆಲುಬಾಗಿ ಅಕಾಡೆಮಿಕ್ ಕಾರ್ಯದಲ್ಲಿ ನಮಗೆ ಸ್ಫೂರ್ತಿ ಕೊಟ್ಟಿರ್ತಕ್ಕಂಥ ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯದ ನಿವೃತ್ತ ಪ್ರಾಂಶುಪಾಲರಾದ ಡಾಕ್ಟರ್ ಜಿ ಬಿ ಪಾಟೀಲ್ ಅವರು, ಅವರಿಗೂ ಕೂಡ ತುಂಬ ಸಲ್ಲಿಸ್ತೇನೆ. ಕೊನೆಯದಾಗಿ ನಾನು ಸಾಕಷ್ಟು ನಮ್ಮ ಎಲ್ಲ ಅಧ್ಯಾಪಕ ಬಂಧುಗಳಿಗೆ ಹೇಳ್ತಿರ್ತೇನೆ, ಏನಾದರೂ ಆಕ್ಟಿವೇಶನ್ ಮಾಡಿರಿ, ಏನಾದರೂ ಇನ್ಸ್ಪಿರೇಷನ್ ಕಾರ್ಯಕ್ರಮಗಳನ್ನು ಮಾಡಿರಿ ಅಂದ್ಕೊಂಡಿರಿ. ಹಾಗಾಗಿ ಒಂದೊಂದು PG ಡಿಪಾರ್ಟ್ಮೆಂಟಿಂದ ಒಂದೊಂದು CME ನ್ಯಾಷನಲ್ ಸೆಮಿನಾರ್ಗಳು ಮಾಡಿರ್ತೇವೆ. ಅದನ್ನು ಕಾಯ ಚಿಕಿತ್ಸಾ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಅದು ಸ್ಫೋಟೋ ಆಗಿ ತೆಗೆದುಕೊಂಡ್ರು ಕ್ಯಾನ್ಸರ್ ಮೇಲೆ ನಾವು ಮಾಡಬೇಕಂತಕ್ಕಂಥದ್ದು. ಜೊತೆಗೆ ಯುವ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಪ್ರೋತ್ಸಾಹ ಕೊಡಬೇಕಂತ ವಿಚಾರ ಬಂದಾಗ ಡಾಕ್ಟರ್ ಸಂತೋಷ್ ಬೆಳವಡಿ, ಡಾಕ್ಟರ್ RV ಶೆಟ್ಟರ್, ಡಾಕ್ಟರ್ ಯಾಸ್ಮಿನ್ ಪಣಿಬಲ್, ಡಾಕ್ಟರ್ ರಜನಿ ಅವರೆಲ್ಲ ಕಳೆದ 1 ತಿಂಗಳಿಂದ ಒಂದು ಚಾರ್ಟ್ಔಟ್ ಮಾಡಿ ಇದಕ್ಕೊಂದು ಮೂರ್ತ ಸ್ವರೂಪ ಕೊಟ್ಟು ಬಹಳ ಕಾಲೇಜ್ ನಾವು ಕರೆದಿಲ್ಲ, ಲಿಮಿಟೆಡ್ ಕಾಲೇಜ್ ಕರೆದಿ ಎಲ್ಲರೂ ಬಂದಿದ್ದಾರೆ. ಅದು ಬಹಳ ಖುಷಿ ಕೊಡುವಂಥದ್ದು. ಹೀಗೆ ತಮ್ಮ ಒಂದು ಪ್ರಯತ್ನ ಕಾರ್ಯಕ್ರಮ ಯಶಸ್ವಿಗೊಳ್ಳುವಲ್ಲಿ ಎಲ್ಲ ವಿಭಾಗದ ಅಧ್ಯಾಪಕರುಗಳಿಗೆ ತಮಗೆ ವಿಶೇಷವಾಗಿ ಡಾಕ್ಟರ್ JS ಅವರಿಗೆ, ಚೆನ್ನೈನವರಿಗೆ ಆಗಮಿಸಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ಆಮಂತ್ರಿತರಿಗೆ ಮತ್ತೊಮ್ಮೆ ವಂದನೆ ಸಲ್ಲಿಸಿ ನನ್ನ ಮಾತನ್ನು ಮುಗಿಸಿ ನಮಸ್ಕಾರ.
Thank you, sir, for your presidential speech. It is an essential aspect of of our culture to express our gratitude towards the people who joined and become a part of this event, making it grand success. Now, I would like to call upon Dr. Veena Kori ma'am for vote of thanks.
Good afternoon, everybody. So I am very much thankful to all the dignitaries of the desk, on the desk, after desk, respected staff members and delegates for making this Onco Veda a grand success. Thank you.
Thank you, ma'am. Now, next, I hand over session to Dr. Pallavi to conduct scientific sessions.
would like to welcome you all for the second scientific session by Dr. Satyanarayan Bhatt sir on the topic Application of Multidimensional Ayurvedic Treatment in the Management of Cancer with special reference to Rasaushadhi, a clinical experiences. It gives immense pleasure to introduce Dr. Satyanarayan Bhatt sir. Sir completed his BAMS degree from SGM College of Ayurveda, Udupi, and completed his MD in Vaishajya Kalpana from IPGT and RA, Gujarat Ayurveda University, Jamnagar. Sir is in design and development of Ayurvedic formulations, quality control of Ayurvedic medicines, research on single herbs and herbo-mineral preparations, clinical research in Munyar Ayurveda Hospital under various Chikitsa Kalpas. Sir has guided many PG dissertations and also recognized as PhD guide. Sir was resource person at many national and international conferences, presented papers at national and international conferences. Sir has published articles at international journals. Presently, Sir is working as Principal and Director, Research and Development at Munyar Institute of Ayurveda Medical Sciences, Manipal. Now I request Dr. S.N. Pedvadi Sir, HOD, Professor, Department of Kaya Chikitsa to present bouquet. Thank you, sir. Now I would request Satyanarayan Bhatt sir to continue the session.
शंखं चक्रं जलौकां दशदमृतघटं चारदोद्रिश्चतुर्भिः सूक्ष्मस्वच्छादिद्यांशकबरविलसन्मौलिमम्भोजनेत्रं कालाम्बोधोज्ज्वलां कटितटविलसच्चारुगीताम्बराढ्यं वन्दे धन्वन्तरिं निखिलगगनप्रौढदावाग्निं. Let us go to Lord Dhanvantari to destroy all our enormities and bestow us in the best of health. Hey everyone, welcome for my presentation. I know that it is a very odd time for me to speak. I hope I will be able to reach you. At the outset, organizers, especially respected principal of the institute, Dr. Ramesh Murad, and especially Dr. Santosh Gadawari for inviting me and giving me an opportunity to address and interact with all of you. It's really a pleasure to have Dr. Shakuntala Muni here, who had already enlightened you with the most important aspect related to cancer. Because we know that early diagnosis in the case of cancer means half the battle won. However, I will be speaking on a totally different aspect. There are so many slides here. I could not trim them out because of the paucity of time. I may be a bit quick on a few of slides. Probably we will get some time at the end to discuss so that any important aspect which I missed out can be addressed at the end. A few cluster slides in the beginning. All of you know that this year's theme for Global Cancer Day was to fill the gap in cancer care. That is the major problem in the entire globe. There are crores of people who need cancer care, but they are not being provided. There will be several reasons for that. Effort has to be started in 2022 to find out the areas of concern. In 2023, where we have to accumulate the people to fight against this, and 2024, it is a responsibility to put pressure on all those who are in the position of governance who can take action. So we are in this particular juncture now. And another biggest point here that we have to speak about is COVID-19 widens screening gap. We have observed this in our institute also for last couple of years. Cancer cases, advanced cancer cases have risen up. One major issue was that cancer patients who were on regular follow-up with an oncologist could not go for a couple of years because of COVID pandemic. A few of them were afraid to go to the hospital. but many of them were denied from coming to the hospital by oncologists themselves. They said that if you feel something alarming or emergency, then only come. Otherwise, you continue the medication at home. But unfortunately, we know that cancer is such a silent disease in many of the occasions that when symptoms become overt, it's already reached to the distant metastasis. And then nothing can be done. Only palliation is the remedy. So many people have suffered because of this. That is why in this particular article, they spoke as COVID-19 avoidance screening gap. This is a statistics which states that around 21% hike or a jump occurred in last decade in new cancer cases, and around 26% mortality also was increased. This was, however, in 10 years, but last couple of years were probably the most dangerous. From 0.1 to 1% was the jump of an average cancer death. IHME reported, which was published in JAMA Journal in December 30th, stating the situation of India's cancer burden. The statement said the growth rates are among the global highest in India, global highest. In 2020, I have the data of 2020 only, around 13,92,179 cases were detected. Before that, if you see, it was around 8 lakh cases per year. A jump is really alarming. So this is a picture which shows you top 10 cancers. Out of these, top 4 are probably more important. I think it is visible. Breast cancer, lip and oral cavity cancer, cervical and lung cancer. Even in our Ayurvedic OPD also we see the same pattern. These 4 top cancers are observed even today. Out of these, when you observe mortality ratio, death rate, we can see that in the case of breast cancer, it's not so much. It may be less than 1%. But if you see here, lung cancer, you can see out of 4.7, 4.4 is in esophagus, out of 5.4, 4.9 is the death in the case of lung cancer, and out of 4.54 is the mortality in stomach cancer. These are some cancers which are highly dreaded. The mortality rate is very high. Be it any system, tackling these conditions have become really challenging. When you see this picture, almost 50%, say around 43.5% cases are of only these 5 conditions: breast cancer, lip oral cavity cancer, cervix, lung cancer, and colorectal cancer. I am not going for the details of this. If you just observe the geographical distribution of cancer, here in northeast, as this is LED screen, I can show the pointer here. Northeast, highest cancer cases are there, and most of them are esophageal cancers, probably because of tobacco and household burning of firewood. In West Bengal, lung cancer and urinary bladder cases are maximum, mainly because of air pollution and water pollution. If you see here in Goa, majority of the cases are colorectal cancer, probably because of eating of red meat, alcohol, and tobacco. If you go to the Punjab, all the types of cancers are more there. I think this particular point has to mainly, however, kidney and urinary cancer and breast cancer are more, but most probably the causative factors are attributed to pollution, pesticides and toxins in food. In all my lectures, I usually repeat this. Food is probably one of the most important causes for cancer. Because nowadays we are seeing young women, 25 to 30 year age, they are coming to our hospital. They do not have any habit of smoking, alcohol or anything. Food toxins. including fruits, which are bombarded with pesticides, which are genotoxic, are probably one of the most important causative factors for cancer. If you see grapes, a bunch of grapes is dipped in very toxic pesticide at least 24 times in its entire lifespan. Whatever you treat it, you wash it, whatever you do it, there is definitely a possibility of remnants of these genotoxic materials that may not cause effect immediately, but definitely it can cause a genetic aberration resulting in various types of cancer. This is what I have observed. I am not commenting on, but I would like to just mention changing pattern of cancer today. We have seen that all stomach cancer, especially cancer of upper part of stomach, they are increasing in incidence. Lung cancer incidences are increasing in metros, probably attributed to pollution. Oral cancers increasing in men. Breast cancer cases are increasing in young 25 years old coming with breast cancer. You don't have to wait the women to reach menopause or whatever. Many cases. More than fibroadenoma, we are observing cancer cases. Then on the other hand, lower stomach cancers are slightly reducing. Very interestingly, cervical cancer cases have come down, probably because of increased awareness. Screening of cervical cancer has become more and more popular nowadays. That may be one of the reasons why this awareness is built up, preventive action are taken, and also early diagnosis is possible. That may be the reason why cervical cancer cases are slightly at a decline. These more statistics I have, I will just skip them. Now what about our system? Ayurveda being our age-old system definitely has a lot to contribute in cancer. Situation was slightly different a few years ago. Whenever a cancer patient approached Ayurveda OPD, people who are not ready to touch, either afraid or lack of knowledge, whatever it is, they were instantaneously being referred to a higher center or an oncologist. It's not so. I'm very sure that many times integrative approach is absolutely. You should have an idea, an awareness about the condition. What Ayurveda can do. Ayurveda can help in any phase of cancer, starting from the early detected stage till having final quality of life or a happy end. In every stage, Ayurveda can help. As I mentioned in my last line here, it may be prophylactic. All of us we talk about this. We speak about ahara vihara, we speak about antioxidant food, we speak about metal chelating food, we speak about rasayanas, genoprotectives, many things we talk about as prophylactic. Palliative. There are many advanced stage cancers where only palliation is possible. Ayurveda can help a lot in palliation. It has narrow range cases, even curative is also possible based on our experience, and supportive. When patient is already on conventional treatment, we have a scope to help them. It may be the chemo preventive, it may be radio protective, it may be improvement in quality of life, it may be symptomatic benefit. There are so many options where Ayurveda can help. So please remember from this point that there is no area of cancer where Ayurveda cannot help. I don't say that you treat every cancer as a first line of treatment from Ayurveda. Whatever may be the case, you can definitely help them in one or the other ways. So your role is always existing, always relevant. You know that many Shalyatantra experts are here. Arbuda is never a vis cancer. Cancer can be any disease condition. It can be Arbuda, it can be Granthi, it can be Asadhya Pandu, it can be Asadhya Kamala, it can be Tridoshita Gulma. So many things where cancer may be a manifestation. I'm not going for the details of pathophysiology. I think Dr. A.S. Prashant will explain this elaborately as he is an authority in the field of Ayurveda. My focus would be only on the application of Rasaushadhi and finally a quick experiences that we have gathered in our last 2 decades of treating cancer patients, depending upon the time. This classification I have taken up from a publication of Dr. Prasad, who was a former HOD of Shalyatantra at BHU. Retired long ago. He was a teacher of stalwarts like Dr. Muralidhar Sharma, Dr. Prasanna Rao. He was a guide for them. In a publication probably around 3 decades ago, he tried to classify the cancers based on their presentation under these categories. It may be the diseases which can be labeled as a clear malignancy, or maybe diseases in which most probable consideration of malignancy can be there, need not be cancer always. Sometimes presenting symptoms may be mimicking that of cancer, but many of them may not be cancer. This is how he tried to explain them. Just very quick slides to talk about them. I have just shown a couple of photographs and then I will proceed. The diseases falling under the group which can be definitely considered as malignancy may be certain types of arbuda like Mamsa arbuda, Rakta arbuda, Asadhyavarana or malignant ulcer. Most probable malignancies may be Mamsaja Ushta, Alasa, Mamsa Kachapa, Galaudha, Asadhya Galaganda, Tridosha Jagulma, Asadhyavarana, Lingarsha, etc. Verrucous carcinoma of lip like Mamsaja Ushta, maybe adenomocystic and mycoid epidermoid tumor of salivary gland may be correlated with ulcer. Galaudha can be correlated with CA of oropharynx. Tumor of heart gullet may be correlated with Mamsa Kachapa. Papillary carcinoma of thyroid may be correlated with Asadhya Galaganda. This is the histopathological picture. Tridosha Jagulma may be intra-abdominal tumors, may be primary, as in the case of non-Hodgkin's lymphoma, or maybe secondaries, or carcinoma having metastasis intra-abdominally, peritoneal deposits with ascites or without ascites associated with KHCR and other features. Come under this, as you can see in this picture. Maybe Asadhya Varana, Lingarsha. So my purpose is only to convince you that cancer is never vis-a-vis arbuda. It can be there in any of the clinical conditions. That is why describing a line of treatment based on Ayurvedic principle becomes challenging. Of course, it is the duty of Dr. Prashant Agarwal. Now we will come to the subject proper that we are going to talk about. I am not going to discuss all the formulations. A few I will just highlight because we can talk on individual formulation for hours together. It's a customary for us whenever we speak on Rasaushadhis and their application to praise Rasaushadhi in the beginning. So let us have a couple of slides on them. Probably you can identify a few of these formulations starting from Swarnamanga up to Rasa Sindhura. It is Panchamrita Parvati in between, Shatapati Abhrakavasma, Abhragarva Potali at the top. Rasa Chikitsayam Shresthatvam, we are studying from second BMS itself, just as a reference to by heart. Alpha Madrupa Yogitva Daruchera Prasangata Kshipramaragvidayitva Doshadhi Vyodhikorasa Swalpahi Matra Vipala Gunasha Sadhyutan Deepan Pajanascha. It's very important, even though we just by heart, an excellent bioavailability or bioavailability enhancing property, that is the most important factor that we have to consider. Smaller the dose, quicker the action, better will be the bioavailability, longer shelf life, no problem with palatability. Sadhyohita Deepana Pajanascha, we consider probably all Rasaushadhis themselves by nature as Deepana Pachana. When you add them with any herbal component, naturally their bioavailability is enhanced many times. Hopefully you might have gone through an article on Kajjali. Kajjali is a basic material for us. All Sagantha preparations contain Kajjali, black sulfide of mercury having a cubic HGS structure. it was blended and used along with antitubercular regimen, and it was observed that rifampacin's bioavailability was enhanced by 1.4 to 2.3 times. It may be any drug for that matter, need not be a drug of Ayurvedic origin. It may be a drug of any other system. The bioavailability can be improved with the help of rasoshathi. A phytoconstituent may be there in a very, very small amount, but you will find an exaggerated clinical response. That is what we achieved in the case of all these Moshchana preparations. Even it is out of subject, even in the case of anti-diabetics. So you have the drugs like metformin. When you use certain components from Ayurveda, bioavailability of metformin itself is enhanced. You do not know that. Due to the synergistic effect, person may fall into hyper. So this is how we will have to understand the drug-drug interaction. As Madam is here, that was my intention to specifically point it out. Sometimes we Ayurvedic people, you simply say that you take that, it's that, it's not that. Many of them have an adverse interaction many times. They may have synergistic action also, but you should know. You should have a basic idea about these components, at least to some extent, so that you can have an idea how to space them, how to modify the dose, how to decide the regimen of the therapy. Same thing holds good in the case of cancer management also. Last line by Sharangadhar, asadhyeshu api datavya rasota shreshtam uchyate. So there are conditions where we say that it is pratyakshaya, anyway patient is going to die. Don't touch him. That's not the case. Whatever is the state, it is our responsibility to see that something can be offered to the patient. And this is very important in the case of cancer. In terminal cancer, in Ayurveda, probably more than 80% of cases that are coming to us are stage 3 cases or beyond that, depending upon the type of classification anyway. So many of them are requiring palliative management rather than curative. So there is a statement which many times is wrongly interpreted. Na doshanam, na roganam, na pumsancha parikshana deshasya na kalasya karam rasthikitsite. Don't have to examine anything, just give research. It's not so. Ajikitsa people will be very angry. So this is, of course, this is reference which is quite late. Acharya Gurudeva Mukherjee also has mentioned this in a couple of research mentioned. This is clearly indicating the emergency use of rasaushadhis. Many of Rasa Chikitsakas used to quote their experiences. I remember Dr. Upendra Dikshit quoting once. The patient came to his clinic and collapsed in front of him. His blood pressure was almost not regular. He was in syncope. He had sweating. Patient is not able to give any history. Now you have to treat him. Either hemagarbhapatari or trinetra rasa mixed with adraka sauce and 1 and 2 drops of honey applied on the lips or sublingually. Within minutes, patient got up. Then he had a time to refer the patient because he had MRI. What the next story is different. But where you are going to do dosha dosha vivechana then? This is a beauty of Rasa Shastra where you can definitely make an attempt to try. It simply indicates a specific area of application of Rasa Aushadhi. It is not that while giving Rasa you don't have to check this. You do all the assessment whenever possible and use Rasa Aushadhis accordingly. That is why in all later texts you will find Rasa Panchaka described for Basmas, Maharasa, Parasa, Sadharana Rasa. Only in older texts you do not find them because Rasa Shastra is not basically meant for Ayurveda at all. It is totally different system, just like physics or chemistry. That's a different. So when Chikitsa part came into existence, naturally they have imbibed the principles of Ayurveda also. So if you do not know Rasa, you will be mocked at. That is what the last reference speaks about. 2 points I would like to just mention here. संशोध्य विधिना धातून् उपधातून् विषाण्यपि योजयेत् कर्मणि प्राज्ञो दोष संजायते अन्यथा. In Rasaushadhi, this is something which you have to be very careful. Carry out methodic shodhana of every component, maybe of herbal origin, which is having a known toxicity, Vishadravyas, or maybe of metallic or mineral origin. You know the impact of shodhana is not just detoxification, it has got multiple impact. So this is absolutely essential. Then you do not blame other systems that your drug has caused hepatotoxicity or nephrotoxicity or any other acute toxic effect. That is most probably because of erratic manufacturing. We have seen that in the case of metallic and mineral preparations, with an exception of arsenic, there is no chance of acute toxicity. They may cause acute or chronic toxicity, that is because of cumulative toxicity when you administer the drug for a prolonged period. That is without proper judicial anupana or timing, without having any idea of the course of the regimen, or not preparing properly. Because in our OPDs we simply write repeat 7 days, repeat 7 days, repeat 7 days, Arogyavardhini, 1 year, 2 years. We do not know when the drug has to be stopped, for how many weeks you have to gap it, when you have to restart. So these things many times we neglect. That may be one of the reasons where cumulative toxicity is a possibility. Otherwise it is the culprit herbal drug which can cause acute toxicity. Vatsanava can cause acute toxicity if shodhana is not proper. That can cause acute toxicity if shodhana is not proper. The person may have sudden syncope because of the toxicity. In the case of simple formulations like Mrityunjaya, many such cases we have observed when shodhana is not proper. So that is why in the beginning itself it is mentioned samshodhya vidhina dosha sanjayet anyatha. Another thing which we neglect in the case of Rasaushadhi application is anupana. Anupanai rasayujya deshakalanusaribhi doshagnehi madhuravapi kevalena jalena. Most of the Rasaushadhis are ideally to be administered in the form of powder. I don't know you know or not, there is a practitioner, Dr. Krishna Prakash, in Puttur. He doesn't use any modern tools in his clinical diagnosis or management. He is an ardent follower of this. You know, when you see the formulations in Rasaushadhi, in only a few places you may find reference like Vatin or Butikam Karayet. Otherwise, you do not the preparation of any pill or tablet. That the purpose is dosage precision. When you administer as much as possible, try to powder it, sahapana anupana abhyam, mix it with specific sahapana and anupana and then administer. These sahapana and anupana have their own role to play. They may be acting as targeted drug delivery systems, bioenhancers, cytoprotectives. There are many benefits with them. So adequate effect you will find when you follow proper anupana. However, he has given other choices. If you are not able to use this specific anupana, use doshagna anupana. If that is also not possible, go for madhu at least. Because madhu is yoga considered as best anupana that is available. So these are the background information that I wanted to give. So when I have mentioned Rasaushadhi in cancer, these are the headings. However, Rasaushadhi can expand into various categories. A few of them under which some quick examples, let us have a look. We talk about murchana, nishchitya vyadhikhatakatvam murchana, or avyabhicharita vyadhikhatakatvam murchana. We are processing mercury in such a way that it certainly attains the capability to cure a disease. When you speak about murchana, sagandha, nirgandha, sagni, niragni, all this classification, I have just considered the method-based classification. Kalviya rasayana, parpati, puttali, or upapa rasayana having their own importance. We have lauhas, we have manduras, we have basmas, we have pishtis. Just randomly selected examples I am quoting here. To start with the Kalvia Rasayana, the first example that I am mentioning here is Shiva Gutika, which is an example from Samhitas. Many times you may or may not accept it as a Rasaushati. However, containing Shilajatu as an important ingredient and also having its own application in clinical management of cancer. So I have taken this as an example. Shiva, an ideal dose is about half karsha, practical dose. I'm not talking about classical dose. It may be even 1 karsha also. Many people administer it in a dose of 3 grams. Some people may be administering it in a dose of 1 gram. But what we are using is a single dose of 6 grams, depending upon the location of the disease. I am using this only in a couple of conditions, mainly in transitional cell carcinoma of urinary bladder, RCC, renal cell carcinoma, then a few cases of hepatocellular carcinoma, especially intra-abdominal tumor, because you know that it is indicated in Bastiroga, it is indicated in Gulmachitsa. Among these, my clinical experience is that it had shown considerable result in the case of CA urinary bladder. Pancreatic cancer otherwise is also having probably one of the worst prognosis among all the cancers. In any of the system, if you achieve a life expectancy of 5 years, that is the greatest achievement that you can consider in the case of pancreatic cancer. Mortality rate is extremely high. I used this in pancreatic cancer also. One of the patients I had a survival rate beyond 5 years who had hepatic metastasis. Probably I have a case, I will discuss that later. Vasanta Kusumaka Rasa, the dose mentioned here is around 1 rati. Classical dose is also the same, around 1 rati. Before food, depending upon the condition, you can use separate anupanas, starting from Madhu. There are various other anupanas that are indicated. Rasayana, chemopreventive, supportive care in the case of hepatocellular carcinoma, CA pancreas and renal cell carcinoma. I have used this in 2 types of cases. One is CA pancreas, and many of these cases, depending upon the location of the tumor, we find uncontrollable diabetes also. And also as a supplement in the case of chronic myeloid leukemia. Next is Karpura Rasa. This is only with the theoretic importance because Karpura Rasa is not available now. It is a banned drug as it contains arifena. It is an opium containing drug. Western people can use opioids. They can use morphine with special precautions. Even though it is in our pharmacopoeia for a pretty long time, we are not allowed to use any arifena or its preparations. Well, Bhanga is banned, but quite recently, for last 2 years, there are manufacturing centers who got permission to use cannabis. The cannabis preparations are nowadays licensed and marketed under some special licenses. We have Hemp Street like company which are preparing cannabis preparations, but arifena preparations are not yet allowed. Probably during my PGs, maybe second year PG in 1999 or so, that was the last time when we could use Karpura Rasa. It is an extremely useful drug in the case of intractable diarrhea. Even arifenasa is also indicated for the same, which is mentioned in Rasatarangini. Karpura Rasa is useful in the case of some colorectal carcinoma, where the presentation is C diarrhea with mucus mixed or blood stained stools. In a couple of doses, you can immediately stop it. Only with some theoretical point of view, probably hoping for a better future, I have mentioned this here. Kanaka Sundara Rasa is another formulation. It's to be given in a dose of 2 rati, 250 milligram with dahi, curd or buttermilk. However, it is indicated in Jwarachasara Adhikara, that is why I mentioned that. That is the Adhikara Ratnavali where it is mentioned. Clinically, it is also applied in CS stomach colon. Sorry that I don't have clinical data on use of Kanakasundara Rasa because I do not use it in my clinical practice. Some sporadic information you can get it when you try to Google in combination with other drugs, but I found the combinations very erratic and without scientific basis, so I did not highlight it. But definitely Kanakasundara Rasa is useful in Jwaratisara and Grahani Adhikara also, so it should be having some impact in GIT cancers. Similarly, Sarvanga Sundara Rasa in a dose of 2 Rati with honey before food, that is in Apanakala, in Asriptara or uterine cancer. Features of DUB can be seen in the case of cervical cancer or endometrial cancer. Ovarian cancer may not present in the form of bleeding. In these two conditions, Sarvanga Sundara Rasa is an option. Madhumali Vasanta, 1 Rati with honey after food as a rasayana, as a chemopreventive, as a supportive in lung cancer, especially bronchogenic carcinoma, and also in bone cancer and leukemia. So bone cancer is another most difficult type of cancer to handle. We also had probably more than 10 cases in the last 10 years. Unfortunately, I don't have much clinical success to share in this case. Probably the life expectancy was almost same as it was managed by any modern oncologist. Chaturmukha Rasa, 1 Rati with honey and Triphalachurna as a rasayana, chemopreventive in lung cancer and stomach cancer. Arogyavardhini as a supportive drug in hepatic cancer, hepatocellular, or all types of cancer where there is a metastasis in the liver, and also in the cancer of gallbladder, which is most likely to metastasize in, or in the case of periampullary carcinoma, which also can have metastasis in the liver. Gandhaka Rasayana in skin cancer. I have a patient even today who is a known case of squamous cell carcinoma of skin, a fair-skinned person, a Muslim guy from Bangalore, whom we are treating for almost last 7 years. He had around 4 lesions in his body, and 3 of them are completely vanished. 1 lesion is still there, which is completely gone off, but for last 2 years, a very irregular follow-up because of his family issues. In him, we have used Gandhaka Rasayana as an additional drug with other or regular regimen. I hope you remember that if Gandhaka Rasayana is to be used for Rasayana purpose, our method is totally different. In the references to Gobaisa, Trivaram Tatashchaturjata Gurujika Dipatyata Dakshuk Pingrade Bhavyushtavan Pratagatrikena. Siddhesitam Yode Tulyabhagam Rasayanam Gandhakam Sanjitam Sat, and he says, Karshonmite Sevita Yeti Vartu Vidanti Kushtubalam Vidayuti. 1 Karsha is the clinical dose, 12 grams. You will be given 250 milligrams or 500 milligrams. And in most of these preparations, Sita is not used, except a few pharmacies which prepare Gandhaka Rasayana in the form of a granule or avalega, where you can give it at least in half Karsha dose. So how do you expect Gandhaka Rasayana to act in all the conditions when you are giving it in a subnormal dose and in a different manner? Then the preparation, 88 bhavanas are to be given properly, which is very well proved in an M.Pharma thesis carried out in Jamnagar. How this sequential bhavana one after the other has its own impact in Gandhaka Rasayana. Prepare the drug, give it accordingly, you can do. Swarna Vasanta Malati or Swarna Malini Vasanta. This I have used in cases of leukemia, and also in case of bone cancer. Half to 1 Rati is the classical dose, and you know that Madhu or Madhu and Kana. So these are the Anupanas, both for Lagmalini Vasanta and Swarnamalini Vasanta. Swarnamalini Vasanta is an ideal option in the case of leukemia. All gold preparations, all Swarna containing preparations, they were excellent in the case of blood cancers. It is well established that gold nanoparticles have an apoptotic effect on types of blood cancer. Panchavaktra Rasa is indicated in leukemia and lymphoma. Panchavaktra Rasa is basically indicated in Jwara, to Radhikara. If I am not wrong, probably it is a thesis work of Dr. Krishna Prakash in Navajwara. Same Chaturmukha Rasa, it is a Swarna Kalpa. There are many references of Chaturmukha Rasa, one in Rajakshamadikara, Radhikara, like that, one in Atisaradhikara and so on. This is a Swarna Kalpa. It has to be given with Trikati Churna and Arka Moolatva Kashaya. There are many practitioners who are using Arka Moola as an anti-cancer agent. Many traditional practitioners are using it. I don't know, incidentally, you could find that this particular preparation is effective with Arka Moola Kashaya. I would like to mention here that non-Hodgkin's lymphoma can be handled extremely well with Ayurvedic medication. We have many cases of NHL which have responded very well. Gandamala Kandanarasa, I have not used this much. Of course, in all the cancers related to the papillary gland or wherever lymph node is involved, just like Kanchanara Gugulu, this also can be applied. Lakshmi Vilasa is a supportive drug. Nityananda Rasa in lymphoma, I have used this even in breast cancer. I am not able to say whether it really has played an important role because it was one of the components of the. I don't have a data to say that Nityananda Rasa alone had worked. Definitely it is useful, but there is a problem with Nityananda Rasa because it has cancer. If you are not sure about the quality of the product, don't use it for a prolonged period. It can cause toxicity. Under Parpati, we have Panchamrita Parpati, Sarveshwara Parpati, Rudra Parpati. Sarveshwara Parpati is extremely difficult to prepare. You see, all Maharasa, Uparasa, Sadhana Rasa are there. Of course, we have practitioners like Dr. Gopi Krishna who prepare Sarveshwara Parpati for his own purpose. It becomes extremely expensive and a very elaborative and long process. So there are clinical cases who have responded well, especially oropharyngeal cancer for Sarveshwara Parpati. Rudra Parpati is a very unique Parpati, if you remember, where Karapaka is advised. It is the only Parpati where Churnavat powder is advised. Otherwise, for all Parpati, Karaha, Churna, Vishopama, Tyajya. You just go through Rudra Parpati where powder is expected, and Rudra Parpati is evaluated clinically with not very documented evidence in the case of lung cancer. It is to be given with Brangaraja Rasa and honey. Tridhatu Garbha Pottali is a Pottali, Abhra Garbha Pottali, Heva Pottali, and Lokanath Rasa. Lokanath Rasa is a misnomer as a Pottali. It is prepared Puttagatar, Gaja Puttagatar. All others are prepared by Gandhaka Pakagatar. I have not used too many Pottalis in my clinical practice. I have used Hemagarba Pottali, Apragarba Pottali, Rasagarba Pottali, Tamragarba Pottali, and Pravala Pottali. These 5 I used for 2 patients. I found clinical result only in Hemagarba Pottali. That was in lung cancer and in a patient of non-Hodgkin's lymphoma, where quality of life was improved, life expectancy was better, and both the cases are no more now. But I could find some clinical improvement in these cases. So curative effect I could not establish. But he has been using Hemagarba Pottali for a pretty long time in cancer cases. He along with Dr. Yaracharya, he tried to infiltrate Pottali powder directly to the esophageal cancer lesion through endoscopy because it can cause a local apoptosis, but it is highly risky because the lesion will be very fragile. There is always a possibility of bleeding. Internally, I can assure you that Hemagarba Pottali will be useful in the case of lung cancer and maybe in the case of leukemia. But in lung cancer, definitely it will be useful. It gained such a huge popularity during COVID pandemic. In many of social media, they had shared their experience of improving oxygen saturation within minutes after giving Hemagarba Pottali. And it is another wonderful drug in the case of cardiac emergencies also. So they are the cases where it is very well established. But in the case of cancer, the available data is very minimal. Kupipakwarasayana, all of these are supportive drugs. I use Makarathoja in lung cancer. I also use Samirapannagarasa in the case of cancer. Others like Mallasindura, Tamra Sindura, I have not used in this condition, however. Makarathoja is probably my common prescription in the case of lung cancer, along with other herbal drugs. Maybe Siprapaladishurana, maybe Laksuta Mishrana. Along with that, I use Makarathoja, which definitely enhances the therapeutic effect. Symptomatic improvement you can definitely observe. Hemoptysis or pain in the flanks, respiratory distress, cough, these symptoms get improved within 1 to 2 weeks. That is Lauha and Mandura are supportive. Dhatri Loha I have used in leukemia. Dose of 250 to 500 milligram with Madhu and Vrita in equal proportion. Punarnava Mandura, very good chemopreventive. An excellent drug when people is already on chemotherapy. And many of them are leaving chemotherapy in the middle because of poor compliance. That's the biggest problem that we are facing today. So this is the area where we can help a lot. I don't say that you ask them to stop chemotherapy and come to you. There are many cases where it is absolutely useful, but at the same time there are quite a few cases where it is absolutely dangerous. Quality of life and life expectancy is drastically reduced in several cases where we definitely know that chemotherapy is not going to help the patient. It is the responsibility of an oncologist to explain exactly that you can find many other options, which is not being done. I am very sorry to say this in this scenario. The situation in India is really very, very bad. Unlike where they primarily target at the benefit of the patient. If patient is helped, what is done? This is what I do, this is my limitation. They take the help of herbologists, they take the help of those who can explain meditation, they take the help of nutritionists, they take the help of several people, they make a group and they say that this is better, you can try this, you can go for this, they advise and patient get benefit. But that is not being done here, and many oncologists, they are so fiercely telling that if you go, you will die, I am not responsible. And if he delays or skips a chemotherapy course, the cursing of the oncologist patient dies. They are so afraid because I have Manipal center very close to me. They are so afraid in the situation there. We should give an assurance. Patients should feel happy. I have seen that even the terminal cases, for sure that they are going to die, at least they have a smile in their face at the fag end. That is the biggest contribution that you can do. There are many cases where chemotherapy is extremely useful. Maybe leukemia cases, certain types of non-Hodgkin's lymphoma. R-CHOP is very useful. But there are many cases where they know that immunotherapy is only experimental. Say that 2.5 lakh per injection. I don't know how many injections you have to take till you live. I know the people who have taken up to 32 injections. Spend almost a crore without any clinical benefit. If you say that without chemotherapy or without this therapy, life expectancy is 1.2 years, with this therapy 1.32. This is the research that is going on across the world. People should be compassionate. So then all this economical burden, unnecessary stress can be saved. So in this case, both these preparations have helped me a lot, apart from other drugs. Raudra Rasa is mentioned here. I am not sure that it is a Bhasma. It is difficult to say whether it is a Baddha Rasa, whether it is a Bhasma, because we have worked on this particular formulation. Somanathi Tamra Bhasma, that is a thesis work of Dr. Gopi. He worked on gastric cancer, and this is gastric ulcer, but this is found to be useful in the case of even respiratory cancers. Bhasma, highly accessible formulation. In North India, Bhasma is so popular. Maybe starting from Dr. Devendra Tiguna. So many people are using Bhasma. And till now, I'm sorry to say that I did not find such a miraculous response with Bhasma. There are a few formulations, proprietary formulations also available. I have not personally used Bhasma much. It has got some marginal. In vitro studies have showed that it has got some good effect, but clinically, it is one among some 25 drugs that they are combining and using. So we do not have a sufficient evidence to say that Bhasma is such a miraculous drug in management. That is why I mentioned this, that it is a supported drug in all the types of cancer. So most probably in lymphoma and leukemia it is helpful. Bhasma is not having any direct anti-cancer activity except Shatapati Bhasma, which has anti-cancer activity against prostate cell line, cancer cell line. Otherwise, it is an excellent antioxidant, wonderful drug, very good bioenhancer. You can use it with many of those formulations that you are using in your clinical practice as a supportive drug. Bhasma can do wonders. Giving Bhasma alone is practically extremely difficult considering the cost of the drug. Kalpas you can use. It is probably the best drug in the case of lymphoma, lung cancer and leukemias, various types of leukemias. Very good preventive also. Stomach cancer, one of the most difficult type of cancer to handle as per my clinical experience. Only you can improve the quality of life because most of the stomach cancers, they are diagnosed late. When the local tumor is highly advanced or already there is hepatic metastasis. In such cases, none of the systems can do. They may be doing a PEG here. Food is given through the back. Patient will have this suffering. Probably it can give some help. Bhasma is one of the Bhasmas that is tried. In uterine cancer, Vaikranta Bhasma, then Arbudahara Rasa in all the types of cancer. These are only two specific drugs mentioned in Arbuda, Raudra Rasa, Arbudahara Rasa. These are only two formulations mentioned specifically in Arbuda, which says cancer. Under the Arbuda Chikitsa Prakarana in Vaisheshya Ratnavali. Arbudahara Rasa is also mentioned in Rasaratna Samchaya. You please let me know if I am crossing the time. A few published scientific evidences very quickly on Bhasma. This is a published article just to show you that it is really useful. This is by Somen Das and others. Bhasma in cancer, a prospective clinical study. There are many in vitro studies. This is a clinical study where solid malignancies were considered. 43 patients were considered for the treatment. And out of them, 17 patients showed very good response, and best response was in rectal cancer. Around 41.02 patients survived for 1 year, and it is very good that 15.38% patients showed 5-year survival rate, which is considered as a standard. This is the response in various types of cancers. The entire article is available online. You can go through that because it is published in AYURVEDIC. It is an open access journal. This is another article by Daniel and others. Probably most of you have read this article because this had made huge news a couple of years ago because it is published in Nature, one of the topmost group of journals in the world. It states comparative study on cellular entry of incinerated ancient gold particles, this is Bhasma, and chemically synthesized gold particles, published in Nature Scientific Reports. This is just to confirm that Bhasma can absorb, Bhasma has bioavailability, Bhasma can enter the cells, it can be recovered even from the nucleus. That was very well established here. They studied this in HeLa cells. cervical cancer cell lines. And they compared the chemically synthesized or laboratory synthesized gold nanoparticles and gold nanoparticles that are present in Swarnabhasma. They compared them. Analysis showed that 60 nanometer was the particle size of majority of nanoparticles in Swarnabhasma. That is extremely good. You talk with your counterparts, they will say getting a nanoparticle of 500 nanometer itself is very difficult in laboratory. By our traditional method, we could achieve 60 nanometers. There are other reports which have given 57 nanometer sized particle in the case of Swarnabhasma. But many of them form aggregates. It is not that all nanoparticles are distributed. They form aggregates. Average size of aggregate was 4711.7 nanometer. Both the types of particles could enter the cell. The finest and the micro, both could enter the cell. That is interesting. He says, we found that their nuclear accumulation likely occurred after nuclear envelope breakdown during cell division. We also found that a larger IAUP, that is Swarnabhasma gold nanoparticles, entered the cells via macropinocytosis, whereas the smaller particles entered via cadherin-dependent receptor mediated endocytosis. There are two different mechanisms by which gold particles could enter the cancer cell. For smaller particle, it is the cadherin-dependent receptor mediated endocytosis. For larger particles, it was macropinocytosis. So in your physiology, you must have studied this macropinocytosis. Pinocytosis, you must have studied how it changes its shape and enters the cells. So it is very interesting because in Swarnabhasma, it is not that we are having only nanoparticles. There is a wrong belief among the Ayurvedic practitioners also that Bhasma is a nanoparticle. It is not like that. It may have only 10% nanoparticle many times, 5%, 20%. You have a huge amount, say 60% of organic material, some 20% of micro-sized, some 10-20% of nanoparticles. So you will have to understand that it is not just the nanoparticle, but even the larger sized particles also can enter the cells and show its action. Lauhabhasma and Tamarabhasma, they are comparatively evaluated in breast cancer cell line, MDA MB231, and both of them have showed good results, almost equivalent results. You can just Google, you can find the entire article compared to efficacy of Tamarabhasma and Lauhabhasma in breast cancer cell lines. Of course, I don't say that whatever is true in vitro study is true in human clinical trial also. Lots of patients, apoptosis can happen because of various reasons. You have to be very, very careful. In vivo is far better, which is definitely more expensive. You may have to go for nude mice to induce cancer in the mouse. In vitro, thousands of plants have been evaluated. A few of them only could show clinically benefit in cancer patients. But definitely this is a first step for us that gives an idea that they can have an advantage clinically. So these definitely have an advantage clinically. We have seen Tamarabhasma and Lauhabhasma act, and this is an evidence to support it. So this is another study, evaluation of alternate Ayurvedic Bhasma, Tamarabhasma, where copper is found to induce apoptosis in P12 cells. The mechanism was that it changed the mitochondrial permeability transition pathway. Reaction oxygen species was increased. P53, BAX, caspase 9, 7, caspase 3 were stimulated. They are all apoptotic genes, pro-apoptotic genes. And BCL2, which is an anti-apoptotic gene, is downregulated. Very clearly giving you the mechanism of action. How scientifically they have explained the mechanism of action of Tamarabhasma in cancer. Even Yashadabhasma is evaluated. If you see Granthapata, you may not find a direct reference in cancer. But the studies have shown two different samples were taken. One is Vanaspati Marika, another one is Parada Marika. We say that Sarvesham Rasavasmana is better, but here, however, it did not show much difference because this is a very small trial. You may have to go up to the in vivo and clinical trial to establish it. This study did not show much difference between two samples. However, it is interesting that in a very dreaded cancer, pancreatic cell line, MIA-PACA2, when adriamycin, a standard chemotherapy drug, was a control, this had shown very good anti-proliferative effect. Hirakabasma that I was talking about, in vitro trial, they called this as Ayurvedic nanodiamond particles, a fashionable term, so that everybody can read the article. Otherwise, it's very difficult to publish also in many of the occasions. Some of you might have experienced. The language that you use becomes very important. When you use certain terms, it will never be published. That's absolutely true. So whatever they said, we report a functional nanodiamond based traditional Ayurvedic herbal formulation, Hirakabasma. And they evaluate in solid tumors, Dalton cell lymphoma, CD1 mice. This is very good trial. It was an in vivo trial, where they found that it induces apoptosis aided by active participation of dendritic cells. It reduced tumor volume, it inhibited distant metastasis, increased the lifespan of tumor-varying animals, and it elevated protective cytokines, IFN gamma and tumor necrosing factor alpha, and it reduced TGF beta, which is responsible for angiogenesis. So combined action they could find. I'm not going for much details of this, but this study has at least indicated that in lymphoma, most probably Hirakabasma has got a very good candidature. Even Manikabasma is evaluated. Ratnanam Shodhanam Shreshtam Maranam Virguna Padam. It is not that you have to take only that Ratna for the preparation of Basma. Anyway, you try the sample and prepare the Basma. That is not the advertisement of Vaidhanath, just to show as a representative picture that there are only a few companies to prepare Manikya Basma. So this is a study of Manikya Basma. Again, they mention this as a nanoparticle, a nanomedicine. Manikya Basma, a nanomedicine to affect cancer cell viability. They found that crystalline structure of 70 nanometer could be established in HeLa cell line, that is cervical cancer cell line, MDA-MB231, that is breast cancer cell line, HCT116, DLT1, MG63. They found that IC50 is 105 to 155 microgram per ml. That's quite good. It's really very good. Many plants have been studied where IC50 is more than 700 or even 1 gram. So 50% of the cancer cells could be destroyed at a very, very small dose. That is something really appreciable in the case of Manikya Basma. Is there other details of this? This is purposefully displayed here because we always say that more the putta, better is the efficacy in the case of basmas. Especially in the context of abraka basma and loa basma, we are telling it. The shadistu shadantahasya, vyadinashana karmani, shadistu sasrantasya, all this you are telling. We say that Sastraputi is mainly for Rasayana purpose. And in all my lectures I state that Sastraputi how practically impossible it is to prepare. Because you have to go for Abrakashodhana, 1 day at least. Then you have to go for the preparation of Dhanya Abraka, 3 more days. Then you have to dry it. Then go for Bhavana, Charika Nirmana, dry it and a putta, 7 days. After every putta, if you leave Dhanya Prakarana and Shodhana at least 3 days. So 3 into 1000, 3000. So 12 years, we calculated it, minimum 12 years is required to prepare Sahasrapati Abraka Basma. So if you are getting Sahasrapati Abraka Basma today, they might have started manufacturing in 2010. Can any pharmaceutical company afford this? It's a question mark. So you leave that. We just think about Shatapati at least. They have compared 3 samples here, 20 putta, 50 putta and 100 putta Abraka Basma. That is very interesting. and they compared them whether there is any difference in their anti-cancer property. They used lung cancer cell line, leukemia cancer cell line, and prostate cancer cell line. In all these three, they could find good anti-cancerous effect in the same order of the putta. Best effect in Shatapati, next in 50 putta, next in 20 putta. Best result was observed in the case of prostate cancer cell line. So probably this is the area where we can try to use Shatapati Abrakavasma. It showed anti-proliferative activity. Probably the entire text is available online, you can search for it. Shilajatu. Shivagutika contains Shilajatu. Chandraprabha contains Shilajatu. We have several Shilajatu yogas, which is the most difficult drug to get. We are using Shilajatu in tons. Availability is maybe 1/10 of that. It is a highly adulterated material. All the Shastra people know this very well. Epuric acid, benzoic acid can be incorporated to make any petroleum product as Gomutra Gandhi Shilajatu, which is carcinogenic. Shilajatu is anti-cancerous. But very interestingly, nowadays there are certain companies who have come up with the purest Shilajatu to be sold, but at a fancy price. You cannot prescribe it for your patients. Maybe you can prescribe it as a rejuvenative for high-fire patients. So such companies are there. You will get entire detailed analysis report of 50 pages along with the sample, and they use silver containers. Silver spoon is provided in that. So that is the fashion today. Whatever it is, if you can get Shilajatu Shila, which is available, you can extract Shilajatu from that and you can use it for your clinical purpose. That is the way talk. But when you talk about Shilajatu, it has got humic acid. Mainly important content is a fulvic acid and other humic acids. Fulvic acid is probably the best known electrolyte for human beings, which has a composition very much similar to the electrolyte present in human beings. Fulvic acid is being sold as a nutraceutical supplement today. It is exported in the form of capsules. These fulvic acid and humic acid, they possess anti-inflammatory, antioxidant, anti-mutagenic, antitoxic, antiviral, heavy metal chelating, anti-tumor, apoptotic and photoprotective properties. That makes Shilajatu preparations very useful. A study has shown that apoptosis is induced via the production of reactive oxygen species, and it inhibited proliferation by inducing miRNA 22 and by inhibiting miRNA 21. miRNA 21 is anti-apoptotic, or it is pro-proliferating, it is inhibited. miRNA 22 is anti-proliferative, it is stimulated. So this is observed in Shilajatu. So it is sure that Shilajatu has got an anti-cancer property. So there is nothing wrong in using Shivagutika. So this is an article published from a university from America. And none of the Indians are involved in this, all those names difficult for me to read. So Chinese counterpart and Taiwanese counterpart are there. Two Chinese and Taiwanese scientists are involved in this study. The study was conducted in America. They used the term Mumi for Shilajatu. That is the word used in Taiwanese. They say Shilajatu as a potential chemotherapeutic for the urinary bladder cancer. This study has established that against T24 and 5637, two types of urinary bladder cancer cell line, this works wonders. They also studied it against a uroepithelial cell, normal uroepithelial cell. They found that it is not causing any destruction of normal uroepithelial cell, but it is causing harm to this bladder cancer cell line. So I am happy that in all those Shivagutika preparations which I tried in my cancer patients, whatever result I got is definitely supported by a scientific background. Even today, I have a patient who is a case of transitional cell carcinoma. Is taking treatment for last 2.5 years. You know, that is one of the very difficult cancers to treat. If there is a small mass, you can excise it. Definitely there will be recurrence. And we can try local radiation. If it is successful, fine. Chemotherapy doesn't help in urinary bladder cancer. Then they tell that remove urinary bladder throughout your life. Patient doesn't want to survive. So this is the situation in bladder cancer. If you can help to some extent, that is your greatest contribution. So in that particular patient who is coming from a place called as Kadaba, 150 kilometers from our place in Manipal, is totally asymptomatic now. However, the cancer lesion is still there. The size is reduced. So I hope that probably I can maintain patient for a pretty long time. So this is what the study goes further. Arsenicals in cancer management. We use arsenic maybe in the form of talabhasma, maybe in the form of rasamadikya, malla sindura, samirapannagarasa, or malla bhasma, where even oxide is generated along the sulfide, which is very, very potent drug. Malla bhasma you will have to give only for a short period. We found that it is more potent than rasamadikya in our in vitro and in vivo studies. However, this is first one is Haratala, second is Manashira, third one is Somala, here is Rasamadikya, Malla Sindura and Shila Sindura. Shila Sindura, and we found that it is useful in tropical eosinophilia, in all those allergic manifestations. In cancer, I have not used it. Malla Sindura is used as a supportive drug for symptomatic management in lung cancer when patient has got respiratory distress and low saturation of oxygen. Rasamadikya I have used in many patients, especially in ulcerated conditions. Any type of cancer, maybe squamous cell carcinoma having an ulcer, maybe infiltrating ductal carcinoma where the mass is fixed, already it is opened, very bad situation. We have tried this. And also in leukemia, in lymphoid leukemia, I use rasamadikya. I consider this as one of the very safe drugs to use clinically. But you should know how long it has to be used and with what it has to be given. If at all you are giving rasamadikya alone, always give it with madhukrita, which is a cytoprotective. Otherwise it can cause cumulative toxicity, which is very well established in a PhD study by Dr. Shimanarayan. Extensive toxicity studies carried out. Then, if you are not sure about the source of haratala, it is bound to cause oligomenorrhea because it can cause citrine toxicity if you give it for 3 months or beyond that. Better you stop it for at least 4 to 5 weeks so that whatever the cumulative effect of arsenic will be there gradually tapered down with the help of other metal chelators that you use, and you can reuse it. Otherwise, it never causes acute toxicity, it never causes allergic reaction. It is more immunosuppressive. It's not an immunostimulant, that is what we see. But many of the works that are carried out by modern scientists is on the last arsenic trioxide, the most dangerous, at the same time most effective drug in leukemia. There are many studies. This is a study on rasamadikya nanoparticles. Again, they use the term nanoparticles. Rasamadikya is ground and administered. That's all. So this is an in vitro study. And just to skip the details. Arsenic trioxide in leukemia. It was tried in adult T-cell leukemia successfully, even in resistant cases, chemo-resistant cases. There is another case, in the case of HPV positive cervical cancer, where it was found to be very effective. In esophageal carcinoma also it was tried. Realated nanoparticles, that is nothing but our Manashila. They have not called it as Manashila. The work was not done by Ayurvedic scholar. Realated nanoparticles, they tried in the case of mouse melanoma. I did not find excellent result in the case of malignant melanoma with metastasis. So we had at least 4 patients of malignant melanoma with distant metastasis. I don't think that in any system they are benefited. Only the treatment in malignant melanoma is excision. If you are able to excise the lesion completely, that is the truth. But if the lesion is in the foot, which is very common in the plantar aspect, if lesion is gone to the inguinal lymph nodes or intra-abdominally, it's great suffering, because I could see the patient who was on treatment for more than 3 years. Lesions, they start erupting on the entire limb, multiple spots, skin starts opening, oozing, ulcers. There will be suffering. So this is something interesting which I observed. So probably this may be one of the candidates which I can try next time when I get the case of melanoma. They also tried this in the case of cervical cancer. Arkeshwara rasa is evaluated in cancer. I just skip this. This was studied in pancreas and skin cancer. Raudra rasa. So due to the paucity of time, I am not going for the details. I will just mention you one aspect. Raudra rasa is probably the most effective formulation that I observed in the case of oropharyngeal cancer. The product was first evaluated by my senior, Dr. Bhavana Bhuth, from Chennai department in Jamnagar between 96 and 98 probably. She worked in association with the Oncology Institute at Rajkot. She carried out clinical study also. So later, so many people have worked on that. There are many people. My classmate Deep Singh Chawda worked on this, Lokhandwala, Ramesh Kumar, and in our institute, Dr. Gautaman worked. So we tried to develop a standard operating procedure. In the procedure, it is simply Kajjali. Kajjali given Bhavana of so many trees, Punarnamasvarta, etc., etc. And a Laguputta is given. Kajjali is so sensitive, you know this very well. Laguputta means which putta you have to consider. So we tried Bhudara putta, we tried Kapota putta, we tried Lavaka putta, we tried Bhudara yantra also. And finally, based on the pharmaceutical characters and analytical study, absence of and passing of Basma Parikshas except Nirutta Punarabhava. That cannot be applied because when you apply it, it will be dissociated. So based on that, we concluded that it is the Kapota putta which is most ideal, using 8 condoms, and preparing Raudarasa is most ideal. After observing our result in vitro study against human KV cell in oropharyngeal cancers and all previous studies, so we incorporated in this our own product also. We made a variant of our product, which we are still using in the case of oral cancer, which is very difficult to treat. Advanced oral cancer is very difficult to treat. If it is operable, fine. If radiation is possible, it is fine. But once it is advanced, once there is an infiltration, it is very, very difficult. Even if there is no distant metastasis, local infiltration itself is enough to make it very difficult to treat. This is a product which is being evaluated now in Yanapaya University from Prashasana department. He is carrying out one PhD work association with modern scientists, Dr. Sridhar Gokhale. This is his preliminary finding. With his courtesy, I am just because study is very preliminary. But I wanted to show you that IC50 level, you can see 25 microgram per ml. That means it has got a very huge future. So this is being continued. Hopefully in 2-3 years we will come out with very good data on Ardhudhara. This is also very difficult to prepare. Almost similar to Raudra Rasa. Unfortunately, Gandhaka is not there here. It's still difficult. Finally, one more preparation I wanted to mention, which is not from Ayurveda, but from Siddha system. Siddha people are using lots of rasa drugs, which many of you may be doing quite well. Rasanandi Meduku is a formulation which is available in the market. It's very potent, very effective in cancer management. There are a few practitioners in the border area of Kerala and Tamil Nadu. To quote Dr. Sushilama is one and such practitioner who is using Rasagandhi Melagu very successfully in clinical practice. So you will get all the details of its composition, etc. You can go through that. And this is a study that is carried out. I wanted to just show PD dose continuously. He says that should not take bath for these days. After a day's bath is given, then there's a day gap, then again you have to start this. These are the Patyapatya. I can't comment much on this because this is not my clinical experience, but I found that this is worth sharing because I know that there are many clinical success stories behind this particular product, which need to be further evaluated. I could find only one research article on Rasagandhi Melagu, that is how they call it in Tamil. This was in HPV positive cervical cancer, where they have successfully evaluated the product. Anyway, that is an in vitro study. Finally, a couple of my experiences. I'm not going for the details of this because this may take several hours. So Mahaushadha Kalpa is a treatment package or a treatment approach that was designed from our institute. We designed this in 2004-05. Now this is almost 20 years since then. And we have 2 US patents for this. One US patent for the entire treatment approach, another US patent for the basic drug that we use called Munex. So last year, 2021, we issued both these patents. That at least makes it a scientifically validated product. And these basics, sorry that I have to skip them. So these are the basic components of our therapeutic approach. We use a polyherbomineral product Munex, for which we received the patent. Hiranyaprash, that is gold nanoparticles divided in honey as a base. Mahaushadha granules, an antioxidant supplement, which we use as a chemopreventive and radioprotective. Ojo Kalpa, dietary advice, lifestyle management, dhyana and pyramid therapy. There are many such references where meditation miraculously cured cancer patients. You can find many such articles, published articles on Vipassana, which have helped. We have combined them for our patients. So that is why I am not able to give you a single particular formulation clinical details. Whatever my clinical experience is based on this entire therapeutic approach, rather than on a particular plasmas. And it is absolutely essential also. When a patient comes, you have to have a multidimensional approach. Whether it is detected by you in early stage, or whether he is already under some treatment, or he has finished surgery and came to you, he doesn't want to go for chemotherapy or radiation, or someone who has skipped because of very poor compliance. He says that if I take one more chemotherapy, I will die. It may be that type of patients. Or there are many cases where oncologists themselves said that we can't do much. You take some morphine or some supportive drug, or you can take others' help. All the types of patients. Accordingly, you will have to use multiple approaches. So this is a drug of multiple herbs and minerals. Entire details I can give you. So we carried out safety study. We carried out antioxidants profile. Safety study was conducted based on OECD 423 protocol. So beyond 5 gram per kg body weight did not cause any adverse effects. In dark cell lymphoma in vitro anti-tumor study we carried out. We evaluated this against 12 different cancer cell lines in vitro. We tried to observe what can be the mode of action because our center of interest was lung cancer. which is probably the biggest cancer killer in males in the world, having very poor prognosis. So we specifically evaluated against A549 human lung carcinoma. We wanted to see how it acts. We could find that it acts. Its effect on gene expression, DNA fragmentation, and apoptosis activity was studied. These are all published already. We have published articles on this. So details I will skip. So these are various cancers: HeLa, SKOV3, PANC1, HEPG2, AGS, U937, EB3, various cell lines which we successfully evaluated. So this is a basic drug. In almost all cancer patients we use this invariably. Then other drugs, depending upon the clinical presentation, depending upon the slokas involved, depending upon the lakshanas, depending upon the doshik involvement, other drugs, other associates or herbal drugs we do add. Then Hiranyaprash immunostimulant activity is established. In leukemia, we have result. Mahaushadha granules as an antioxidant supplement. I mentioned in the beginning itself, food is the main culprit. We cannot avoid it. We cannot grow vegetables always. All the vegetables, fruits, we cannot grow in our backyard adding any pesticides. And we believe that whatever organic that are supplied may be true. We have to use it. What we can do even in such situations, we have to give at least some supplements which can act as metal chelators, which can chelate pesticidal residue, which can have some free radical scavenging activities. So that was the idea with which we developed this Mahaushadha granules. It has got Haritra, it has got Kuda, it has got Mandukabarni, it has got Jiraka. Very basic ingredients it has, where every raw material is sourced and established, and we prepare it. And we use it probably in all those patients who are already on chemotherapy and who have found that it has an excellent immunomodulating effect. We know that the patient who is under chemotherapy, where there is an immunosuppression, WBC level has not reached to 4,000, chemotherapy is getting delayed. In all such patients, this has helped a lot. It has got a multi-dimensional approach. Ojokalpa is mainly for Panchakarma. In many of the patients, it is very difficult for us to apply Panchakarma therapy. Many patients are not suitable. Some of them are not ready to admit, except for Dhara-like procedures. However, in only a few patients where I tried, Basti helps a lot. It depends. You have to select the drug. For example, Rukkamayanthaka in the case of CA urinary bladder. Or Dashama Siddha Taila is used in the case of Viruhavasti Krama, in the case of renal cell carcinoma, and also in the case of suprarenal cancer. In around 6 or 7 cases, we got remarkable result. Apart from that, I don't have any data to share where Panchakarma was effectively combined in our therapeutic package. Dietary advice, this, just wanted to show this picture, the first one, which has become so popular for last few years. What is that? Lakshmana Phala. So Lakshmana Phala fruit doesn't have anti-cancer activity. Fruit is of course good antioxidant. It is a leaf of the tree that has got anti-cancer activity. The fruit is being sold at a fashionable price. The fruit costs 450 rupees. Maybe 5-6 years ago, nobody knew that it was just quite a product. 250 to 450 fruit, which is being bought by most of the cancer patients in our place. However, it is helpful and supportive, but it is not having a potential anti-cancer effect. Leaf, if you use, just a couple of leaves, just tear them, add a couple of cups of water, say around 400 ml of water, do Arthavashesha and administer, it definitely helps. In the case of brain tumor and colorectal carcinoma, it has helped. and a couple of articles published from United States of America also has supported it. Bark of the tree also has got some effect, but it may have slight toxicity because of certain contents. The leaf definitely can be used. And in this picture, there is cauliflower there, which I never recommend for my patients. So in all the articles we may find that cruciferous are very good. They are very good superfood, anti-cancerous, cabbage, cauliflower, all these. But that is the one which has maximum pesticide content. Except in Northeast, when I visited Sikkim, you may be knowing that it is a chemical-free country, where pesticide use is totally banned. It is the first state. It is the first state where pesticide is completely banned. Except that, I heard that there is some people near Nenamangala cultivate without using pesticide. I don't know. This has got a maximum amount of pesticide. Most dangerous genotoxic food. So I tell all my patients in our list, we say that avoid cauliflower. But text says you have to use it. Similarly, tomatoes. You say lycopene, very good antioxidant. Tomato can even imbibe lead from the environment toxic. Environmental pollution, even lead can be captured by tomato and it stores it, which can cause toxic effect. There are certain scientists who spend their entire life with the propagation against tomatoes. That's a different story. There are many studies on vegetables. Pyramid therapy, we have a pyramid in our institute. If at all you are interested, you can see it. This is made up of entirely wooden particle. There is a specific dimension with which it is prepared. There are many centers where pyramid therapy is carried out. There are many pyramids available. People keep here, people keep here. That is not the pyramid. The pyramid is constructed inside which a person has to sit and meditate. He has to concentrate on his breathing. A couple of works have been carried out from Manipal University. One from the Department of Physiology, which is published, Dr. Surekha, but you can Google, you can get the paper for her PhD. Another from Department of Medical Laboratory Technology. They worked on the effect of pyramid construction on stress parameters, on wound healing, on diabetes. It's very interesting that animal studies are also carried out. Animal cannot meditate. It is just placed, but that particular dimension has got an effect on the body. They found that a blade, sharp blade kept in the center of the pyramid can remain sharp for a longer period. A vegetable fruit that is kept in the center of the pyramid will remain for a longer period without getting spoiled. That is observed. But till now, the scientific basis could not be unraveled. This pyramid we place perpendicular to north-south direction, and we ask the patient to sit inside. Let them get relaxed and just concentrate on breathing. That's all. Don't have to do anything. Or if he is able to do meditate, he can do that. Best meditation is Anapanasati, literally in Buddhism. Just observe your own breathing. That is awareness of present tense. Awakening. Awakening of cellular intelligence. That is what Buddha speaks. Very simple. You just give the command to your cells. Your cells behave differently. That is what epigenetic factors also about. Ahara, vihara, how they affect epigenetic factors. Even meditation affects epigenetic factors. Because in a gene, we cannot modify the gene. There are certain areas which you can make not to be expressive. That can be done by autosuggestion, that can be done by ahara vihara. That is why we incorporated this. This is how the pyramid looks. This is a photograph probably of 2006. Sorry, yes, 2006, almost 16 years ago we have taken this. Sorry, I've taken only a few minutes. Because later, if the time permits, we will discuss. There are many cases. So we have around 738 cases till last year. This year's case I have not included. Probably we are having more than 800 patients now. It's a very small institute, it's not a very big institute. But we could have more than 700 cases. And out of these, we could find at least 80 different types of cancer. We name the type of cancer we have a patient. And when we see the prevalence, again, breast, oral cavity, pharynx, lung, bronchus, top of the list. Same as the general incidence. This is the statistics. And see, as I mentioned in the beginning, 45.5% of patients were diagnosed with metastasis. Almost 50% came with metastasis. So this is the list of different types of cancers where metastasis we could see. We focused on lung cancer, which was most challenging. And here, 60% patient responded to the clinical relief. Only 4% was 100% cured. 100% cured. Without the aid of any other intervention, complete remission and cure of the disease. And few of those patients are still there under follow-up. I have a patient who is under follow-up for the last 16 years. He's still coming. So his wish was, non-Hodgkin's lymphoma, his wish was to see that his sister is married. Then even if I don't know, his sister is married, he is married, he has children also. Absolutely symptom free. Now, of course, he is not coming very regularly, he comes once in 3 months or so. He takes some supplements and foods. Such cases we have, out of these, around 4% without having any other treatment. Means not as an add-on therapy, but as a single therapy based on Ayurveda. More than 50%. Here, I wanted to show only one very important observation. 31.25% was 5-year survival rate in lung cancer in our study. 31.25. So what the global picture states, as per Cancer Facts 2019 published by the American Cancer Society, 5-year relative survival rate of distant lung cancer is only 5%. This is the best contribution that we could give. More than 30%, 5 years of survival is what best we can give to the patient. We don't aim at cure always, it is not possible. The nature of disease itself is like that. To help patient in some manner. And these are the general statistics. Just a couple I will show. I wanted to show this because this was the first success story in 2005. I don't have detailed data of this patient. This woman, 27-year-old, came with an X-ray. She didn't have much of the systematic features. X-ray. Clinically, she was diagnosed as multinodal goiter. Then they went for biopsy. Mainly suspect a multinodal goiter, but here and there are papillary clusters. So there was an opinion that it is a papillary carcinoma. I don't say that it is 100% proved case. But there were biochemical features indicative of hypothyroidism. The TSH level going to 97.48. So I have the drug details here. We treated a patient for 6 months, where physically she was absolutely fine. TSH level came to 5.2. Then she disappeared. I was not sure what happened. I did not go for any follow-up tests. Only this much we did. Clinically she was fine. TSH was normal. After 12 years she reappeared for some other problem, for joint pain. Then I was happy that patient is surviving. She did not have any complication. So that was very initial stage, which gave us inspiration that we can go further in this direction. This is another story, just to show one colon cancer, adenocarcinoma of colon, post-operative case, came on 26 August 2010, that is 12 years. Pain in lower abdomen, irregular bowel habits were still there to the patient. He did not go for any other conventional therapy like chemotherapy. We started with this Munex 2 tablet twice a day. Co-specialty again our proprietary preparation. Arogyavardhani. Then a combination of Yashtimatu Churana, Amalaki, Mudantimasana. This was our first line of treatment. I have the details of CT scan, colonoscopy, then 2 markers. I am sure that Madam has already explained you. CEA, CDA 19.9, they are used for pancreas also, they are used for GIT cancers. Very good markers. They were all normal. Another case of adenocarcinoma of colon. This is the 3rd case. This is the 4th case. I'm sorry that I am skipping. Just a couple I will show you. CA breast I am not elaborating because I firm believe that surgery is a must. If you are telling that I will treat you, then once the mass fixes to the pectoralis, you are sending in. That is very bad. CA breast has to be treated with surgery. It may be lumpectomy. If tumor size is more, it may be radical mastectomy with the axillary clearance. If mass is fixed, then it is a different story. They do not go for surgery. They will try for initial chemotherapy, try to reduce the size, then say that it is yet fixed, they will give palliative. In such cases, you can try directly with Ayurveda, but in other cases, in many cases, post-operatively, we could treat effectively without chemotherapy, depending upon the stage of the disease. And Madam must have definitely explained about ERBR status, HER2 receptors, triple negative cases are considered to be very difficult to treat. We have to go for second line chemotherapy drugs, but we could treat them successfully without chemotherapy also. Because hormonal therapy did not help them, we are going for very strong chemotherapy drugs, and many patients they are so reluctant. So in our patients usually we advise a surgery and sometimes a radiotherapy, which definitely is useful if at all there is a locally disseminated cancer cell, and we can help the patient a lot. So my sincere advice in breast cancer is, please do not delay the surgery. That is why I have not highlighted, because there are many such cases post-operatively which we treated. Lung cancer, I just will mention one case out of so many cases. This was a patient. So now I have more than 30 patients from his family. His brother was a CA patient. His sister is a CA patient. His daughter-in-law was a CA patient. Unfortunately, she expired. We detected her cancer, we referred to chemotherapy. In between chemotherapy, she collapsed. He survives. He's young. He survives only without treatment. This is the first successful case without any modern intervention. His younger brother is surviving with surgery, without chemotherapy. His sister is surviving. She is also now 60 plus, with surgery, without chemotherapy. And we have many more, of course, not cancer patients. So all the story started probably somewhere in 2008. He was a diagnosed case of bronchogenic carcinoma with hemoptysis, dyspnea, general debility. He was a known case of type 2 diabetes. He also had undergone cardiac bypass surgery. And for 11 years he took treatment. Even after cure, he continued treatment. He took treatment for 11 years. Then he stopped. That means almost up to the COVID era. 2019 he came. Now he's elderly individual. So these were the symptoms. Even pleural effusion was there. Bronchoscopy confirmed adenocarcinoma. This was my first prescription. Munex 2 BD Munistami is our own product. A combination of Lagusutta Mishrana, which all SPM students know very well, developed there. But this is our product and slight different combination. Anyway, same three drugs, Sitopaladi Churna, Lagusutta, that is Shruti Vedika, and Shwasakundala. Makaradhvaja, Ashwagandha, Yashti. Pyramid therapy, Pranayama. So this, in Pranayama, we selected Avaloma Viloma, Surya Vedana, and Kapalabhati. This was how we. The entire details I have, every follow-up, what changes have happened, what drug we have added, we added Chandrakala in between, how symptoms changed. Entire story is here. It was in December where CT scan thorax showed no cancer, only emphysematous changes. Still we continued this particular treatment because we found one instance of hemoptysis. We continued Chandrakala for a short duration. Again we repeated chest X-ray in 2009, it was normal, except for one lymph node calcification over right scapular region. So this was the last prescription that we gave. Second drug is for his diabetes, not for cancer. So this was the lesion, bronchogenic carcinoma. The lesion disappeared in the case. This is a uterine cancer, 57-year-old lady from Pune. Due to her, I have many patients now from Maharashtra. She is coming even today, once in a while. She is using our medicines regularly, uninterrupted, for last more than 10 years. When she came, she was a diagnosed case of ovarian carcinoma. It was post-operative, post-chemotherapy, recurrence, hepatic metastasis, peritoneal deposits. She came with ascites, difficulty in breathing, so poor condition. We ourselves were not sure that whether she responds or not. Chemotherapy anyway she could not complete it because of non-compliance. Her physical condition was like that. There was tense ascites. So now probably it was when I explained this particular paper, 10 years. We are frequently getting a USC abdomen CA125 level, which is marker for ovarian carcinoma. So the prescription initially, Manex Kalchanara Gulu, Manili plus Kamaduga, Amala TST Gulu Sattva, with Godanti Vasma, Punarnavashtakatwata Shatavarexal. So this is various USC findings. CA19.9, CEA, CA125. So this is a case of cervical cancer detected in 2012. Still she is coming for follow-up. I'm not sure whether this is clearly visible. This report says that there are no lesions, only fibrosis is there. There is a case of fibrosarcoma, post-operative without any chemotherapy. Still he is having the tumor. Tumor is not completely resected. It was a very large tumor here, till the mid-thigh. He is surviving with that. He feels a bit difficult to walk. He has to stretch his limb. He has got lymphedema quite naturally. It's 14 years. Still he is doing his business. He is from Kalasa. He is a jeweler. This is the most successful case that we have non-Hodgkin's lymphoma. This was the patient I was talking about. For last 16 years he is coming. So this is his latest prescription. This was when I prepared this slide. He came 15 days ago also. This is another case of non-Hodgkin's lymphoma, but he was taking Gleevec. He was taking oral chemotherapy along with our medication. He is still under follow-up. So this is a Muslim guy who is currently in Dubai, who has already stopped the treatment. These are his specific reports. CML or chronic myeloid leukemia is very responding very well for our therapy. Acute lymphoid or myeloid leukemia has poorest response. I had seen small kids, 3-year-old, one girl and boy dying in front of our eyes. Because once crisis occurs, you cannot control by any method. Hemolysis, bleeding. And now I have one lady, 23-year-old lady, who is a case of acute myeloid leukemia. For last 3 months we are managing her. We are under palliative care like blood replacement, steroid therapy intermittently. And they tried bone marrow replacement, that also failed after 2 years. That case is surviving now for the time being. Otherwise all our success stories was chronic myeloid leukemia. Sorry for the poor contrast. So this was the prescription. I want to highlight only on the last Jayamangala Rasa. Jayamangala Rasa mentioned in Jeerna Jvaradhikara and Dhatugata Jvara. This is very useful in the case of leukemia associated with fever. Many times there will be intermittent fever, there will be very high fever. Patient, because my patient she was taking 6 tablets of paracetamol in a day. In such cases, Jayamangala Rasa works wonders. You take 1 tablet, 250 mg, powder it, mix it with honey, with a couple of drops of Ardraka Swarasa and lick it once a day. It definitely helps the patient. So this was used only when the patient had fever initially. Then we did not continue it. It is a good rasayana also. This was the story. Here we have VABCL genetic markers, RT-PCR. It was below the detectable limits. This is after 3 years. This is a case of chronic lymphocytic leukemia. All these are here. Pancreatic cancer I mentioned in the beginning. For about last 2.5 years we are maintaining him with only our drug. Only the problem that he has is an uncontrolled diabetes. He is an insulin dependent patient. Very simple drug, AYURVEDIC anti-diabetes. So these are showing you how the size changes have occurred during the course. This is the story of oral cancer. There is a big story. He had an opening here. Cheek was almost open. He completed surgery, he completed radiation, he completed chemotherapy and then came to us. His family members are all my patients. Now he has expired not because of cancer. He had cardiac issues and he expired. He stopped our treatment a couple of years ago. Last year he died. He even took nemotuzumab, which is an advanced chemotherapy drug. We didn't help him. Sorry, I could not incorporate the photographs of this patient. So from 2015 till 2020 or so we treated him. It took almost 1 year for us to heal his lesion completely. Along with me, Dr. Rajanish Giri was also there, who was handling the ulcer. This is his last PET CT. Sorry, I was a bit fast. I took your patience into challenge. Let me conclude. We have a lot to offer in cancer. Follow a scientific, holistic approach. Don't become blind on the other side of the system. It is you who are responsible for a patient. Never feel lack of confidence because you can contribute substantially. We say that modern oncology has got several drawbacks. Many times it looks that patient is getting so much trouble with the therapy, but definitely we have lots of advantages in modern oncology. Maybe surgical oncology, and in some places maybe guided radiation, and in a very few cases maybe chemotherapy. Assure the patient, but never give false assurance or tall claims, which is occurring. Maybe the folklore practitioners, you go there, he gives something, it cures. I know many such patients who went there and came to us. I have samples of those roots and barks with me. It is not you don't be blind. It is not that you don't go, but you do not deviate from a scientific path. Assessment should be there properly. You take help of such treatments. Many people they say, 6 महीने में मैं ठीक कर दूंगा, ये खाओ ठीक हो जाएगा, वो कभी ठीक नहीं हुआ. There are many such cases. You are playing with the people. Please do not do that. You give a helping hand, patient will remember you. I have seen many patients dying. Their family members are happy. They tell that you have helped them, and his end was peaceful. And that is the most joyous moment for us. With this, let me conclude. Thanks for the opportunity. Thanks for your patient listening. At the end, we are not victims of our genes. We are masters of our genetics. Remember this. Genes will hear what we say. So do not forget ahara, vihara, dhyana.
Thank you, sir. If you have any queries, please write it in the chits. Chits will be provided later and it will be discussed during the panel session. Okay. Now it's time for lunch. It is for half an hour. Then after that, come back. Oral scientific sessions are going to start.